since 6 months. On retrospective history, there is no history of neck swelling, abdominal pain, recurrent fractures, kidney stones, galactoria, or mood swings. He is on antihypertensive drugs since 1 year, and he had a permacath insertion for dialysis October 2019. And no other significant family history or personal history. On general examination, also no significant finding. There is no bony swellings noted. Examination of neck was also insignificant. There was a permacatheter in situ, no neck mass or no cervical lymph node palpable. Investigations, there was a raised IPTH, and calcium was more like in the normal limits or lower calcium levels, and increased alkaline phosphatase levels, and creatine levels were also increased due to renal failure. When the ultrasound neck, there is a well-defined heterogeneous hypoechoic oval lesion of 2.2 cross 1.4 cross 0.6 centimeter, seen in relation to upper mid portion of right lobe of thyroid, likely to be right parathyroid hyperplasia, adenoma, and bilateral thyroid lobe appeared normal. No other significant findings in the ultrasound. And BMD, there is significant osteopenia in the left forearm. In MEB scan, it was a suggestive of right superior parathyroid adenoma posterior to upper pole of right thyroid lobe. These are the films suggestive of right-sided lesion. Provisional diagnosis of secondary hyperparathyroidism was weighed, and the plan was to proceed with bilateral neck exploration, frozen section biopsy, IOPTH monitoring, and IONO. We performed a bilateral neck exploration and total thyroidectomy with frozen section biopsy, auto transplantation in the ipsilateral pectoralis major, and IOPTH. The findings were large glands were found from the right side. Right superior parathyroid and right inferior parathyroid were respectively 2.45 cross 1.5 cross 1 centimeter and 3.9 grams, and 2.5 cross 1.5 cross 1 centimeter 100 milligram. Left-sided glands were less in size compared to right side. And all parathyroids were sent for frozen section biopsy, identified as parathyroid tissue, except left inferior, and bilateral recurrent laryngeal nerves were preserved during the procedure. And IOPTH values were, there was a significant drop, more than 50% fall, as seen in the slide. And coming to histopathologic examination, a superior parathyroid and left inferior parathyroid were suggestive of parathyroid hyperplasia. In the postoperative course, patient had undergone periodic dialysis postoperatively, and biochemical hypocalcemia correction done with IV and oral calcium and vitamin D supplementation during postoperative period. And patient is currently normocalcemic with oral calcium supplementations, and patient is a prospective renal transplant. Patient is to undergo renal transplantation and is on evaluation for the same.
Thank you, Dr. Shalik. Uh, any questions to Dr. Shalik?
Dr. Salik,
Yes.
I think it was a good presentation. I just need a clarification from Dr. P.K. Pradhan that why some glands were picked up by maybe and other gland was not picked up. That was one gland was picked up. I think right upper one was picked up. The left lower was not picked up. For those, both the glands were almost of equal size. Any comment for Professor Pradhan?
Hello, good morning. I think it's a very nice. Can you show the slide of the weight and the size? Then only I can answer you. Because that depends upon the basically sometimes weight. But 100 milligram is quite low. Gamma camera may not pick up. Normally they say it is around 250 milligram. But nevertheless, sometimes if the uptake is too high, it is 9 times rather than the normal cell, the maybe is uptake into the mitochondria. 9 times, not 1, 2 times to the normal cells, parathyroid cells. So obviously it should pick up. This is 3.9 gram, right side parathyroid adenoma. 100 milligram, it is unlikely to pick up. RIPG and 1.2 grams, and another is 10.4 gram.
800 milligram.
Central compartment, that is 800 milligram. Okay. So this 1.2 gram and the other one is 3.9 gram. These two would have been picked up. Can you describe? This is right superior parathyroid adenoma. It is 3.9 gram. And which one is picked up in the maybe?
So scans findings will suggest you of right superior parathyroid adenoma, posterior to upper pole of biparad lobe.
And go back to your slide. Yeah. Right superior parathyroid adenoma. It is 4 grams. So it has been picked up. What Dr. Mahanti is asking, why other glands are not picked up? Another gland is there which is 800 milligram. One is 1.2 gram. 1.2 grams should have been, but the other part is anything which is hyper functioning, that will picked up fast. Sometimes in hyperplasia you see double adenoma, but to our thought process, this is the only adenoma which is picked up, 3.9 gram, and the other 100 milligram it is unlikely to pick up. The 800 milligram it should have been picked up, but it depends upon the function. It is not necessarily the size, it is our weight, it is also the function and the resolution of the gamma camera. This is multifactorial. That is the major reason for a distinction. But when the question of hyperplasia, this is a secondary hyperparathyroidism and a parathyroid adenoma you want to distinguish. Normally in hyperplasia you will see multiple uptake. Out of 4, you might see 2. Then we say either it is a double adenoma or it is a hyperplastic. Okay, but nevertheless it is very difficult to distinguish. But normally the conceptual is, if you, how do you know, Dr. Mohanty, now I will ask you very clearly, or the resident, that it is a hyperplastic or adenomatous preoperatively? Then only the
Secondary is more associated with
secondary is more associated with
hyperplasia.
hyperplasia. So that's why you thought preoperatively, okay, this is secondary, so it will be hyperplasia. But to our mind, if it is a hyper functioning one only picked up and which has more weight, it is picked up, and that's the reason.
Yes, sir.
Is it okay or something else? Dr. Mahanti is looking forward to me.
No, just try because I wanted to know because that can more than one gland be picked off in a patient with
Yeah,
hyperplastic?
it can be picked up. It can be picked up.
Yeah, yeah, yeah.
I think the resolution, can I speak?
Yeah, yeah, please go ahead.
The resolution you can improve with a definitely PET scan. But the PET scan has to be very specific, either with 18F fluorocholine or if you with a carbon 11 methionine. These are the two agents. Other agents are also there, like fluorinated amino acids. But these are the two most common agents which is now in the vogue, mostly 18F fluorocholine. And that's the reason your pickup rate will definitely increase by around 10%. So if you find 2, 3, obviously you can say easily that this is a hyperplasia. Okay.
Vivek sir, sir, can I ask you two questions? Can I involve you in this debate, sir? Sir, am I audible, sir? Vivek Agarwal, sir?
Hello.
Hello?
Hello.
Vivek sir, can I involve you in this discussion, sir? I just wanted to ask you two questions, sir.
Yeah. Yeah. Please carry on.
One is since in secondary hyperparathyroidism we end up exploring all four glands. Is there any indication preoperatively to get a functional imaging? That is one question. And second question is which is better to do a total parathyroidectomy and autotransplantation in the arm or subtotal parathyroidectomy? And the timing of surgery, whether it should be done before transplant or after transplant.
Okay. As far as your first question is concerned, hello. Am I audible?
Yes, sir. We can hear you, sir.
Okay. So as far as your first question is concerned, whether to do pre-operative imaging or not, well, in this case, like we have CKD, we know it's a secondary involvement. So practically all glands have to be seen. Uh, but sometimes mediastinal or ectopic parathyroids, you cannot, really during the exploration also you'll be missing them. So if you have an imaging facility comfortably at your place, no point, not doing it. It can definitely add on to some information. If you don't have, you can even get away with that. Second question is whether to do total parathyroidectomy and autoimplantation or 3.5 kind of subtotal kind of parathyroidectomy. Well, in this situation, I would say you have to see the condition of the patient, the longevity, your own results of autoimplantation, whether you are able to, your implants are picking up well or not, and intraoperatively, whether the glands which are involved, if all of them are very large, probably it is difficult to leave a right sized gland behind. So it is always a good idea to auto implant. But if you think most of the glands are not that big and one of them is almost near normal, maybe doing a 3.5 or a 3 gland parathyroidectomy is a better idea. Of course, you have to look into the longevity, expected survival of the patient also. Sometimes your intraoperative manipulation, if you think you are not able to preserve the half gland properly, then you be ready for a auto implantation. You have to preserve all the glands as and when you remove them, so that in case you think that you are not able to preserve the half gland or the one gland properly and it is compromised, better to remove that and auto implant. So these are more practical tips rather than looking at the data as a whole, how one should individualize his own treatment. And of course, sometimes we take into consideration the turmoil the patient will face if we remove all the glands. Managing the hypocalcemia post-operatively sometimes is easy with 3.5 or 3 gland removal, because if we remove all four, then it takes time for the implants to function. And if you think your patient is sick, especially these CKD patients, they may be very sick, and if your facilities cannot support these kind of turmoils, then again you may resort to um, uh, lesser three subtotal kind of procedure. So these are just my personal experiences I'm sharing. Uh, Data, of course, and what should be the ideal can be looked into the literature. But this is how I would make my decisions, considering all these points together. So I think that's what I want to contribute. Anything else you want to know, please discuss. Hello, was I clear in my points? Hello.
Thank you, sir. Thank you very much, sir.
Good morning. This is Dr. Anish here from CMC Vellore.
Yes, sir.
I just had one question. What is the duration of secondary hyperparathyroidism for this patient prior to surgery?
Dr. Shali.
6 months.
6 months. Okay. So, what is your general indication for surgery in secondary hyperparathyroidism?
There is a high PTH level, and it can calcium phosphorus ratio also.
What is your institution's? I mean, do you do parathyroid surgery for all patients with secondary hyperparathyroidism, or is there a subset in whom that you would do?
Sir, can I answer this question? This is Dr.
Sure.
Ramya from LGPGI.
Sure, please. Yeah.
Sir, at our institute, we operate on selective secondary hyperpara patients. Usually, if there is failed adequate medical management, which is giving active vitamin D and adequate dosage of senacalcet, and with high levels of PTH, if they are not responding for at least a duration of 3 months in a complaint patient, that would be one reason. The other reason would be if there is severe intractable life quality of life limiting kind of bone aches or muscle aches, or if there are complications like calciphylaxis. These I would say are some of the indications. We don't operate upon all patients of SHPT.
Okay. And what was the indication for this patient?
Shalik.
This patient is waiting for renal transplant.
Okay. Yeah. So that is also another, I think, issue, especially in the West, where the physician may not accept for a transplant unless the hyperparathyroidism is sorted out. So, like Ramya pointed out, there are certain indications for surgery in secondary hyperparathyroidism. Not all patients require it, and I think the protocols as to when to operate would differ between institutions. For example, in CMC, we have a very high threshold for operating patients with secondary hyperparathyroidism. We hardly do that. One reason is because they develop a very severe hypocalcemia following surgery, which is very difficult to manage. Yes. So we usually look at the severity of bone disease, and if it is a severe bone disease, then we would offer. Regarding the extent of surgery, like Vivek had pointed out, we would assess all 4 glands. So it is a 4-gland exploration. And if there is one gland that is almost normal in size, we would do a 3-gland parathyroidectomy. If all 4 were enlarged, then it would be a 3.5. We don't go for we've almost stopped doing a 4-gland with autotransplantation.
Yes.
Thanks.
Thank you.
Thank you, sir. Our next presenter is Dr. Ramya. She is a third-year senior resident in endocrine surgery, SGPGI. Ramya, ma'am, please share your screen.
Are you able to see, Vikram?
Yeah, we can see you.
A very good morning, respected faculty and my colleagues. I'll be presenting a case of parathyroid carcinoma, which we title it as stubborn tumor and relentless surgeon. This is the saga of a young lady which has been there for almost 25 years, and I'll make the long story short. I'm sure most of the alumni of SDPJ are aware of this patient and have managed her at some point of time. So the beginning of her story has been aptly titled by our seniors as a parathyroid cripple and syndrome of disappearing bones. In 1996, she had come, she was a young lady in her 20s from a very poor socioeconomic background from a district, Devariya in Uttar Pradesh. When she had come, she was bedridden with a crippling disease of long bone fractures, loss of height, palpable neck mass, and with severe bone and muscle aches. And on examination, she had multiple brown tumors and limb deformities, and she was severely anemic. And briefly presenting her biochemical values, at that time, her serum calcium was 13.6 milligram per deciliter, and with very high value of intact parathormone, which was 1800 picogram per ml. And her ultrasound neck at that time revealed a 4-centimeter nodule, which was posterior inferior to the right thyroid lobe. And the impression given on sonography was a probable thyroid nodule or a parathyroid tumor. And at that time, SESTA-BB was not available at our institute. A technetium thallium subtraction CT scan was done that showed a right inferior parathyroid tumor, and an FNEC was performed at that time, which showed a parathyroid lesion. As we can see in this X-ray, there was extreme osteoporosis, and there were fractures which I think they're not probably appreciable in this X-ray, but she had extreme osteoporosis. And she underwent en bloc excision of right inferior parathyroid tumor along with the right lobe of the thyroid and resection of the adherent strap muscles along with surrounding fibrofatty tissue. The histology revealed parathyroid carcinoma with capsular and vascular invasion, which are definitive, which indicate that it is a carcinoma and it was invading into the right lobe of the thyroid. Post-operatively, her serum calcium and intact parathormone came down to normal limits, and her symptoms remarkably improved. And she was asymptomatic and biochemically normal for over 5 years. And unfortunately, despite adequate counseling, she lost to follow-up in this meanwhile. And in 2001, she had come with a history of a nodule in the neck, which she noticed for 2 months. And on examination, it was in the plane of the strap muscles. It was not deep. It was in the subcutaneous or rather strap muscle plane. And the ultrasound neck also showed that it was not a deep one, which was only a subcutaneous nodule. And her serum calcium, IPTH at this time, however, were normal. Her MIB scan was done at this time, which was normal, and the surgery performed was excision of this nodule alone. And the histopathology showed that there were nests of tumor cells infiltrating the strap muscles and was suggestive of recurrence. Again, after the surgery, she lost to follow-up because she was unmarried and dependent on her family brother. So she was also having financial limitations. This we assume the reason why she keeps not coming for follow-up. Her saga continues. And in 2008, she had come with severe bone pains with biochemical increased calcium and mild increase in PTH. At this time, her CECT neck was performed and it showed a 2-centimeter nodule involving upper 2 tracheal rings in the posterolateral aspect with no breach of mucosa. And we performed excision along with the shaving of this local recurrence from the trachea since there was no infiltration, along with right ipsilateral central compartment lymph node dissection. And postoperatively, however, this lymph nodes did not show any involvement of the tumor, and the tumor was completely excised. And postoperatively, she again became biochemically normal. And in 2014, she presented again with weight loss, dehydration, nausea, and abdominal pain. And this time, she had a hypercalcemic crisis with a calcium near 15 milligram per deciliter and much higher IPTH. And the MIB scan showed increased uptake in the right paratracheal region with multiple tumors and excision of this recurrence with window resection of the trachea and closure followed by tracheostomy was performed. And post-operatively, she recovered. And in 2018, she had come with history of hemoptysis, multiple brown tumors, generalized weakness, and loss of weight. On examination, there was severe anemia again, and there was no palpable neck mass. This time her calcium was around 17 milligram per deciliter, and intact parathormone levels were 1750 picogram per ml. And CECT neck showed local recurrence, as we can see in this picture, local recurrence in the right paratracheal region, extending retrotracheally with intratracheal extension. However, maybe this time did not show any focus of increased uptake. All we could see were some brown tumors. There was no uptake in the neck. And the procedure performed was excision of this local recurrence along with resection of the upper two tracheal rings. And a part of the esophageal was also, a wall was also excised because it was seen to be adherent to the esophagus. Since there was no upper tracheal ring for anastomosis, we performed cricotracheal anastomosis and esophageal wall primary repair. And post-operatively, there was transient fall in the calcium, but there was again progressive increase in serum calcium this time. As we can see in the right bottom corner of the screen, this is the resected specimen. This is the trachea. This is the tumor, and this is the intratracheal part of the tumor. So this is the photomicrograph of the same tumor, which we have excised in 2018. This shows that there are multiple nodules of parathyroid cells with thick fibrous bands, which are characteristic of usually seen, though not pathognomonic, of parathyroid carcinoma. As we can see in this picture, photomicrograph, this is the hyaline cartilage, and this is the area towards the respiratory epithelium. As we can see, the tumor is inside the trachea. So this is the part of the tumor which was inside the trachea. And in less than a year, she came with progressive dysphagia, and her biochemical investigations again showed severe hypocalcemia, and the imaging showed now recurrence in the left paratracheal region with retrotracheal extension and the deviation of trachea to the right. But this time there was no intraluminal extension. Operative find, we have contemplated surgery upon her. I remember this intubation was very difficult, and it took almost 3 senior anesthetists to secure a tube for surgery. Intraoperatively, the hard mass was, it was fibrosed, plastered between the esophagus and criciotracheal anastomosis region. It was infiltrating the left thyroid lobe and entrapping the left recurrent pharyngeal nerve. We have performed the resection of recurrence along with left hemithyroidectomy, and esophageal mucosa was injured at this time, and it was repaired, and left recurrent laryngeal nerve was sacrificed, leaving behind minimal residual lesion, and radiopic clips were placed for probable radiation in the post-operative period. And post-operatively, there was improvement in dysphagia. However, her calcium persisted to be high. Currently, patient is on medical therapy, which is she's able to tolerate cinacalcet only 60 milligram per day, which is 30 milligrams twice a day. And as and when the calcium rises above 12 or 13, we give her usually monthly once in bisphosphonates in the form of zoledronic acid. And she keeps having fluctuating calcium levels. However, she's able to tolerate semi-solids orally. And her methionine PET CT done in 2019 had showed residual mass in the neck with a lytic lesion in the skull. But however, repeat imaging is not possible because of financial constraints. And the interesting discussion points in this case would be, what are the options for management of local disease at this point of time? And what are the ideal or recommended imaging to detect metastasis, and which probably can differentiate the metastasis from round tumors? And what is the role of adjuvant therapy to control local disease in the form of radiation? And what are the other medical management options that we have? Maybe monoclonal antibodies and such molecules, and any newer targeted therapy. Before I open the case for discussion, just few points about literature that regarding parathyroid carcinoma. It's very rare, and it's difficult to distinguish parathyroid carcinoma from other malignant neck lesions. FNAC is contraindicated from any parathyroid lesion, as the cells tend to grow along the tract side. And both diagnosis, even histopathological diagnosis and management of the parathyroid carcinoma are unclear because of its rarity, and only high index of suspicion by the operating team, an endocrinologist is the only way, and surgery is the only definitive treatment. Despite complete resection at primary surgery, in many cases, recurrence is the rule than a chance, and it's just a matter of time. Mortality in this pathology is mostly due to hypercalcemia rather than the local disease, and control of hypercalcemia also needs surgical excision. It's not easy all the time. Local recurrences can be managed safely and effectively with reoperation after initial medical control. And when there is metastasis, medical management most of the times is the only option available, and surgery would still be required to manage local compression. And chemotherapy is not useful, and the literature says that radiation has not been very helpful. So in this case, we have learned that parathyroid carcinoma has an intractable course with tendency to recur. Close follow-up is necessary to detect early recurrence, and reoperation with tumor-free margins provide the best chance to control the invasion into the upper airway. Thank you.
Thank you, ma'am. It was a nice presentation. Ma'am, we have two questions from the audience for you. They need some clarification.
Okay.
Ramya, ma'am, can you hear me?
Yeah, I can hear you, Vikram. I'm trying to see the.
Yes, ma'am. I think there are three questions for you. HRPT2 genetic testing is done routinely. I would also
No.
invite comments from other faculty for this. So the second question is, I think you can answer. Was there any adjuvant treatment considered for her before
Yes, ma'am.
second and third surgery?
Actually, radiation was considered at many points of time, especially in 2018. But one problem was her finances. The second problem was patient was having cricotracheal anastomosis, and if there would be a stenosis, then it's going to be a bigger problem than because at that time we thought that we have done surgical resection, and even literature doesn't show doesn't prove radiation to be effective in parathyroid carcinoma. So we did give it a thought. I remember Dr. S.K. Sahu from endocrinology has also suggested the same, and we all took a combined decision, discussed with the patient, and we did not, however, pursue radiation after discussion with radiation oncologists. And there's another question from.
Yeah, was there any genetic testing? Was it contemplated any time for this patient?
No, sir. We did not contemplate genetic testing in this patient for any somatic mutations. We did not.
Ma'am, I would like to ask, before you did a tracheal resection, did you do any imaging to rule out distant metastasis?
Actually, Vikram, we at that time we had performed only maybe. I would say system EB sometimes may pick up distant metastasis, but however, PET CT at that point of time in 2018 was not done. Actually, you would also know that this patient had such severe financial constraints all the time. So treatment, we always fell short for that ideal investigation.
Okay, thank you, ma'am. Anisa,
Rabi, I have a question.
Yes, sir.
Yes,
It
sir.
is actually a very good presentation, and I must congratulate the team for their management. I mean,
Thank
it is
you,
a very
sir.
difficult situation, but it's always good to learn from the long story. So, looking back, would you have done anything differently?
Yes, sir. Actually, from starting from beginning in 1996, we would have probably avoided an FNAC.
Yeah. Okay.
Because it did not add any information for our management, and we would have stressed upon the patient for early follow-ups. I mean, I'm sure it was stressed even then, and
Yes.
had she come very close for close follow-up, then we could detect the disease at much operable or rather at earlier disease stage that is easy amenable for surgery. And
Yes.
but however, despite all this, we are all aware that the pathology is such that the parathyroid carcinoma tends to recur despite adequate surgery in almost 60 to 50 to 55 to 65% of the patients.
Yes, like you mentioned, yeah, I agree with you. I mean, it was 1996 for the first presentation, so there must have been some decision as to why FNAC was done, definitely at that time. But as we know now, there is always a chance for needle tracking when you do an FNAC.
Yes,
so that is one point. Second is, as you mentioned, yeah, the follow-up duration should be shorter, but
As we know, our patient population is such that it is difficult at times. And as you discussed earlier, the role of radiation, though in literature it is said to be a radio-resistant tumor, we do offer radiation for patients with parathyroid carcinoma that we have operated at CMC, but yes, it is debatable whether to offer it or not. The only other point was whether to consider a tracheal resection, segmental resection at an earlier point. So, I mean, that also is a decision that has to be taken, when the patient presents. So maybe looking back, maybe that may have, like you said, it is not a cure that you're aiming for. It is just to delay the point of recurrence. And that's how you probably would manage these patients.
Yes, sir. Actually, we followed a rather approach that initially shaving was done. At that time, it was clearly not infiltrating the trachea. Then we performed window resection. I mean, the best minimum possible that was the aim at each surgery.
Sure.
Sir, Ani sir, can I ask you one?
Sure. Yes.
Sir, in these parathyroid carcinoma patients, should we routinely do any kind of genetic analysis?
So that is an area of debate, but I think we don't have any targeted drugs for parathyroid carcinoma. The aim for the management would be to delay the time of when the recurrence happens. 1, 2 would be to manage the local compressive symptoms as well as to manage the hypercalcemia. So that is probably the aim. And the experience is limited because of the limited cases that our series is that each institution has.
Vikram, can I ask a question to Pradhan sir?
Okay, Ramya.
Sir, which is the recommended imaging to detect metastasis in case of parathyroid carcinoma?
If you don't have anything, I think if you parathyroid carcinoma, you should do FDG PET. Okay.
Yes, sir.
But doing both will be always wiser if you have carbon 11 methionine or 18F fluorocholine along with FDG PET. So that at least but if you have suppose limited money and you want only one investigation to really pick up,
yes, sir.
and you know that it is parathyroid carcinoma and it is recurring again and again,
yes,
I
sir.
think the FDG PET will be the best answer, probably to my mind. Okay.
Yes, sir. So does maybe uptake change with the de-differentiation of the parathyroid?
Obviously it will change. Obviously, you don't expect that amount of parathyroid cells there and
Yes.
with that kind of mitochondrial uptake. So obviously it is expected that it will not really have pickup. The only thing what you ask is, I saw your discussion point.
Yes, sir.
Anything else you want to me for the imaging, recommended imaging to detect metastasis, or is okay what I answered?
Yes, sir. Actually, even when I was reading through for this case, found the same thing that it's better to do two together, and many have suggested to perform in PET CT rather than FDG PET.
One is for localization, another is for prognostication also. Okay.
Yes, sir.
So that is the basic message for choosing a imaging.
Yes.
And next is role of adjuvant therapy to control the local disease. To my mind, these parathyroid cells, basically the normal parathyroid cells are also radio resistant, for your information. One. Okay.
Sir.
And like I'll give you an example. Many patients sometimes say, sir, following radioiodine therapy for benign disorders or malignant disorders, sir, we have hypocalcemia. Never. I have yet to see in the last 20, 30 years, at least since 90 I'm practicing,
Yes,
I have
sir.
yet to see a case with radiation, either internal radiotherapy or external radiotherapy. The parathyroid cells are so resistant that the radiotherapy will not control the local disease, to my mind. Okay.
Yes, sir.
Somewhere anecdotal case is there, might be there in the publications, but I am not aware. The fourth is medical management options. I think suppose somebody has to really think and seriously, if you are like Dr. Anish told that the options has to be through some kind of medical management only. And coming to the newer modalities and targeted therapy, it is not in the vogue now, but I think somebody has to work on, because actually the prevalence is so low, sometimes we leave our effort. But it is nevertheless, somebody should means concentrate. I think always it will be more wiser, and hope in the long run one can contribute.
Thank you, sir.
Thank you, sir. Before we move on to the next presentation, Dr. Mishra sir has an announcement to make.
I just request all the people who are interacting to put their video on. I think that will give a different perception altogether, actually. So that will make as if we are just interacting face to face. We are already working in a very unusual kind of situations, keeping all of us away. So so it will definitely give a different feeling if you put our video on. At least people who are interacting. That's all I wanted to request all of you. Thank you. Go ahead.
Thank you, sir. Our next presenter is my colleague, Dr. Vishwak, second year senior resident, MCH endocrine surgery from SGPGI. Vishwak sir, could you please share your screen?
Am I audible, Vikram?
Yes, sir, you're audible. Yes, sir, you're audible. Please go ahead and share your screen. Dr. Vishwa?
Presentation.
Yes, sir, we can see your screen.
Good morning, everyone. Can you hear me, Vikram?
Yes, sir, please go ahead.
Visible?
Yeah, we can see your slides. We can hear you.
Good morning, faculties and my dear. Good morning, faculties and my dear friends.
Yes, sir, go ahead.
Starting with my case of 8-year-aged gentleman who's a hypertensive for 30 years and diabetic since 20 years. He has been here with a history of increased frequency of micturition and nocturia since 1 month. And no history of dysuria or hematuria, no history of frequent urinary tract infection.
Dr. Vishwak?
Yeah, I think
There's some problem with the audio, sir.
yeah. Thing is my
So if there's a problem, we can connect with you
Vikram,
later on.
can you hear me, Vikram?
Yeah, we can hear you. Yes, sir.
So here is a 68-year gentleman with a known hypertensive and diabetic who has been here with a history of increased frequency of micturition and nocturia since 1 month. And there's no history of dysuria, hematuria, and there's no history of frequent urinary tract infection and no abdominal pain. He gives a history of generalized weakness, and He has a recurrent renal colic since 1982 and a procedure of left open nephrolithotomy in 1982 he had. So for his evaluation of lower urinary tract symptoms, he underwent an ultrasound abdomen and found to have a right suprarenal incidentaloma and hence been referred here for further evaluation. So on retrospective history, he is a hypertensive since 30 years with controlled blood pressure on 3 medications. No paroxysms of headache, palpitation, or excessive sweating. There's no symptoms suggestive of Cushing's or hyperaldosteronism, and no history of bone pain, or no fragility fractures, no mood swings, and no history of acid peptic disease, and no history of neck surgery. Uh, his father expired of coronary artery disease at 81 years, and mother succumbed to a natural cause of death at 91. And he has uh, three siblings. Of the one sibling is hypertensive, and he has no kids. And there is no any syndromic features in the family. So on physical examination, he was obese, no Cushingoid features, no neurocutaneous markers, no morphonoid habitus, and his blood pressure was under well control. No palpable swelling in the neck, except for a previous surgical scar in the abdomen. The rest of the abdomen findings were unremarkable, and other systemic examinations, including neuromuscular, were unremarkable. So on evaluation, he was for his right suprarenal incidentaloma. We could see a non-functional part of biochemical workup, and while on evaluating for the routine uh, biochemistry, we found his calcium was 11.4, and his phosphorus is in the low normal limit. Uh, with normal 24-hour urinary calcium excretion, and his IPTH was 12.05 picomoles, and that time he was having insufficient vitamin D. So we supplemented with vitamin D and then again reevaluated after 5 months, and then we could see his calcium was still on the upper end and phosphorus is in the low normal limit, and his PTH remains high despite vitamin D being corrected. Uh, the other prolactin and thyroid function tests were of normal. The ultrasound neck, it showed a multiple nodule in the mid pole of left lobe of thyroid, with few showing cystic degeneration, and some are hyperechoic with peripheral halo, and which they have given as TIRAX 2, and a hypoechoic well circumscribed lesion of 3 into 6 millimeter in the lower pole of left thyroid with arc type vascularity, suspicious of parathyroid adenoma. This is the hyperechoic left lobe of thyroid with the SOL extending into the isthmus, and the arrow signifying indicating the hypoechoic 6 into 3 millimeter lesion, which we suspicious of parathyroid, enlarged parathyroid. So we went ahead with the functional imaging, technetium 99M MIBI scan. Then the delayed images, they reveal normal washout from the thyroid gland, but there was a persistence of faint tracer
Vishwak sir? Dr. Vishwak? I'm afraid we're not able to connect with Dr. Vishwa.
Yeah. The triple phasic adrenal protocol CECT, which we had taken for uh, the evaluation of a right suprarenal lesion, it showed well-defined heterogeneous 5.7 into 5.3 centimeter with the area of soft tissue and fat density in the right suprarenal lesion, right suprarenal region, rising from the right adrenal limb, and the lesion is abutting the inferior surface of liver superiorly, the upper pole of right kidney inferiorly, and the right crest of diaphragm medially. And the left adrenal gland also, it shows a multiple small fatty lesions with an exophytic tumor component of 5 into 4 centimeter from the left adrenal gland region. This is the cross-sectional view of the right uh, heterogeneous fatty lesion and the left adrenal fatty densities with the exophytic component. So impressive of bilateral adrenal myelolipoma. So the diagnosis of primary hyperparathyroidism due to left inferior parathyroid adenoma and left lobe of thyroid with the TIRADS2 nodule with bilateral adrenal myelolipoma in a hypertensive patient was made. So his ultrasound kidneys were normal in size. The CMD was maintained. A tiny calculus of 5 millimeters seen in the left upper pole. There is no obvious hydronephrosis. BMD is almost normal. An echocardiography has a normal LV contractility with 60% ejection fraction, and fundus was normal. So we planned for unilateral neck exploration with left inferior parathyroidectomy with intraoperative parathormone assay and left hemithyroidectomy. So on neck exploration, we found a 6 into 3 millimeter firm nodule adherent to the left thyroid lobe on its inferior aspect, and this was excised, and this was marked as left inferior parathyroid specimen. But then the patient didn't have a curative fall of IOPTH after excision of this. So we converted from unilateral to bilateral exploration. The carotid sheath, retroesophageal, retrotracheal, thymic portions were examined. A sub-centimeter maroon-colored nodule in thyrothymic ligament was also excised, along with the left superior cornu of thymus. And left hemithyroidectomy was done. The other parathyroids were normal and preserved. We couldn't get this frozen section biopsy on the day of procedure because of logistic issue. But then this post IOPTH after excising the thymic portions, it had a curative fall, and then we abandoned the further procedure. So this is the other maroon colored nodule along with the thymic portion and left hemithyroidectomy specimen. And the specimen which was labeled as left inferior parathyroid, the first 6 into 3 millimeter specimen which we have excised, that we couldn't see any parathyroid parenchyma in it. It was an unremarkable thyroid follicle. And the specimen which was sent as a thymic tissue, it shows a parathyroid tissue within it, and it has a picture of an adenoma. And left hemithyroidectomy was reported of having a nodular colloid goiter. There's no signs or symptoms of clinical hypocalcemia in the post-op course. His calcium went up to 7.7 milligram per deciliter in the post-operative period. He was started on prophylactic oral calcium supplement from POD1 and discharged on POD6 with 1 gram of oral calcium supplement. So the further plan would be to monitor his serum calcium levels, and for his workup for the adrenal myelolipoma, since this our patient is uh, hypertensive with bilateral adrenal myelolipoma, we have to go for a metabolic workup, and already we have done the hypercortisolism part, and metanephrine and normetanephrine and aldosteronism functional part were normal, and we couldn't see any collision tumor in the imaging. So, uh, considering the fact that he has got no kids, the congenital adrenal hyperplasia uh, bears uh, it bears a good reason for bilateral adrenal myelolipoma in this setting. So we did a 17-hydroxyprogesterone. The report is yet to be awaited. So once it's been reported, then we would plan for the procedure. So I chose this case as because the combinations of primary hyperparathyroidism with bilateral adrenal myelolipoma, as such, it's very rare, and it's been scarcely reported in literature, except for a few case reports. And this is one of the first case reported in 1984 in the Journal of Histopathology, an unusual variant of Men's syndrome, where they had attributed this uh, combination of thyroid and parathyroid with adrenal tumor as a component of Men's syndrome, as because men has a component of adrenal cortical tumors as well. After which a few other cases has been reported where this association of adrenal myelolipoma with primary hyperparathyroidism, they attribute that as an unusual variation of MEN1 syndrome. But still, on complete sequencing and mRNA expression analysis of MEN1 gene, uh, there is no loss of heterozygosity on chromosome 11q13, and a complete DNA sequencing yielded. There is no hint that defects of MEN1 gene are responsible for formation of adrenal myelolipomas. So, in view of the rarity of these combinations and scarcity of literatures uh, attributing it to MEN1, I would like the panelists to brief their experience and input on this combinations. Thank you.
Thank you, sir. It was an elaborate presentation. Sir, I just wanted to know why did you do a focused parathyroidectomy? You didn't explore for the other side or the other four glands. It was a limited parathyroidectomy, I guess.
Yeah, initially we planned for focus just because it was concordant with the ultrasound and functional imaging. So we started with unilateral neck exploration. It was not focused. We started with unilateral neck exploration since because the plan was to do a left hemithyroidectomy as well. But then we couldn't have had a curative fall of IOPTH. We converted from unilateral to bilateral, and then we explored all the routine ectopic locations as well.
I just have one question, Anish here.
Yes,
Yes,
sir.
sir.
Please.
Suppose so frozen was not available at that time. That's why you did not send a frozen section. So you did a hemithyroidectomy as well as you took tissue from the central compartment. Now, suppose there was no fall in the IOPTH, what would be your next step?
Sir, we had explored the areas of carotid sheath, retroesophageal, retrotracheal, and thymic portions as well. So we have excised the left superior cornu of thymus. So in that case, we would still have to explore the rest of the ectopic portions. We have to see the right superior cornu of thymus as well, and have to go for the anterior mediastinal component like the and up to the base of skull we have to extend superiorly.
Okay, so you explored all the ectopic sites, in spite of which IOPTH does not fall.
Hmm.
I'd open this to anybody else, any of the other postgraduates.
So maybe then we can review our diagnosis. I mean, if there's no adenoma anywhere, maybe our diagnosis is wrong.
Yeah. So if you've done a complete operation and you've explored all the ectopic sites, the PTH doesn't fall, then I suppose you'll have to close. And one, yes, like you said, confirm that your diagnosis is correct. And suppose your diagnosis is correct, that means you have a persistently elevated calcium and PTH with a low normal phosphorus. Then how would you proceed?
So like it would, for few patients, it would take the IOPTH to fall maybe on the evening or on the next day. So
Sure.
in that, like patient having a persistently high calcium for so many years, there is a chance of there is a delay fall of IOPTH. So in that case, we have to abandon the procedure and then we have to observe him in the post-operative setting.
So that's correct. So you would wait for the biopsy to come and you'd wait, and you'd repeat a PTH in the post-operative setting. That's absolutely correct. So suppose your biopsy does not show any parathyroid tissue and your IOPTH is, or your PTH the next day is still high or elevated, then the next step would be to first confirm your diagnosis. And if the diagnosis is primary hyperparathyroidism, how would you proceed after that?
So we would like to do further imaging.
Okay.
Because already we have confirmed all the ectopic sites with the
Yes.
operatively. We would
Yes.
probably go for other advanced imaging, so maybe anatomical in the form of CT or MRI, and
Sure.
functional like the methionine PET CT, carbon 11 methionine,
Sure.
or fluorocholine.
Sure.
If that gives any suggestion, maybe then then only we will contemplate for resurgery. If
Yes.
find any suggestion of any lesion, then we would try to manage the patient medically and repeat imaging after few months maybe. Or I mean, I would assume that the adenoma must be very small, so that's why it's not being picked up or not seen. And with time, it may increase in size, or once the PTH starts rising furthermore, maybe there are chances of visualizing it. But for resurgery without localization, we would not contemplate.
Yes. So there's a practical, yeah, sure.
And even if parathyroid adenoma is still not found, in that case we can go for invasive testing, like selective venous sampling. So that would be our last resort. Probably.
Sure. Sure. So it's a practical problem that you might face. So just keep that in mind, that if IOPTH still doesn't drop in spite of your extensive surgery, you can always close, wait for the biopsy, repeat a PTH the next day, reconfirm your diagnosis if everything is negative, and then reevaluate for localization with other modalities of imaging.
Okay, thank you, sir.
Thank you, sir.
Divya ma'am, can I ask you a question? Ma'am?
Yes, please.
Ma'am, in syndromic cases like Mann syndrome, when there is a hyperplasia and we are doing a bilateral exploration, is it routine to do a thymectomy in these patients? Or if at all it should be done, what is the indication?
Actually, we at our center, we don't go ahead with thymectomy in all the cases. We just we do the bilateral exploration and do the 3 or 3.5 gland excision depending on the indication beforehand. And thymus we do explore for any abnormal tissue, but we don't do thymectomy routinely.
Okay, ma'am, and the role of IOPTH in syndromic cases?
Actually, it is a good modality, but again, I will say we don't have it in PGI Chandigarh, so we rely totally on frozen section.
Okay.
Can I say something, Dr.
Yes, sir, Sunil.
As ma'am rightly said, that the thymectomy is not done routinely. If there is a curative form in IOPTH, you need not perform thymectomy. But inferior parathyroid can be present in the thymus in about 20 to 25% of cases. So in a desperate situation, you may do a thymectomy when there is no fall in IOPTH. In sporadic cases. But in syndromic cases, yeah, that is at the discretion of the surgeon.
Okay.
So parathyroid
Can I
rests can be
involve?
present. Parathyroid rests can be present in thymus. And in especially in men one, there is also fear of thymic carcinoids. So at SGPGI, we usually do thymectomy.
Yeah, even at CMC, we do a thymectomy for the same reasons that you can have supernumerary parathyroids within the thyrothymic ligament or the thymus, as well as the presence of carcinoids in the thymus.
Sir, can I ask you, I mean, should we change our practice, or should bilateral neck exploration for syndromic cases should be the standard, or is there any role of unilateral exploration in these cases?
So syndromic, I'm assuming it's men 1 and men 2. Both of them behave differently. Men 1 is usually four-gland pathology. So we would always do a bilateral neck exploration. And either a 3 or 3.5 is our protocol in Velo. For men 2, they are less aggressive and usually adenomas, single or multiple. So it would be assessing again a four-gland exploration and removing only the glands that are enlarged.
Thank you, sir. Naval sir, you want to add anything to it? So can I?
Hello.
Yes, sir.
Am I audible?
Yes, sir. You're audible, sir. Please.
Whenever there is a difficulty in finding, this is my personal experience in finding parathyroid, and especially we have a thyroid nodule. Always think of intrathyroidal parathyroid, because in a private setting I operated 2 cases, and both was reported the thyroid nodule in one was reported as a PTC and other was reported as a normal thyroid tissue. So when I opened up, there was no parathyroid gland as demonstrated on the pre-op imaging. So I always take consent for a hemithyroidectomy when I am taking patient for parathyroid surgery. So a high suspicion should be there when we cannot find a parathyroid gland in a normal location, and there is a nodule in the thyroid. That's what I want to say.
Yes, sir. Thank you, sir. Sir, we have come to the end of this session, but I had one question that was regarding parathyroid carcinoma. When we are operating in such cases, is central compartment lymph node dissection mandatory in all cases, or it should be done selectively? And I want to know what is the stand on lateral neck dissection as well in those cases. Sir, Anis sir, could you please?
Sure. So from literature, they say that parathyroid carcinoma has a less propensity to lymph node metastasis. So by guidelines, there's no role for prophylactic central compartment neck dissection in a patient with parathyroid carcinoma. However, at our institution, if we suspect a parathyroid carcinoma or there is metastatic disease, proven parathyroid carcinoma, we would do a on-block resection of the gland with the hemithyroid with structures that are adherent and ipsilateral central compartment. Regarding lateral compartment, we will not do a prophylactic lateral compartment. We would only address the lateral compartment if there is proven metastatic disease.
Okay. Thank you, sir. We are running short of time. We have one more case. We can take it up later in the later session if time permits. So I thank the panelists and all the participants, as well as my colleagues who presented and shared their cases. We will leave this meeting and we'll log in again at around 11 o'clock. And that session is on adrenal diseases. Thank you all.
Thank you.
बोले था
Hello. Hello.
Good morning, everyone. We shall begin with the second session of the day. This is the session with regards to adrenal gland tumors. We will have 4 cases. First of all, I would like to welcome the panelists for this session. Professor M.J. Paul sir from CMC Vellore, Professor Gaurav Agarwal sir from SGPGI, Preeti Dabadgaon madam from SGPGI from Department of Endocrinology, Dr. Dalapati sir from Madras Medical College, Dr. Archana Gupta ma'am from Radio Diagnosis. Welcome you all, sir and madams. Good morning once again to all of you. We'll begin with the first session. First case presentation presented by Dr. Fareen. Case will be Conn syndrome. Fareen, over to you.
You're audible for him.
Morning. Presenting
Audible. Fareen, you're not audible.
Am I audible now?
Fareen? No. No. You're not audible yet.
I can hear you. Other faculty?
Yeah, Fareen, I can hear you, but perhaps if you have a headphone or something, that would be better.
The problem is there in here. Ma'am?
Fareen, do you...
Am
Yes,
I
Fareen?
audible to all of you?
Yeah, Fareen.
Yes, Dilip, you are audible. Fareen is audible. All of us can hear each other. Let's begin.
Presenting Mrs. G, she's 48-year-old lady, a homemaker from Orissa. She presented to us with history of weakness of both upper and lower limbs without loss of consciousness, one episode 7 years ago. During evaluation of the same, she was found to have hypokalemia with systemic hypertension, and she was started on antihypertensive medication that included an angiotensin receptor blocker and calcium channel blockers. However, she was irregular on her medications over the 7-year period. She did not get evaluated any further. Till in July 2018, she developed severe weakness of both upper and lower limbs with no loss of consciousness. There was no bowel or bladder incontinence. There was no syncope. There was no history of any trauma or any altered sensorium. An MRI done at that time was normal. And on further evaluation, she was found to have an accelerated hypertension with hypokalemia, and an imaging done at a local hospital in Orissa was suggestive of a right suprarenal mass, following which she came to SGPGI for further evaluation. On further inquiring, there was history of increased requirement of antihypertensives. She was non-compliant and she used to take treatment at a local doctor who used to give her medications, and her hypertensive episodes used to settle. There was, however, no history of headache, sweating, palpitations, syncope, chest pain, or any weight loss. There was no history of postural dizziness, vertigo, falls, hematuria, dysuria, calculuria, vomiting, or blurring of vision. She's been diagnosed to have hypothyroidism for the last 8 years and is on medications for the same. There is no family history of abdominal mass, a neck swelling, any young hypertension in the family, or sudden deaths. There is no history of renal calculi, no history of abdominal or neck operations in her or in her family members. On examination, she was well built. Her pulse rate was 82 per minute. It was regular in rhythm, normal volume, and all peripheral pulses were palpable. Her blood pressure was 170 by 100 millimeters of mercury in the right upper limb and 160 by 100 millimeters of mercury in left upper limb. In supine position, there was no postural hypotension. Thyroid was not palpable, trachea was central, there was no palpable cervical lymphadenopathy. There was no Cushingoid features, and there were no neurocutaneous markers. On systemic examination, her respiratory and cardiovascular systemic examination was normal. Her central nervous examination, motor and sensory examination was normal. All deep tendon reflexes were normal. On further investigating her, her serum potassium was found to be 2.93 milliequivalents per liter. Her aldosterone renin ratio was 66, which was much above the normal value. Her direct renin for the aldosterone renin ratio was 0.5 micrograms micro international unit per ml. And plasma renin activity was low. Serum cortisol was normal. A 2D echo was done, which revealed concentric left ventricular hypertrophy with a normal ejection value of 63%. And there was mild LV diastolic dysfunction with no regional wall motor abnormalities. A triphasic adrenal protocol CECT was performed, which showed a well-defined hypodense and hypoenhancing lesion of 15 into 19 mm arising from the medial limb of the right adrenal. On NCCT, Hounsfield unit was 11. It was 11 Hounsfield unit, and there was absolute washout of 68%, suggestive of an adrenal adenoma. After preparing her for surgery, we took her up for right transperitoneal laparoscopic hand-assisted adrenalectomy on 5th of December 2019. Intraoperatively, there was a single adrenal nodule arising from the medial limb of the right adrenal of size 2 into 1.5 into 2 centimeter. On crossing the section, it was golden yellow nodule, which was fleshy, and there was no areas of hemorrhage or necrosis. Her final histopathology was reported as adrenocortical adenoma with Y score of 0. Her post-operative period was uneventful. However, she required 2 antihypertensives. That was a calcium channel blocker and an alpha blocker till her discharge, and was advised to review with daily BP monitoring from home. Her serum potassium improved and became normal on post-operative day 2, following which on post-operative day 7 she was discharged.
Yeah. The paper is open for discussion. Do you have any questions? Sir, Gaurav sir, Paul sir, any?
Yeah, hello, Farin. Thank you for that presentation. Can you hear me?
Yes, sir.
Yeah. So I think the clinical diagnosis was quite straightforward because you had hypertension, hypokalemia, and that's the situation in many of our cases. And your biochemistry was also reasonably clear cut with high ARR. Now the question, is currently asked in international circles is the role of adrenal vein sampling. So when do you, in the Indian context, can you say when it might be useful or when is it indicated? Is there an indication or is it routinely required according to guidelines? Are you aware of the role of adrenal vein sampling in diagnosis and management? Yeah.
Adrenal vein sampling would be ideally required for localization uh, of the if there is no conclusive diagnosis and we strongly suspect adrenal hyperplasia, to localize a lesion, I think an adrenal venous sampling would be required, but it is not to be done routinely. If an imaging is there and it localizes a lesion.
Yeah, okay. There are actually some society guidelines which have recommended routine. So if you look at the history in India, of course, there's limited expertise, and because our patients present quite classically usually to the hospital, we must understand the basis. Do you know what factor actually is the main one that leads to use of AVS? What is the critical point that requires extra evaluation? Why, if you've got a lesion on CT, why would you want to check it? What are you worried about? Why would you want to sample?
Idiopathic bilateral involvement is more common than single lesion. And there are
Yeah, so I mean, hyperplasia with bilateral production of hormone is a problem, but the main issue really is about like non-functional adenomas or like incidental increase as you age. So the older you get, the likelihood of a small non-functional adenoma being present in the adrenal is higher. So that becomes like a confusing point. So it may be actually production bilateral or even from the opposite adrenal from hyperplasia or a smaller adenoma which you have not picked up. All this can confuse the issue. So the presence of a lesion, especially in an older patient, does not mean that is the source of the aldosterone. And what is the way of checking it in histopathology? We'll come to that later. Sorry. So the guidelines that recommend adrenal vein sampling say you can probably leave it out in a young patient, like less than 40. Many people agree that it may not be valid because by then these non-functional adenomas are less likely. So if you have a clear lesion with a clear clinical diagnosis and presentation in less than 40, then most people will say, yeah, probably AV is not required. But as you get older and the lesion is smaller, then um, the pitch gets queered by these non-functional adenomas when the role increases. Now, I know, and I think SCPGI, you have some experience. Here in Velo, we've actually debated this issue quite a bit, and looking at our own past literature, there was only one case where we probably would have benefited from it. And discussing with our interventional radiologist, the procedure is quite demanding. It's got potential complications. It's expensive. So in the balance of risk benefit, we felt we are not going in for it. So I don't know, what is your strategy in SGPA? Probably Gaurav can.
Yeah, thanks, Paul. Yeah, I fully agree with whatever you said. I will come to what our strategy is, but just to complete this list of indications where adrenal venous sampling is really helpful, perhaps I can cite one case we managed around July last year. And some of Fareen, perhaps you may not be aware of this patient, young school-going girl, just out of school actually, with hypertension and a definite diagnosis of hyperaldosteronism. No hypokalemia, but hyperaldo. Being so young and hypertensive, she was evaluated, and repeated CT and MRI failed to localize a disease. So, adrenal venous sampling is indicated in such a situation where the clinical and biochemical suspicion is high or the diagnosis is established, and you fail to find an adrenal pathology. And indeed, this patient had a performed. There was a lateralization to the right side. Mind you, Fareen, it is better to call it lateralization and not localization. And in such a scenario where you do not see a pathology on cross-sectional imaging, and then indeed we operated this girl, and she was cured of her hypereldo, and there was indeed a small tumor less than a centimeter adenoma in the right adrenal gland. So this is another scenario, and as very rightly put by Paul, that this is also something which where you would take into consideration the age of the patient. Younger the patient, you are not so worried about non-functional incidentally detected adenomas, which are a common occurrence in elder age. Now, coming to our protocols or our practice, perhaps we use adrenal venous sampling selectively. So, if this was a MCQ, that where would you use it? Always selectively, never, or leave it for somebody else to decide. The answer to us is selectively. So we use it wherever the strength of diagnosis or localization is in question. Either it is non-localized altogether, as I illustrated in the case that I told you about, or you have some doubt of either bilateral nodularity, or the patient is elderly with low index of a consadenoma. So there we use it. Of course, it comes with its own sets of problems, and we have had patients where we have done it and it has remained the results have been equivocal. It hasn't helped us to decide one way or the other. And the patient has then undergone, I mean, this is a patient we managed a few years ago. We eventually operated on one side, considering the other side as being micronodular and perhaps very low risk for a disease on that side. Unfortunately, the patient was cured. But the adrenal venous sampling is demanding, as very rightly put by Professor Paul, and it can lead to problems. It can lead to thrombosis. It can lead to vascular injuries. It may fail. You may not always be able to uh, cannulate the vein and then take samples.
Thank you, sir. Ma'am, Archana ma'am, I have a query, ma'am. Whether CT is better or MRI is better in these adrenal tumors, ma'am, which are quite small.
Actually, there are two things. For finding out intracellular lipid, CT may be less sensitive than MRI, because in MRI, chemical shift imaging is more conclusive. In chemical shift imaging, signal loss of signal in out of phase imaging is more specifically tell about intra tumor intralesional lipid. However, the three-phase CT is concerned, three-phase dynamic imaging is concerned with contrast media. The CT is more sensitive. It has been tried in MRI also, but MRI didn't pick up the lesion so well as it is seen in CT. Traphasic CT or CT with delayed images to find out the washout of the lesions. The absolute washout and relative washout is more significantly differentiate adenoma versus other lesions. So to find out intra-lesional fat, the chemical shift imaging is more characteristic. However, for percentage washout, the CT is more characteristic.
Thank you, ma'am. Ramya, sir, Paul sir, Ramya from SGPGI has asked
Dilip, I'll ask this, sir.
Yes.
Sir, you asked how will we identify on histopathology whether this is the inflicting adenoma or not? Like, do you mean that we should do IHC for aldosterone synthase staining?
Yeah. Now that actually illustrates that sometimes the adenoma is not the source of the aldosterone. Just to highlight that point, we don't do it routinely, but it's only academic.
Yes, sir.
That's right. Yeah.
Thank you, sir.
One of the largest experiences of surgery for hyperaldosteronism comes from a Brisbane center, which is an exclusive hypertension hospital, and James Rutherford. And they've had a long history of managing hyperaldose, and for a long period of time they did not, but then eventually shifted to doing adrenal venous sampling for each and every patient. And in fact, doing it before doing the cross-sectional imaging. But that is one extreme view. It's not something which everybody shares. And as Paul pointed out, there's some societies, mostly hypertension societies, where evaluation of for hyperaldo is important, because that's in that scenario, the prevalence of hyperaldosteronism is higher, reported higher, and they swear by adrenal venous sampling.
Dalapati sir, your comments regarding this, sir?
Yeah, actually, I have a question to Dr. Archana, madam.
Yeah.
Have any experience of radio frequency ablation of these Cons tumors, madam? Because last years in International Surgical Week, we had papers being presented from various centers that they have more than 150 cases where they have done a radio frequency ablation for these Cons like that. And it was awarded best paper for twice or thrice, if I am not wrong. So your thoughts on radio frequency ablation of these tumors?
Actually, in our center, I am doing only diagnostic imaging. I am not doing intervention radiology. Maybe Dr. Gaurav can tell about if they have requested. I don't know what intervention radiology they are doing.
No, we have never asked for a radiofrequency ablation or any kinds of non-surgical ablative treatment for these tumors. If you have a straightforward adenoma and you now have the advantage of minimal access surgery, which is most cases it's a straightforward, not so morbid cure for the for the disease, why should you bother to use such experimental treatment strategies? Paul, what's your view on this? Are we
Yeah, I was also there when that paper was presented. But if I remember right, there has been a follow-up paper which shows some recurrences. I was just trying to check on that. So there is a rider attached that it is not foolproof, and that goes for, I think, the people have even tried radiofrequency ablation for insulinomas. So unless you have a long-term follow-up for about 5 years, you really can't comment, at least 5 years, comment on the safety, efficacy of it. So I'm just...
Yeah, I do remember there was quite a bit of criticism of that strategy. It's not, there may be specific scenarios where a patient is very high surgical risk and otherwise for some reason not amenable to surgery. Perhaps you can try it out, but not as a routine.
Dr. Paul, that can be not residual. That can be the that is not the recurrence. That could be the residual lesion, because radiofrequency ablations, there are protocols for that. The lesion in case of adrenal may be coming out from the adrenal itself, and you have to have for RFA, you have to have some normal tissue surrounding whole lesion. So that is relatively not feasible with RFA. So that could be the residual lesion, not the recurrence.
Yeah, the lesion is residual, but the disease recurs, meaning
That is true. If there is residual
it's
lesion,
just
definitely there is disease.
Yeah, I agree. No, so there actually the group which published, they have reported that they had only one recurrent disease, probably because of a residue. So they still claim that it's effective. Eight patients with CT guided and one recurrence. So that's the current status of the literature. I think, as Gaurav said, since we are doing minimally invasive approach, as you know, CONS is a very straightforward, simple procedure. There may be very rare instances where you have to resort to RFA, where a patient is not willing for surgery or has got significant comorbidities that may benefit from a ablation approach. But so far we have not come across that situation.
Yes, sir. Actually, that was a large series, I think, sir. Around 200 cases, something like that, if I remember that. The radio frequency ablation they have used for these CONs. I don't know how they have done that, actually.
Can I ask what was the smallest size? The smallest size for RFA they have taken?
I don't remember exactly, ma'am. It happened actually 2-3 years back, actually.
Okay.
As Dr. Paul said, they had a follow-up of this series. Initially, they presented some 150 cases, I think. Then the next time they came up with the 250 cases. They had a follow-up of these patients like that. They were presenting on this radiofrequency ablation, and it was.
Is there any physicians on board to take on the prep? I think the evaluation is also important. You have anyone, or you want to?
I don't see any. Do we have Dilip? Do we have any
Preeti
endocrinologist?
hasn't joined, sir.
Preeti may not have joined as yet. So yes, perhaps good to remind all our younger colleagues. This patient had quite a classical clinical course with hypokalemia and a straightforward diagnosis of primary hyperaldosteronism. This may not be so in fact majority. Just a very few patients actually have hypokalemia, and many patients do not have a classical biochemical picture yet. If your clinical suspicion, index of suspicion is high, you can still detect a large number of patients with hyperaldo.
Sir, what is the panelist's opinion on performing partial adrenalectomy if there is a adenoma identified arising from a limb, like in this case?
Paul, would you like to take that?
Yeah, I mean, I would personally not recommend it because, again, we said there's this pitfall that the secretion may not be coming actually from the lesion. And there's no potential benefit in the situation of hyperaldosteronism for leaving tissue on one side, like if you are in a FEO. But I know that I think Waltz has published his experience with partial in CONS.
Yes, sir. They routinely do.
But I can't see the significant logic in that approach. I don't know. What do you feel, Gaurav?
No, I feel, see, just take a step back. Dr. Paul very rightly said that bilateral disease, hyperplasia, is the main consideration when you're trying to distinguish an adenoma and hyperplasia. So if you're going and intervening on one side, better to do complete procedure on that side. In worst case scenario, if you were dealing with hyperplasia, and as some people say that even for hyperplasia with primary hyperaldosteronism, there's a case for surgical treatment. More so, why should you even bother to do partial adrenalectomy? It's not something where you are contemplating bilateral adrenalectomy. Of course, the only reason that comes to mind is these are young patients in majority of cases, and subsequently during their later life they may develop a pathology on the other side, and so they may end up with a bilateral adrenalectomy and so become dependent on exogenous corticosteroids. But I see no good reason why we should not do a total adrenalectomy on the involved side.
Actually, sir, shall I have a word, sir?
Please go ahead, Dalpati.
Yes, sir. Actually, the word partial adrenalectomy has been used interchangeably, sir. What they say in partial adrenalectomy, majority of some papers which I have seen, they remove the tumor alone and leave the normal adrenal tissue. Then they call it as a partial adrenalectomy. few papers which I have seen, they just remove that nodule or the tumor alone and leave the normal adrenal tissue, and they refer this as a partial adrenalectomy. Unlike we think that they remove only half of the tumor or like that, where in case of this Cushing's, where we want to remove the whole of the adrenal gland. That's what my understanding goes when they refer it as a partial adrenalectomy. Maybe if I'm wrong, correct it, sir.
No, you're right. This is an imperfect description in any case. Cortical sparing, partial adrenalectomy, adrenal sparing, tumorectomy or adenomectomy, all such terms have been used interchangeably with, but I'm sure as endocrine surgeons, we have been doing quite a few of such cases, such procedures. We have abundant subtotal thyroidectomy long ago. Because you are leaving, what you're leaving behind is a diseased gland. Similarly, if you are indeed dealing with a diseased adrenal gland and you're removing part of it, the chances of recurrence or persistence is high. But if you're dealing with just a tiny tumor and you're sure that genetically this adrenal gland is not predisposed for more tumors, then it makes sense to just remove the tumor. Secondly, if you have the other adrenal gland which is functioning very well, why should you bother to do partial or cortical sparing or adrenal sparing surgery?
Thank you, sir. Shall we move on to the next case, sir? Yeah. Sir, the next case will be presented by Dr. Vikram. He will be presenting a case on pheochromocytoma.
Thank you, Dr. Dilip. Good morning, everyone. So my patient is a 32-year-old lady. She was initially evaluated elsewhere by a cardiologist for uncontrolled hypertension for 1 year, and she was started on antihypertensives. Incidentally, she was also found
Vikram,
to
your screen is, I mean, your PPT is not yet up on the screen. What you're sharing is just your screen, not the PPT. Unshare the screen, go
Yes,
back
sir.
to sharing screen, and then select on the PowerPoint, not on the. Yeah, now I can see it. Excellent. Yeah, go ahead now.
Yes, sir. So, 32-year-old lady, she was evaluated elsewhere by a cardiologist for uncontrolled hypertension for 1 year, and she was started on antihypertensives. Incidentally, she was also found to be diabetic, and she was started on oral hypoglycemic agents. And before presentation, 20 days before presentation to our center, she had pain abdomen, and ultrasound was done elsewhere, and it showed a left suprarenal lesion. So that's why that's why she was referred to PGI. So on further retrospective history, she did not have any anxiety, palpitation, or headache or sweating. There was no history of constipation or melena or any bleeding her rectum. There was no exertional dyspnea or syncopal attacks. There was no history of proximal muscle weakness, abdominal stria, or of increased facial hair or central obesity. There was no history of neck swelling, and her menstrual cycles were normal. So past history was not significant, and family history, again, there was no neck swelling or abdominal mass or any previous abdominal surgery in the family members. Neither there was any sudden death in the family members. So on examination, our general physical examination was normal. There was no pallor, icterus, edema, lymphadenopathy, cyanosis, or clubbing. Her vitals, her pulse rate was 80 per minute, and her blood pressure in supine position was 170 by 110 millimeters of mercury. Our systemic examination, cardiovascular system, a respiratory system, and parabdomen and central nervous system were normal. On examination of the neck, there was no thyromegaly or cervical lymphadenopathy. So we evaluated her further on biochemical, clinical chemistry and hematology. Her liver function test was normal. Even her renal function tests were normal. The only thing was she had anemia with hemoglobin of 7.9. So further endocrine investigations were done. Our urinary 24-hour urinary metanephrines and normetanephrines were done, and she had a significant elevation of normetanephrines to a tune of 8,100 micrograms for 24 hours. So other investigation to rule out syndromic association, calcitonin was normal, and IPTH was also normal. So since it was a suprarenal mass, so our initial evaluation in our center is to check for metanephrines and ONDST, and our overnight dexamethasone suppression test was normal, but means it was suppressed. To assess end organ damage, as part of preoperative evaluation, 2D echo was done, and she had a low ejection fraction with a grade 3 LV diastolic dysfunction with regional wall motion abnormality. So for further anatomical imaging was done. I'm sorry for the poor quality of CT. So she had around 9 centimeter lesion in the left suprarenal lesion, which was closely abutting the left kidney. And again, on a Dotanock CT, because it was a large lesion, so we got a functional imaging. So this again showed a somatostatin receptor expressing tumor with a SUV max of 15 in the left suprarenal region. So further sequencing for MEN2 and VHL was done, and this did not show any mutation. So after history and clinical examination and biochemical and anatomical evaluation, we diagnosed her to have left adrenal pheochromocytoma, and our plan was to do a left open adrenalectomy. So preoperatively, her anemia was corrected by blood transfusion, and she was started on alpha blockade with adequate fluid intake and salt supplementation. So this is the intraoperative picture. This is the left adrenal which was enlarged. And there were a lot of parasitic vessels. However, it could be easily separated from the surrounding structures. So on grossing, we had a 10 centimeter lesion, which was weighing 186 centimeter. And surprisingly, she did not have a intraoperative blood pressure fluctuation, and her maximum recorded blood pressure during surgery was 129 by 87 millimeters of mercury. So on histopathology, it showed a pheochromocytoma with a PAS score of 1. So post-surgery, she had an uneventful recovery. After 1 month, we got a 24-hour urinary metanephrines and normetanephrines done, and which was normal. So our future plan is to follow her up with annual metanephrine and normetanephrine. Thank you.
If I may take lead in discussing this case. Yes. Vikram, perhaps you may not have been involved with managing this case, but are you aware what were the indications for, I mean, what's her age again? This lady?
She's around 36 years.
A young patient with
Yeah.
hypertension
Yes.
and a large adrenal mass. That is how she got referred to us, isn't it?
Yes.
So what is the probability, and in absence of any other components of any syndromic pheochromocytoma or syndromic hypertension disease, and in absence of family history, what are the indications of, number one, the RET mutation and the VHL mutation studies, and number two, Daytonic PET CT?
Sir, around 40% of patients with pheochromocytoma is known to have a familial association. So it is necessary that we test for all the genes, all the 20 genes or 22 genes which are right now associated with the pheochromocytoma. But commonly, what we do in our center is RET and VHL. So we got her tested for VHL and RET.
So the crucial thing to remember is, in absence of any clinical suspicion or evidence of syndromic or familial, okay, first thing. Secondly, if at all you're worried about familial or genetic forms of pheochromocytomas, what is the commonest mutation associated with
Sir, in
pheochromocytoma?
this young patient with the biochemical elevation of urinary normetanephrines, the most common would be a VHL in this patient.
Mhm. And not SDH mutations?
Sorry, SDH mutation, if it were paraganglioma or head and neck region, then
Mm. Okay, and why would you like to do Daytonic PET CT in a patient who has a clearly unilateral 9 centimeter left adrenal pheochromocytoma?
this lesion was it was a big lesion, more than 6 centimeter.
More than 6 centimeter is an indication. What is the, I mean, and why? If it's a large tumor, what is your
One is
concern?
the last tumor, and second is the young age of the patient to look for any other multifocal.
So again, let me just clear the air from this issue. Size is no criteria to decide. Size doesn't predict malignancy. The reasons when you do functional imaging, Daytonic or otherwise MIBG scans,
आ रहा है तो वैसी चिंता की बात नहीं है, लेकिन एक मेमो और वो अल्ट्रासाउंड तो करवा ही देंगे।
Dr. Anjali, please mute yourself. Sorry. Dr. Anjali, kindly mute your microphone.
नहीं, मल्लिका से करवाने का तो इतना कोई फायदा नहीं होगा, वो तो मल्लिका आज तो कोई फ्री नहीं लगा रहा है।
Anjali, can you please mute your microphone? Yeah, thank you. So, if you're concerned about metastatic disease, if you're concerned about multicentric disease, extrarenal disease, or in rare patients or few patients where you have a clinical and biochemical diagnosis, but you are unable to localize a pheochromocytoma on the whatever cross-sectional imaging you have undertaken. I don't see any other reason than these. So size in any way is not predictor of malignancy, metastatic disease, multicentricity or bilaterality. So don't go by just the size notion. Of course, if you have any reason to believe that what you're seeing on cross-sectional imaging is not the final word. If you have bilateral nodularity or nodule, a tiny tumor on one side and an enlarged gland on the other side, or for some reason you believe, and in worst case scenario, if even if this patient with a 9 centimeter tumor on left side had a small either a medullary hyperplasia or a tiny tumor on the other side, which was not seen on CT scan, it will not show up on a Daytonic scan or MIBG scan. Anyhow, so please do not go with the notion that size predicts malignancy, not in pheochromocytoma. That is a consideration for adrenal cortical disease and not for medullary disease. What are your views on this, Dr. Paul?
As he said, size is not such a criteria. I would usually use functional imaging when there is a clinical suspicion of a familial syndrome like VHL or SDH, where either there's bilaterality is a suspicion within where the CT shows some doubtful lesion, or extraadrenal lesion is also doubtful, or a situation where malignancy is suspected because of clear invasion or metastasis, some other lesion. Like just recently we had a patient presented few but had a path fracture. So then the bone lesion was suspect. So those are situations where you may want to use functional imaging. Otherwise, yeah, it's not a routine evaluation. We have the options of MI. We have MIBG in institutions, so we often do use it, although it's not as sensitive. If you have, we have the FDG, I mean the PET scans as well, so you can use a DOPA, dopamine, DOTA scan. They all have pluses and minuses. So you can follow the institutional protocol on that, what your nuclear medicine department recommends. The real issue is, as you mentioned, 30 to 40% are shown to be have a detectable inheritable mutation. So are you aware of the recent sort of classification? How many mutations? We know the classic 4 familial syndromes based on commonality. When we look, it's VHL is usually the commonest in most centers. And then we have the SDH group of mutations, the RET and the neurofibromatosis, von Recklinghausen's NF1. Apart from that, can you list any other newer mutations, and how do you categorize them? Do you know any clustering that has been recently described?
Yes, sir. It can be classified as pseudohypoxia genes and those associated with RET mutations. And again, in pseudohypoxia, there are two, type 1 and type 2. One is associated with VHL and elongin mutation, and the second one is associated with the succinate Krebs cycle, all the SDH and fumarate hydratase and malate dehydrogenase mutation in these genes. And on the RET, we have RET pathway. We have RET neurofibromatosis, TMEM, MAX, all these mutations in that.
That is the MAP kinase P13K pathway, actually. So, yeah. So how does the act? There is a description for the.
Yes, so the pseudohypoxia pathway, the endpoint is the stabilization of hypoxia-inducible factors. So mutation in any of these pathway will ultimately lead to stabilization of hypoxia-inducible factor, and this will further activate the downstream pathways, and which will lead to cell proliferation and.
Yeah, very good. And the third cluster is described is not so important. The WNT signaling pathway.
That is regarded as like those mutations which were identified. They say this was because of contamination, tumor contamination.
Yeah. And it's only somatic. There's no germline inheritable identification. So mainly it's the two clusters that you described. Very good. And they fit into 4 familial syndromes, which are common. So we have a targeted way of checking. If you have a clinical suspicion of a syndrome, we do the target. But now the recommendation is to actually check all FIOs. And what is the practice there? Are you doing genetic testing?
We are checking for MEN2 and RET and VHL, sir. Other mutations we are not checking.
The second question I have is about.
We do.
Yeah,
sorry to interject. We do test for SDHB immunohistochemistry. So that's like a gatekeeper mutation for our SDH mutations. And if in case there's a loss of SDHB immunostaining, then of course that is an indication that there is a SDH mutation. But I think it was one of the projects of Sendil, and we found just about 10% of all patients with SDHB mutation.
Okay, very. Yeah. The second is about the PAS score. I think we are you aware of any other score? We've actually moved on to a more recent scoring.
Yes, sir. The other one is gap scoring, but that involves again, with the histology, they also involve the biochemical part of this thing.
What is the change actually? So
the changes, they involve the metanephrines and non-metanephrines levels as well.
AI67 also.
Yeah, no, if it's a noradrenaline or a dopamine secretor, then there's a point, because that is associated more with malignancy. So a point is added for that. And then as somebody said, the MIB index of Ki67 stain is also taken. And anything more than 2% is considered because FIOs have very low mitotic index. So that that has done by the Japanese group. They studied the entire country's FIO and paraganglioma profile and looked at the follow-up. So they have a very good data set, and they've actually divided into well differentiated, moderately, and poorly differentiated, and they give a good survival as well as a malignancy risk score for all three categories. Whereas in the past, you just say that 4 or less behaves less malignant, and more than that behaves more. So this has a better predictive capacity. So we've actually moved on to the gap. That may be something you can consider. The third is access. How do you choose access to surgical access? When do you choose which approach? And any other approach?
Yes, sir. One is the open, because this lesion was a 10 centimeter lesion, and preoperatively there was suspicion that there are adhesions, so we went ahead with the open laparotomy for this patient. If it were a smaller tumor, then we could have used a minimally invasive approach, either transabdominal or a retroperitoneal route for this. So, and again, the choice of transperitoneal or retroperitoneal, it depends on the expertise of the surgeon.
Yeah, so I think a very important thing is local expertise. You should not be dogmatic about approaches. Do what works in your hands. Be careful, and safety is the first precaution. Well, I had one question, sorry, which I didn't ask in the previous. What was the reason for hand assist in the Conn's adenoma? Is there any technical reason for that? Are you aware? Sorry, if Fareen is on, can you explain when you use hand assist?
So there were a lot of adhesions intraoperatively. So only to retrieve the specimen, finally a 5 centimeter subcostal incision was made.
Okay, sure.
Otherwise, the procedure was completed laterally.
Yeah, good. So there's a good point that you can, instead of doing a full open, you can put a port and use your hand so that you can still have benefit of less invasive.
So again, it's a matter of semantics. The terminal hand assisted procedure that we described initially, that was for larger tumors, not for a 1 centimeter tumor, where for the reason of ease of access or ease of removal or retrieval of the tumor, we would make an incision after having doing the vascular isolation of the tumor, and the limit that we set, and these were mostly for pheochromocytomas and large adenomas, or even myelolipomas, which were large, we would not put an incision larger than the largest dimension of the largest than the smallest dimension of the tumor. But I agree, at times you have done a laparoscopic or you have completed the laparoscopic in vitro excision of the tumor or the specimen, but for retrieval, either because there are some adhesions, as may have been in this case, or for any technical reason, you have to make an incision to retrieve the tumors, retrieve the specimen intact and safely. Going back to this case of pheochromocytoma, Vikram, if I noticed it correctly, you said the ejection fraction was 48% in this patient, left ventricular ejection fraction.
Yes, sir. Yes, sir. It was 48%.
So, how do you see this issue? Perhaps Dalpati can comment on this. A patient who has ejection fraction of less than 50%, what specific issues we need to be bothered about, and how do we manage such patients?
Yeah. Actually, sir, before that, this hypoxia, actually, there are series where hypoxia predisposing factors also predispose to pheochromocytomas. There are Spanish studies where patients who live in higher mountainous areas where they are exposed to more of hypoxia. They have more of this development of pheochromocytomas compared to persons in the low-lying areas. So that made it to propose this pseudo-hypoxia, hypoxia theory. All these things came. Regarding this cardiac, sir, actually, as you know, that we did a study when I was a resident under Gaurav Agarwal, sir. We did studies, and around 25 to 40% have some form of mild cardiac dysfunction. In that, around 5 to 8% had severe cardiac dysfunction, and these patients had to be treated with alpha blocker for at least 4 to 6 weeks, at least 6 weeks before we take up for surgery, unlike 2 to 4 weeks for normal patients who doesn't have cardiac dysfunction. So the pre-operative preparation for these patients also is quite lengthy for these cardiac dysfunction patients. And with the alpha blocker per se, the symptoms improved over a period of time. The ejection fraction as well as the LV dysfunction improved with the medical treatment over a period of at least 4 to 6 weeks time. Some took at least 8 weeks time. Then it was easier to operate, and it progressed. The recovery progressed post-operatively, and by 3 to 6 months time, most of the patients had a complete recovery of these cardiac dysfunction, which we studied in a prospective study which we conducted when I was a resident there.
Paul, Paul, what's your policy regarding cardiomyopathy and evaluation for cardiac status before operating a patient with pheochromocytoma?
Interestingly, we don't seem to have that many of our cases with significant cardiomyopathy. That's not really a major. I'm not sure what the reason for that is. I mean, I've seen your report from Dhalapathi's thesis. The only one I remember we had a problem was the cardiomyopathy and had a AV block, and we had to put him on a pacemaker during surgery and peripheral. So that was a transfemoral pacemaker was inserted, and that helped us get through the surgery. Otherwise, for some reason, it's a different profile for us. It's very rarely we encounter significant cardiomyopathy. So we use a standard 10 to 14 days protocol, where the times that we have seen an echo with anything less than 55 is quite rare. I'm not sure the reason for that, but maybe something we need to look at. We haven't really closely looked at it. Thank you.
Ramya ma'am has a question for ma'am. Please go ahead.
Sir, I was asking, how do we select out patients whom we should evaluate for dopamine secretion? If there is, how do we select out such patients?
Yeah, it's basically the ones who, you have a malignancy risk, as well as who have an abnormal presentation, either with hypotension or there's no hypertension at all in the presence of a large pheo. I mean, it's a clinical suspicion of malignancy, or somebody who comes with a hypotensive presentation. Those are the two we would add dopamine. We don't do it routinely. It's available when we want it. So that's when, on very rarely, maybe 1 in 20 cases, we check.
Yeah, that's pretty much what it is. But I'm reminded of two patients. One who had bilateral adrenal hyperplasia has been reported as well, and then with a very high suspicion of pheochromocytoma, but her metanephrine and norepinephrine were normal, and so eventually we did her dopamine estimation, and indeed it was raised. She had a unilateral adrenalectomy and then subsequently a contralateral as well. And there was another patient where, again, the clinical index of suspicion of pheochromocytoma in a young patient was very high. Her metanephrines repeatedly were found normal. Eventually, once we did dopamine estimation, and indeed it was high, and this patient had a malignant pheochromocytoma. So malignancy, hypotension, and lack of confirmatory biochemistry in a patient with very high suspicion. Is that correct, Paul, if I may?
That's a good point. Where you're expecting metanophen, you're not getting it. That's the third area to check.
Thank you, sir.
So even though this in this patient, the CT scan pictures you could retrieve are not really ideal ones to discuss, Vikram, but what I gather looking at that scan that you projected, that was like a CT angio film, and you could see bright parasitic vessels coursing into the tumor, even in that fudgy, not so very well focused picture. So that's another thing to remember. If I may request Dr. Archana to tell us about, based on the cross-sectional imaging, when would you consider a patient an adrenal mass to be a pheochromocytoma?
Actually, the picture, whatever is shown here, is basically the problem is setting of window and level. Picture is too bright and at the same time it's blurred also. Though the contrast images, that images has been taken in arterial phase, because you can see the dense contrast in the aorta and the I think SMA arising from the aorta, and the tumor which is seen on the left adrenal gland is very large, showing intratumoral vessels. So that itself suggests like pheochromocytoma is basically and primarily is hypervascular tumor, until unless it is very large and it is having cystic degenerations or hemorrhages. So the periphery which is dense, which basically isodense or hypodense on NCCT is showing dense contrast enhancement. That suggests tumor is relatively hypervascular, and which is tumor having tumoral vessels, hypervascularity in the region of. I am audible because my
Yes,
internet connection is quite unstable right now.
yes, ma'am, you're audible.
It's showing unstable. So here the large lesion which intratumoral vessels that again suggest. And regarding the malignancy in this lesion, unless you demonstrate the invasion in the surrounding structure, you cannot say it is malignant or benign. And as seen in the CT, which has been provided with PET CT, again shows large lesion, which is not showing any invasion into the surrounding organs. So that may suggest it's benign pathology.
Ma'am, there is a question from Dr. Sunil. He asks CT or MRI. What do you suggest in such cases?
Actually, CT is quite informative and it is diagnostic also. MRI is just complementary if you have some problem to find out the invasion into the surrounding structures, or basically it's complementary. So you can rely on CT only.
Thank you.
MRI is not required. Initially, it has been told in the pheochromocytoma shows characteristic light bulb appearance. And that is in large series that may not be seen because of the size of the tumor itself. When there is cystic degenerations and all, you may not see the exact light bulb appearance. If there is heterogeneity, then you cannot demonstrate characteristic light bulb appearance. Rest of the contrast dynamic and everything is same as in CT. So MRI is just another alternative to have cross-sectional imaging.
Ma'am, if I may ask, ma'am?
Yeah, sure.
Ma'am, if there is a metastasis to lymph nodes from a pheochromocytoma, those retroperitoneal lymph nodes, so what will be the CT appearance of those lesions?
CT again shows the characteristic. CT shows large lymph nodes with hypervascularity.
Okay.
Like CT, the metastasis carries the same dynamics as the main tumor.
So can we differentiate those from a multifocal paraganglioma and a metastatic lymph node on CT?
Not exactly. not exactly.
Thank you, ma'am. Sunil sir has a query. Is prophylactic lymph nodal dissection indicated an invasive pheochromocytoma? To the panelists.
Let me take that question. No, you do it only in presence of known metastatic disease, or you have enlarged lymph nodes seen either on imaging or intraoperatively. You sample them, and but prophylactic lymph node dissection is not indicated. It's only when you have either suspected or definite evidence of metastatic lymph nodes. Paul?
Absolutely agree with that. But better to focus on the periadrenal tissue so that you know, whatever lymphatics and fat around, so you get clear planes with the liver, IVC, kidney on the right, and with the pancreas, spleen, and retroperitoneal tissue. So take out, if you have any suspicion, just clear the entire soft tissue. You very rarely will see nodes per se, unless, as said, was already known on the imaging. So I think that's a better strategy.
So the diagnosis of malignant pheo by itself is quite a tricky one. Histology alone doesn't usually suffice. As Dr. Archana said, if there is invasion of contiguous invasion into one of the surrounding viscera or parietal wall, rarely, or else demonstrable metastasis to non-chromaffin cell-bearing structures. So if you have multiple tiny lesions in retroperitoneum or even posterior mediastinum, you are nowhere. It may just be multicentric paraganglioma. But if you have a liver lesion or you have a pathological fracture, as the case that Dr. Paul provided the example of, then you can be sure of malignancy. And this is perhaps, I do not remember what is your reported incidence of malignancy from Vellore. Our reported incidence of malignancy is rather low, proportionately, compared to so many other series which have reported higher than 10% malignancy rates in recent years. Our malignancy rates remain within a range of 6 to 8%, definitely less than 10%. Paul, what is the picture there with you?
Yeah, are you including the paragangliomas?
Yes.
Yeah. Okay. Yeah. No, we are about 12 to 14. Is malignancy.
Thank you, sir. We'll go ahead with the next case. Thank you, Dr. Vikram. The next case will be adenocortical carcinoma, and I'll be presenting myself, Dr. Dilip. Good morning, everyone. Is my screen visible, and am I audible?
No, you have not shared your screen so far. Share the screen, please. Share your PowerPoint presentation.
Yes, once. Now is it visible, sir?
Yes, now.
Yes. 55-year-old male patient, known case of diabetes mellitus type 2 on OHS since 5 years. He presented with a history of decreased appetite for the past 5 months, history of weight loss for about 10 kilos in 4 to 5 months, and history of pain in the left lumbar region since 2 months, which is on and off type, dull aching in character, relieved with analgesics. Otherwise, no other significant history, no GI disturbances, no genitourinary disturbances, no history of vomiting or abdominal distension. On evaluation, was found to have a left adrenal mass and on history taking, no history of increased sweating or anxiety or headache. There's no history of postural dizziness or palpitation or headache or sweating or proximal muscle weakness, no history of gynecomastia, no history of galactorrhea or easy bruisability or striae, no history of renal stones. He had a non-significant past and family history and a personal history. Coming to the examination, pulse rate was 100 beats per minute. BP on supine position was 130 by 90 and on standing it was 130 by 86. There was no postural hypotension. On examination of the abdomen, it was an ill-defined palpable mass in the left lumbar region, not crossing the midline, bimanually palpable but not palpable. It was a restricted mass with restricted mobility. Now on investigating him, we got a 24-hour urinary metanephrine workup as well as the other functional workup done. So in the 24 hours, urinary metanephrine and non-metanephrines were normal, they were not raised. Dihydroepiandrosterone was normal in limit. Overnight dexamethasone suppression test was non-suppressible. However, LDDST came out to be normal. Serum potassium was normal in range. Echo done was normal.
So, Dilip,
yes,
you were showing the neck of the patient's neck and face. Any findings?
No,
why
sir.
So why is this picture put up? What purpose does it serve?
It doesn't serve any purpose. Sorry.
Please do not use patients, especially facial picture. You may have masked the eyes, but please be mindful.
Yes.
This is a patient's right to privacy, and it's unethical to, unless the picture you use is serving a specific purpose.
Yes.
Please do not. Okay, please go ahead.
Sorry, sir. With this, we went ahead with anatomical evaluation, imaging for the left adrenal, left lumbar mass, wherein we got a CT done, CECT contrast enhanced CT scan with adrenal protocol. A well-defined heterogeneously enhancing hypodense lesion measuring 15.4 into 10.8 into 13.1 centimeter is noted in the left suprarenal space. The left adrenal gland is not visualized separately. The absolute washout in this was 64% of the contrast. The relative washout of the contrast is around 38.8%. Multiple small pre-aortic, para-aortic, aortocaval, paracaval, and retrocaval lymph nodes were noted. With this, they gave us a differential diagnosis of pheochromocytoma, adrenocortical carcinoma, and adrenal oncocytoma. The Hounsfield units on plane was on non-contrast CT was 80, on arterial phase it was 85, portal venous is 140, and delayed is 130. These are the images, these are the contrast images where there is a heterogeneously enhancing lesion on the left adrenal space. This also shows some amount of, this is the arterial phase where it shows the heterogeneous enhancement. Here we are able to see the left adrenal mass over the kidneys. With this large lesion and a few suspicious lymph nodes, we went ahead doing a 18 fluoro FDG PET CT scan, wherein we got a hypermetabolic soft tissue mass lesion in the left suprarenal space, likely to be adrenocortical carcinoma, SUV max of 20. There is non-FDG avid solitary pulmonary nodule were noted in the right middle lobe of the lung, which is likely benign, and no metabolically active distant metastasis was noted. The urinary evaluation was done, wherein both the kidneys were normally functioning with adequate drainage. Now, with this background, we took the patient for a patient underwent a open transperitoneal left adrenalectomy, wherein the intraoperative findings was no ascites was noted, there is no lymphadenopathy, no peritoneal or liver metastasis, Multiple flimsy additions of the omentum to the parietal walls was noted. Well encapsulated pale pinkish colored mass arising from the left adrenal gland extending superiorly beneath the spleen and pancreas and abutting the diaphragm posteriorly and pushing the left kidney down and laterally. Increased adrenal surface vascularity was noted. There was a single adrenal vein which was noted and was ligated. No retroperitoneal lymphadenopathy was noted. The weight of the tumor was 1.2 kilograms. On cut surface, it was a yellow fleshy tumor with areas of hemorrhage. Now the post-operative course of the patient, left pneumothorax was detected post-operatively. ICD inserted on the same day and was removed on the day 3 of following expansion of the lung. The drain was removed on post-operative day 2. Wound was healthy and patient was discharged on day 7. Now coming to the histopathological examination, patient it was reported to be a adenocortical carcinoma with a modified V score of 4, wherein there was a capsule breach noted by the tumor cells at places. Clear cell areas were scanned, and mitosis is sparse. That is about 3 to 4 per 50 high power feed. The case is open for discussion.
So there's only a slight question about the CT apparently clearly showed lymphadenopathy and the
Sir, there were non-significant lymph nodes, sir, which were detected.
Okay.
Very small. They have mentioned it as small lymph nodes, so non-significant lymphadenopathy.
Okay. And the planes you said with the
Planes were maintained with the surrounding
kidney and the spleen and pancreas were not a problem.
Were normal, sir.
Could
Even
be taken out intact without.
Both in the CT as well as intraoperative finding. Only a few adhesions, omental adhesions were noted to the parietal wall, not even to the tumor.
Okay, so this is, I mean, generally the point now is for a large, what looks like an adrenocortical cancer is local recurrence is one potential. So usually the problem is in if the inadequate access and if you put too much of pressure or during mobilization, even retractors damage capsular rupture. This is one main problem. The second is if there is local spread into the periadrenal tissue or we know that it goes into lymph nodes. It's always best to take out all the periadrenal soft tissue in that region. So here it will be paraaortic and renal hilar and perirenal, all the soft tissue, so
Would
that
you
you get
suggest
a good clearance.
lymphadenectomy, sir? That is clearance around the tissue.
Yeah, no, as you said, say, actually, to do retroperitoneal lymphadenectomy becomes a much larger operation. You will go all the way down to the bifurcation on the IVC. So it's more about taking the periadrenal tissue where you will get the local lymph nodes. So it doesn't have to be a formal lymphadenectomy is what I'm saying, unless you have, as you said, if there are significant nodes seen on the preoperative imaging, then you will try to do a formal dissection. But otherwise, it's just important to take all the soft tissue. The main thing is to avoid that capsular rupture by having adequate access. So never limit you. If you find that you made a cut and then while mobilizing you're finding it, you're having to do a lot more pressure to mobilize than you would normally, then better to extend and make sure that you do it carefully. I think that's the important thing. The take-home message for pheochromocytomas also, as we discussed last, is that size doesn't matter anymore. So any pheo is potentially malignant. I think that's what's come out of the GAP score actually, and I've even seen a 3 centimeter pheo come back with recurrence and poor behavior. So again, it's the periadrenal soft tissue that you need to make sure you get. It's not just like taking the nodule out with the adrenal. It's about taking the entire soft tissue in that region with all the planes intact and no rupture. I think that's a very important thing for adrenal surgeons. Just want to make that point there.
Yeah, I fully agree. So you do not dissect the tumor away from the body, you dissect the body away from the tumor. That is to ensure that you do not breach that plane at all, and you remove at least some part of periadrenal soft tissue or peritumoral soft tissue. And as far as the lymph nodes are concerned, even now we are now talking of suspicious nodes, whereas what you could have achieved by retrieving at least a few lymph nodes for the pathologist to examine, you would have known for sure that they were only reactive lymph nodes. So it makes sense. I fully agree with what Paul said. There's no role for, no scope for doing a retroperitoneal lymph nodal dissection, a formal one, but a few nodes which can be retrieved easily with the peritumoral tissue should have been taken out and specifically asked for being examined by the pathologist, either intraoperatively or later on. So that would have made us wiser. And another comment, Dilip, and for all my friends, younger friends, do not include any patient identification, anything which makes this picture identifiable for the patient. How did having the patient's name in the gross pathology picture makes us any wiser? How does it help? So you have to mask all such identifiable things in the presentation.
Sorry, sir. Sir, Ramya ma'am has a question. Ma'am, would you want to go ahead?
Sir, I was asking, would you have preferred for such a large tumor thoracoabdominal approach or anterior approach for resection of the tumor?
Yeah, if I'll go first, I think again it's surgeon preference. What we have found over time is the thoraco. When you cut into the thorax, that's the most painful. So whether it's approaching a large retroperitoneal thoracotomy or adrenal thoracoabdominal, I very sort of reluctant to open the thorax unless necessary. And I've found whatever the size and all that, a good extended subcostal triradiate incision. On the right, you can mobilize the liver. On the left, you can take out any large mass. We have never been challenged to open the thorax. That's our experience. But again, it's an individual decision and approach. That's the guideline I would give. Yes, Gaurav, what do you feel?
I agree. It has to be individualized. I do not prefer doing thoracoabdominal for majority. There would be specific instances where if you, for example, there's a possibility of invasion to the retroperitoneum parietal wall, a really massive tumor. This is not a massive one. I mean, anything which is kind of filling up whole of the quadrant or something, then perhaps. Or if there's invasion of the diaphragm, multiple viscera in the vicinity. But majority of these cases, we are able to do just with a liberal abdominal approach and usually transperitoneal. I don't see much value of doing retroperitoneal approach for such large tumors.
So which cases do you select for adjuvant radiation in case of adrenocortical carcinoma?
Maybe one of the others can, Dalapati, you want to take that?
Sir?
Your approach to radiation post ACC resection.
We did give for a few cases, sir, when there is some recurrence or the residual tissue is left in the tumor bed, radiation. But I don't know about the efficacy of this radiation. And these are all actually radiation and chemotherapy. It's of experimental value rather than doing good to the patient as such. Only maybe surgery might be the better option. And the radiation, though we have given for few patients, the survival did not change, either the radiation or the chemotherapy which have been given for these patients. So we are not much in favor of this radiation for these tumors.
Yeah, I would agree with that. Yeah, Gaurav.
Uh, sir is on another call, sir.
Sorry. Something
Okay, no problem.
COVID core group related queries which I've been avoiding for some time. Sorry. Can you please repeat that, Paul? I was distracted.
Post ACC resection, your approach to external beam radiation, adjuvant radiation.
Yes. Again, it's one thing that has kept us guessing for a very long time. There are no specific studies which can guide you. There are no recommendations made to best of my information. So my little bit of logical thinking is, if you are not sure about doing a R0 resection, either because the disease itself or because the procedure itself, I mean, you end up breaching the capsule, and you can actually breach the capsule at times. This patient itself, there was some hint on histology that the tumor capsule was breached. In those areas, you can err on the side of over treating them, and radiation, to it is anybody's guess how effective it will be. But we have subjected such patients with really large tumors where either there's been a tumor breach or R1 resection, microscopic residual disease, but it cannot be advocated as a routine.
Yeah, thanks. I think there's a question on adjuvant mitotain. That's a good point. It's the only therapy so far that's been shown to make a difference. Our general policy has been, after using mitotain, it has a lot of side effects. And if you have a situation where large ACC you've taken out, there's no obvious met, and you wanted to use it in adjuvant situation, we find that the impact on quality of life is quite high. And even invariably the patients actually discontinue or lose the dose to inadequate levels. So our policy now has been, let them live a reasonably normal life till the recurrence occurs, and then we can use it in a therapeutic setting. That's been a change in strategy after experience with using it purely adjuvant situation. You can share yours as well.
Actually, sir, this mitotain, the procurement of mitotain is a big problem, sir. We don't get mitotain. That's a big problem. Actually, we tried for two, three patients. We could not get the mitotain at all. Actually, some company in Bangalore, something like that, they have to get it from that. Though it's of doubtful value, this mitotain is, though as you said, there is a lot of toxicity, narrow therapeutic range, and still we have to slog it to get the mitotain for making the patient to suffer.
I agree, Dalpati. It's not easy for the patients. It is expensive. We've been able to get mitotain through three sources. In our recent few patients I can recollect. There's a supplier from New Delhi. There's another which Vellore Bangalore connection, and there's a Bombay hospital pharmacy, or a pharmacy close to Bombay hospital. If Ritesh is connected, perhaps he can educate us more about that. But then the cost varies a lot. There's one recent patient from a big corporate house. I'm sure many of my residents would remember him. We operated him about 3 years ago. He's a top executive in a corporate setup, and
Yes, sir.
he's been able to import it directly through an importer. So the government of India has a policy of allowing import of drugs which are called orphan drugs or rare disease drugs. So you can give a prescription, you have to fill a lot of forms, but the patient can directly import, and that is how he's procuring, and that's the only way he can get a bill. And there are certain other possibilities of getting it through the gray market, where the patient will not be able to get a bill. uh, Going back to the indications, so three settings. Adjuvant setting, the only worthwhile studies to look at are some studies from Brazil, southern Brazil, where in childhood adenocortical carcinoma, there was a report of utility of adjuvant mitotain. But by and large, the utility has been shown only for two scenarios. One is unresectable advanced cancers, where there have been anecdotal reports of almost complete resolution as a preoperative or as the primary therapeutic strategy. or in recurrent and metastatic disease, as Paul said, and that is what we usually do. But there are a few patients where we had resorted to a R1 resection, a residual or metastatic disease, where we have used mitotic. But majority of patients they find it difficult to procure and afford it.
Yeah, so Dalapati, if you have trouble contact, I think I can put you on to somebody who need the mitotain. We had, in fact, when Pooja was here, we had an interesting, was operated outside, came with a recurrence, and he had actually significant lymphadenopathy, and we did a complete clearance of the retroperitoneum with the nodes were going all the way down into the pelvis. So I cleared right up to the bifurcation, but we couldn't get the whole disease out. So we knew he had residual disease. And we put him on mitotain, and he went on for almost 3 years with residual disease, and he improved quite a bit. I must be surprised. One of the stunning experiences I had was I was traveling in Kerala, and then somebody tapped me on the shoulder in the station and found this guy we had operated 1.5 years ago, almost lost to follow up. He's there with his family holidaying. So that was the extent of his improvement. Then he went on for a couple more years and then succumbed to recurrence. So you have to individualize. I think mitotain, that's the key word is individualize, but it can be useful. So do try and get it when you need it.
Thank you.
That reminds me of a physician, an elderly physician, classmate of one of my teachers from my medical school days. As he comes from a hill state, and it's been at least 16, 17 years since his left adrenocortical carcinoma surgery is still going strong. And then you ask yourself, was the diagnosis right? Did we misdiagnose? Well, in that patient's case, there were metastatic lymph nodes. So I mean, it's as solid a diagnosis as possible. Let's not lose track of one important message this case has also given us. The patient had a pneumothorax postoperatively. So just a reminder, perhaps we all do it in patients who have undergone suprarenal mass surgery, laparoscopic or open, especially when it's a large tumor, as a routine during surgery and then immediate post-op period, look for pneumothorax. Do a chest X-ray bedside. If in doubt, put in an ICD, because this itself can be a life-threatening complication. Any experience with you, Dalpati or Paul?
Fortunately, we didn't have pneumothorax, but actually 2-3 cases we had to resort to thoracoabdominal incision for these huge tumors. That's one of the few indications where we would go for thoracoabdominal incision for these huge adrenocortical tumors had to be sorted.
I've had a pneumothorax with a retroperitoneoscopic approach, where the lateral port has punctured the pleura, but open we have not had.
So that's perhaps fortunate. We've had a few cases of pneumothorax, both detected intraoperatively and, as this case illustrated, detected postoperatively. We have had a couple of cases of laparoscopic surgery for large tumors, mostly pheochromocytomas, where we have created a hole in the dome of diaphragm, repaired it intraoperatively. In fact, one video that was presented by us in one of the conferences. But don't lose track of this possibility. This is a known complication, pneumothorax, and then we must take care of it. Any other questions?
Thank you, sir. We'll move on to the next case, sir.
Yes.
Yes. So the next case will be presented by Dr. Abhishek, MCH SR, senior resident, second year. Abhishek, sir, over to you. Please share your screen, sir.
Yeah, is my screen visible?
It's yet to come on the screen, sir.
It's showing that your screen sharing is paused. I don't know the reason for this.
So just exit, stop
Okay.
screen sharing and share it again, sir.
Okay. It's again showing the same thing as screen sharing is paused.
Just go to the top of the window and press that resume sharing, sir.
Yeah, I'm clicking that. Nothing is happening. Wait, let me try. Shall I exit and start again?
Just
Let me leave and.
no, sir. हाँ, sir. वो शेयर कर रहे हैं लेकिन यहाँ पे दिख नहीं रहा है, वहाँ से तो उनका पास में शेयरिंग दिखा रहा है। समझे को कह देंगे कैंसिल करके फिर से शेयर करते हैं। There is some technical issue. We'll just sort it out. Give us a minute, please. I'm sorry for the delay. Ma'am, till the this one gets corrected, I wanted to ask Archana ma'am one question regarding the previous case.
Yes.
Ma'am, in that it said that it is a large tumor with subcentimetric lymph nodes in the multiple groups like para-aortic, aortocaval. There are multiple groups. So should we take it as suspicious or should we still take it as negative for malignancy when it comes to CT findings?
That depends on characterization of the lymph node. Can you tell me the CT findings, the size of the lymph node, whether the fatty hilum was preserved or not, what was the contrast characteristic after giving contrast medium on CT scan? That all depends. You can say it's involved or just it's significant or not.
Okay, ma'am, but that was not mentioned, I didn't believe, ma'am, in the CT scan. But जब ऐसा सब मतलब if all these characteristics are present, then we definitely think, even if it is a subcentimetric lymph node, that we think that it is a malignant.
Yeah. In most of the other lesions also, if they are clusters and the fatty hilum is not adequately seen, then you can suggest this malignant involvement of the lymph nodes. And one more point I want to make it clear, like in this CT scan, while you were reading CT scan, you told there was absolute percentage washout was more than 68%, I think.
Yes, ma'am.
and relative percentage washout was again more than 40%, around 40%, 38
Around
or
40%.
something.
Yes, ma'am. It was borderline.
38.8%.
Yes, ma'am.
I want to highlight one point. If the contrast on contrast images, the CT value is more than 120, maybe 140 or 150, the significance of this washout criteria is not there.
Okay.
You cannot adequately differentiate in adenoma versus malignant lesions. In this case, you have shown the contrast, Hounsfield unit in contrast imaging was more than around 140. Around 140 you have shown.
Yes, ma'am. Yes, ma'am. It
So
was
in
around
this
140,
case,
135.
yeah, in this case, absolute percentage washout was 68 and relative was around 38, around 40. So
Yes,
it was, you cannot say it is adenoma only.
Mm-hmm.
Same.
Hello, ma'am. Hello, ma'am. नहीं नहीं नॉर्मल पीसी की तो उनके पास है हाँ उनके पास
Dilip, can you hear me, Dilip?
Yes, sir. Vishwak, sir, I am able to hear you.
Yeah, like we have a poor internet quality here in the active quarantine area. That's the reason why Abhishek couldn't share his screen.
Okay, sir.
Maybe you can proceed with the next presenter.
That was the last presentation, sir.
Okay.
Dilip, you can ask him to mail his presentation to.
Yeah, I have already mailed. I have already mailed to NNGN and Vikram both.
Ma'am,
Okay.
he has already, ma'am. We are downloading it.
Okay. And we should also appreciate that 3 of our residents are in active COVID duty and still they are making presentation to just finish. So we all appreciate your efforts.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Is there any other queries from anyone regarding the cases so that we can learn from our distinguished faculties so that till the technical problem is rectified?
Can we get a short summary of this adrenal protocol for the CT regarding adenoma, malignancy, FIO from Dr. Archana? It would be useful for us. We repeatedly getting asked these questions.
Archana, ma'am?
Okay. Yeah. if some patient any request come for adrenal imaging, what we are initially doing, we are taking patients first for NCCT, and we used to include the diaphragm because you are supposed to be excluding the extra-adrenal lesion in the abdomen. So it is a request for abdominal imaging. We are taking scan from the diaphragm till pelvis, till pubic symphysis. Or if on previous
Archana ma'am, you're not audible, ma'am. Archana ma'am, I think we've lost connection with Archana ma'am. Any other queries where we can ask our distinguished faculties from other institutes? Yes. Okay. I think Dr. Abhishek has joined back. He's shared a screen. Dr. Abhishek, will you go ahead with the presentation?
Yeah, you have to forward the slide because.
Yeah, I'll do that. I'll do that. Please let me know when I have to change the slide.
Yeah. Okay. Thank you.
Please go ahead. Dr. Abhishek, second year MCH, sir.
Yeah. Good afternoon, everybody. Extremely for the delay. So I'm going to present this case on ACTH independent macronodular hyperplasia. So this 53 gentleman, known victim stays on oral hypoglycemic and was well controlled with HbA1c of 13.8.
Sir, please speak close to the mic. Please speak close to the mic.
Am I audible?
Yes, sir. Yes, sir. Please go ahead. Please speak close to the mic.
Yeah. He is also hypertensive since 8 years. He was controlled. He has a history of obstetric sleep apnea. Also had a history of dyspnea since 2 years and off, and it had influenced over the last 2. He also has a history of muscle weakness, tinea oculis, this libido, and history of weight loss from 90 to 78 kg last 2. Next slide, please. Yeah. So he was for these complaints he was being evaluated elsewhere, and he underwent a CT scan, which showed a left upper lobe, lung lobe head venous mass, along with adrenal mass, and so then he was referred SGPG-IMS for the management. Next slide. On retrospective, on further taking, there was no control of abdominal easy bruising, achy, no history of any renal stones or behavior abnormality or fractures, no history suggestive of headache, visual blurring, seizures, memory loss, or cramp, no paroxysms of sweating, palpitation, anxiety, and no history of stools, vomiting, burning, exudation. Next slide, please. He has his pulmonary course in 2006, for which he took it for 9 months, and he's a non-smoker. He was alcoholic for around 20 years and left over the past 6 months. Family history was not contributed. Next slide, please. Yeah, on clinical examination, he had a BMI of 28 kilogram per meter square, facial plethora, acanthosis, and obesity present. However, there was no stria, petechiae, or easy bruising. There was extensive tinea over groin and chest. On examination of respiratory system, bilateral V's were present. And ophthalmological examination was done, which showed a right posterior subcapsular cataract. And motor system examination showed a proximal muscle weakness. Next slide, please. So he was on evaluation. He was found to have a CLC and was furnished antibiotics, which decreased, came normal. Next slide, please. And he was also evaluated for cortisol secretion. So the 8 AM cortisol, 11 PM cortisol, ONDST, all were unsuppressed, and even LDDST was unsuppressed, and ACTH was markedly low. Next slide, please. Serum DHES was low. However, 17-hydroxyprogesterone was high, and rest serum aldosterone, TSH, and prolactin were within normal limits. Next slide, please. He was actually initially being managed in the endocrinology department, and CT abdomen was done, and it showed a bilaterally enlarged adrenals, which showed multiple nodules. Largest nodule was on the left side, which left measuring around 3 centimeters, and it was suggestive of macronodular adrenal hyperplasia. Next slide, please. So they got a CT-guided lung biopsy from the lung mass, which was suggestive of inflammatory cell infiltrates, comprising predominantly of volumes, and there was no evidence of any fungal organisms or any granular pathology. And we also got sputamation done, which was 3-4 gram positive high and a bacilli. Please. So based on these findings, a diagnosis of primary ACTH independent bilateral macronodular adrenal hyperplasia was made with Cushing syndrome and lower respiratory tract infection. Preoperatively, he was managed with IV antibiotics and optimization of chest, bladder, and blood pressure, and was then taken up for laparoscopic bilateral adenectomy. Next, please. So the operative procedure performed was laparoscopic converted to terminal hand-assisted bilateral transperitoneal adenectomy. The procedure was converted to hand-assisted on grounds on the right side. There was a failure on the top of the adrenal gland due to a grossly enlarged liver, which could not be retracted. And on the left side, there was a failure to progress on account of adrenal nodule in very close vicinity to the renal hilum, and it could not be easily dissected off. Next slide. So operative findings, that both adrenals were enlarged and contained multiple nodules of varying sizes. On the right side, the adrenal gland measured 11 to 7 centimeters, a weight of 81.5 grams. On the left side, 12 into 10 centimeters with a weight of 145.5 grams. Next slide, please. So this is the cut section of the gross specimen. We can see multiple golden yellow nodules on cut section, which shows the lipid content. Next. Post-operatively, he had an uneventful course. Initially, steroid replacement was given intravenously and then shifted to oral. And drain was removed on post-operative day 5. Patient was discharged on post-operative day 7 with steroid replacement. Next slide, please. Histopathology showed a bilateral adrenal macronodular hyperplasia. I want to add one more thing, that the patient also had, since this was a case of bilateral adrenal hyperplasia, the pathophysiology of this is basically related to expression of hormone receptors on the surface of adrenal glands. So there are certain receptors which are expressed, either eutopic receptors, which are expressed on at a higher level, or certain heterotopic receptors, not normally expressed, but are expressed in these cases. So these receptors are such as gastrointestinal peptide, vasopressin, LH, FSH, and TRH. So we have certain protocols for evaluating these receptor status, and these receptor status evaluation was done in this case. Hello. Yeah. So these receptor status was evaluated in this from the endocrinology department, but unfortunately, I don't have the reports what they found out. So now the case is open for discussion. Thank you.
So, Abhishek, are you aware of what is the post-operative status? What is the he would be on prednisolone?
Yeah, he's on Visolone 5 mg 3/4 and 1/4 BD, and on immunocorticoid 100 microgram OD. Lastly, recent update I don't have, sir, actually, but this was the thing which I know.
So because the ACTH levels were always, they were assessed thrice and on all occasions they were low, that is helpful to a large extent. But what was the diagnosis of the lung lesion? What kind of
That
lesion?
was probably a pneumonic consolidation, sir, because gene expert and tubercular pathology was evaluated for, but we couldn't find anything like that. And since the biopsy also showed mixed inflammatory cell infiltrates, and his TLC was also raised initially when he had come. So most probably it was a pneumonic patch. And it progressively improved after IV antibiotics and spironolactone, and then we took him up for surgery.
Okay. Talpati, what's your experience with macronodular hyperplasia causing Cushing syndrome, ACTH independent macronodular hyperplasia?
Actually, we don't have any experience with this AMAH. Only PPNAD we had a case. AMAH we have not seen a case till now, sir.
We have had a few. I can't give you exact number, but we have had a number of such cases over a period for last 3 decades, maybe close to 5, 6 or such, but slightly higher number of primary pigmented nodular hyperplasia, including at least 3 of the ones which present with the typical atrial myxomas and PPNAD, the Carney complex.
Sir, I wanted to ask about the role of unilateral adrenectomy in such cases.
Actually, these cases are associated with McCune-Albright syndrome, sir, if I am not wrong.
Yeah, yes, McCune-Albright.
Yes.
They have if I'm not wrong, it has a bimodal age distribution, and in younger patients, they are associated with McCune-Albright syndrome. I think so.
Yes.
So,
yes.
Anjali ma'am, your thoughts about this, ma'am?
Actually, these mild cases of AMAH, what I remember is they treat with medical treatment also, sir, because of this gastrointestinal polypeptide, if I remember. They use propranolol, all these drugs for very mild cases of these AMAH.
Yes.
Also, I
Yes,
think.
so in mild cases, if we find that GIP is expressed, we can use octreotide. If beta adrenergic receptors are expressed, we can use beta blockers. Similarly, if vasopressin receptors are expressed, we can use that blockade. GnRH receptors are if they overexpressed, then we can use GnRH agonist and antagonist.
GnRH,
but then again,
use, I think.
Yes, but then again, sir, they are only for control of mild symptoms.
Yeah, mild cases.
Related to Cushing syndrome.
Surgery will be the treatment.
Yeah.
Right?
Yes, or we can use it to control the symptoms before surgery, and then we can proceed for surgery once the symptoms are of Cushing syndrome are relatively controlled. So they can be used there. Yes.
I remember this AMAH, actually, they have a very varied presentation in CT, I think. They might have a very large bilateral masses to even undetectable adrenals also, or very small adrenal glands, just like a normal adrenal gland also they can present, I think. So in this,
yes, absolutely, absolutely.
in this case, we had bilateral adrenal tumors, right side more than the left, and a bunch of grapes appearance also they say in CT, this AMAH also, I think.
Yes, sir. If there are multiple nodules, then they may show that bunch of grapes.
Sanjay sir has a comment to make. Sanjay sir.
Yeah.
Hello.
Yes,
Yeah, this is Dr. Sanjay here, Assistant Professor Surgery from. So I have a comment and a query. It was a very good presentation, and it was rightly managed with bilateral adrenalectomy because he had overt Cushing syndrome and he had bilateral nodules. So, and receptor status could have played a role in medically managing this patient, as those patients who have aberrant receptors, and even though if they have overt Cushing syndrome, they can be managed with medical therapy. So the most centers follow this algorithm. They first evaluate the aberrant receptor, and if it is positive, the case is managed medically. If it is negative, then based on the symptomatology and cortisol level, they are managed with unilateral or bilateral adrenalectomy. And good case presentation, Abhishek.
Thank you, sir. Thank you so much.
I think somebody did bring up this possibility of staged or unilateral adrenalectomy in such cases. Dalpati, would you like to discuss that? Or perhaps Dr. Anjali, or I can see other surgeons who are connected.
Anjali ma'am.
The problem with bilateral adnectomy is actually we lose patients with adrenal crisis. That is the big issue in our setup. They don't follow these stress dose of steroids, whatever. They need to be actually counseled from the day we see the patients, that they need to be on steroids in the post-operative period, and they need to take stress dose of steroid. That's the big issue with these bilateral adnectomy patients. Rather than treating them and following these patients, a very, very big issue. So as far as possible, if possible, if confined to one gland, then we can get away with a unilateral adnectomy in these type of cases. And if it's a florid cases where there is no other resort, then we have to go ahead with a bilateral adnectomy in these type of cases. That's what my personal take will be.
Anjali ma'am, your thoughts about it?
Excuse me, please, sir, can I say something? Actually, I assisted in this case.
Sunil sir, Anjali ma'am has raised hand. I'll just get back to you. Sunil sir, please go ahead.
Anjali ma'am can say.
Please go ahead, sir, Sunil sir.
Okay, this patient also had severe hypercortisolemia and had severely diminished bone mineral density. He was quite fragile patient. So it was a joint decision which was taken with endocrinologist and with patient and his relatives to perform a bilateral adrenalectomy. We did evaluate the patient for receptors also.
So your voice is not clearly audible. Can you just speak near the mic, sir?
Okay.
So that it can be a little bit louder.
So the patient was extensive evaluation was done for the receptors also, and they have a full protocol for that evaluation. So that was followed, and receptors are positive in many cases, but ultimately we did, but that turned out to be more for an academic purpose only. So ultimately decision was taken for a bilateral adnectomy, and the reason was severe hypercortisolemia only. And just one thing that I wanted to just share was that because these lesions are quite nodular and a bunch of grapes appearance, as sir also pointed out, while operating on this patient laparoscopically, it was very difficult to just get to all the nodules in a very fatty abdomen. So I would just like to ask the panelists that how to approach a patient of Cushing syndrome when abdomen is so fatty, and particularly when there are multiple nodules and you may not get to remove all those nodules. So that's why hand-assisted technique was used in this patient, because we were not very sure whether we'll be able to remove all nodules by visual inspection alone.
Am I audible now?
Yes,
you are.
Yeah, actually this thing, because in between probably my audio was not working. So I just want to contribute to the discussion. Like, as we all know, and we have been discussing, these are very rare cases. So far as our this thing, globally only 200 odd cases have been reported. And that time Abhishek reviewed it very nicely. And so far as our center is concerned, this was the second case for us. And as had been rightly discussed, there are various treatment options, and that depends on the size of adrenal gland and patient's biochemical profile. Unilateral adenectomy and as well as receptor blockade, depending on which aberrant receptors are expressed in these tumors, could be offered, like propanol and other GP inhibitor and octreotide as well. So far as this case was concerned, initially we thought we may go ahead with unilateral adenectomy, and this thing probably left side there were larger nodule. Then this thing in endocrinology team also discussed with this. I'm just slipping, that name is slipping from my mind, from NIH. He's the one who has reported the largest series. And since this patient had episodes of recurrent infection and pneumonia in past, and he was predisposed to the infection, so a decision was taken that he would be benefited better with bilateral adenectomy rather than going ahead with unilateral adenectomy. So that's all I have to contribute to the discussion.
What Sunil raised is a definitely a issue which poses a lot of problem to surgeons. Patients with frank Cushing syndrome, overt Cushing syndrome with large amount of retroperitoneal fat, surgery is never easy, be it laparoscopically or even open one. You have to search for and remove the adrenal gland within a lot of perinephric or retroperitoneal fat. And the way I feel it is best approached is that do not try to look at the adrenal gland itself. You have to remove the entire suprarenal fibrofatty tissue, which will have the whole of adrenal along with it. And trying to do a partial adrenalectomy in such a scenario is almost impossible laparoscopically or open wise. So bunch of grapes or whatever it may feel, but fortunately it's all within the adrenal gland. Can I request the others who are not speaking to please keep their mics muted? There's one.
Actually, sir, doing a open adenectomy is more tiresome than doing a lap adenectomy in these cases. Actually, with a laparoscopic technique, we can have a better visualization and magnification, which will help in removing the whole of the adrenal gland. Whereas in open adenectomy, it will be really a big problem. Opening the abdomen, finding the adrenal gland, as well as removing the entire adrenal gland. Open adenectomy would be a very big challenge compared to laparoscopic technique. Actually, these patients would benefit more with the laparoscopic adenectomy than open adenectomy because wound infection, the healing, everything is a problem. So these patients are ideally suited for laparoscopic adenectomy and open adenectomy. Unless otherwise, we have to. It's always a challenge to both the surgeon as well as for the patient.
Yeah, I completely agree with Dalpati that visualization is definitely better with laparoscopy, and wound-related complication and convalescence is also better. Means whether you want to resort to laparoscopic and retroperitoneoscopy would depend on surgeon's choice.
Agreed. And I mean, we are not operating as many of those patients now as we used to. Patients who had failed after transfemoral surgery for Cushing's disease, or those who had unlocalized disease in light of ACTH dependent Cushing's requiring bilateral adrenalectomy. And even in that experience, it seems somewhat better to offer these patients laparoscopic surgery rather than open surgery. And
ये लास्ट हुआ है
once-
अभी अंजलि मैम को होगा उसके बाद हम अंजलि सॉरी मलिका मैम का
If you can keep the mics off for those who are not. Please mute your mics, please.
मेरा तो
Please mute your mics, please.
iPhone.
Uh,
Okay. So I think, is there any other issue to be discussed?
Sir, there's one question from Dr. Kunnikudi Karunakaran. Experience of Nelson syndrome after bilateral adrenalectomy and post-op follow-up in these cases.
Yeah, that's more of a problem with bilateral adrenalectomy for Cushing's disease, ACTH dependent, and usually pituitary disease and nothing, and no other. We have had a few patients who have come back with Nelson syndrome. I cannot be certain about whether these were progressive pituitary tumors, primary pituitary tumors, or Nelson's per se. But because those are managed primarily by endocrinologists and neurosurgeons, I do not have much follow-up on those patients. But yes, we have had a few patients. Anybody in particular, anybody in the panel has any more specific experience? May please contribute.
Sir, there's a comment to be made from Dr. Sanjay. Dr. Sanjay, please go ahead.
Yeah, no, actually, I wanted to comment on that question only. But Gaurav sir has rightly said that Nelson syndrome is not seen after bilateral adrenalectomy for this disease because pituitary is intrinsically normal.
Yeah, thank you, sir. Sir, I think with this we'll close the session and we'll come back at 2 o'clock for the next session, which is on pancreas men syndrome. Thank you all. Thank you all the panelists for such a wonderful enlightening session. Thank you all. We'll join back at 2 o'clock for the next session. Thank you.
Thank you.
Yes, much.
Next session will start at 2 o'clock exactly. Thank you.
Good afternoon, everyone. Welcome to post-lunch session number 5 of this 4th cyber endocrine surgery workshop. On this session, we will be discussing about all endocrine syndromes. And panelist of this session, Professor Deepak Abraham sir from CMC Vellore Endocrine Surgery Department, Dr. Mukta Bakshi, Consultant Endocrine Breast and Oncosurgery, Fortis Hospital, Noida, Dr. Gun Johari, Assistant Professor in KIMS Hospital, Bhubaneswar. They have already joined. And also there are other members already connected to us. So we'll go ahead with the first case, which will be a case on BHL that will be presented by Dr. Farin, Senior Resident Endocrine Surgery. So Dr. Farin, you can start with case presentation.
Good afternoon, everyone. Am I audible, Sushant?
Yes, Farin, you are audible.
Presenting 10-year-old boy presented to us from Orissa with complaints of generalized body rash for the last 4 months, palpitations and sweating for 2 months, abdominal discomfort and vomiting for 2 months duration. For these complaints, he was admitted in a pediatric ICU setup at Orissa and found to have high blood pressure recordings of 240 by 140 millimeters of mercury and was admitted with hypertensive crisis. He was on further investigation, he was found to have bilateral suprarenal masses. He was stabilized with labetalol infusions followed by 3 antihypertensive drugs when he presented to us. There was no history of constipation, melena, or bleeding per rectum, no history of fever, hematuria, or dysuria. No, there was no history of exertional dyspnea, syncopal attacks, any proximal muscle weakness, abdominal strain, facial hair, central obesity, acne, or diabetes. There was history. He was a single child of a non-consanguineous parents. He did not. There was history of sudden death in family. That was his maternal uncle died at the age of 30 years, cause of which is not known. There is no other significant history in the family. On examination, his pulse rate was 110 per minute. It was regular in rhythm and normal in volume. All the peripheral pulses were well palpable. His blood pressure was 130 by 80 millimeters of mercury in the right upper limb in supine position. On examination of the neck, there was no neck swelling. On examination of abdomen, there were no palpable masses or organomegaly. Bowel sounds were present. Other systemic examination was normal. He was investigated with 24-hour urine metanephrines, which were found to be normal. However, norepinephrines were high. The serum calcitonin was normal, 8 AM cortisol was normal, 17 alpha hydroxylase levels were normal, and dihydroepiandrosterone levels were also normal. Echocardiography was done, which was normal, and ultrasound of the neck, which showed bilateral normal thyroid and isthmus, with few subcentimetric bilateral cervical nodes with maintained fatty hilum. An MRI brain, which was done at Orissa during his hypertensive crisis, was reviewed here, which showed subacute hematoma in the left gangliocapsular region with multiple blooming foci in bilateral basal ganglia suggestive of old hemorrhage with intraventricular bleed. A fundoscopy was done, which showed a bilateral resolving macular star. He underwent triple phase CECT abdomen and gallium-68 Dotanoff PET CT. On CECT abdomen, there were well circumscribed ovoid masses in bilateral suprarenal regions, and both the adrenals were not seen separately. The lesions were intensely enhancing, and they had cystic and necrotic areas which were better visualized on the venous face. And the left suprarenal mass was actually bilobed with an anterior and a posterior area to it. Plus, there was also a lesion which was seen separately just in front of the IVC. Probably this was the lesion, just anterior to the IVC. It was 1.5 into 1.6 centimeter. This particular lesion was not Dotanov avid on the Dotanov PET CT. Only bilateral adrenal lesions were picked up on the Dotanov PET CT. He underwent open transperitoneal left total adrenalectomy with right adrenal sparing surgery and pre-caval intrarenal paraganglioma excision. Intraoperatively, there were two tumors which were present in the left suprarenal region involving both the limbs of the adrenals. And on the right side, the lesion was mostly arising from the medial limb, and the lateral limb and the body of the adrenal was mostly normal. Also, there was another mass lesion of 2 into 1.5 into 1 centimeter, which was present in the precaval region inferior to the third part of the duodenum, about 5 centimeter inferior to the right renal vein. On grossing, these were mostly fleshy lesions with necrosis and cystic areas with it. The final histopathology was reported as bilateral adrenalectomy specimen with bilateral pheochromocytoma, PAS score of 0, and the right precaval paraganglioma, which was consistent with the findings of paraganglioma. Post-operatively, he was monitored for 24 hours in ICU, requiring noradrenaline, following which he was shifted to the ward. In the post-operative period in the ward, he was started on oral medications and oral diet from third post-operative day. He required single antihypertensive drug. And he was started on oral, initially he was on injection hydrocortisone infusion, which was gradually tapered, and he was started on oral hydrocort and discharged with hydrocort and fludrocortisone doses. He was discharged on post-operative day 10 with a normal urine and metanephrine and a normetanephrine report. Eventually, 1 month later, his pediatric endocrinology has been involved with the patient and has been tapering his doses of and titrating his doses of oral steroids.
Okay, very nice presentation, Dr. Farim. Any question for this? Case is open for discussion. Dr. Farin, were there any lesions in pancreas or kidney?
No, there were no lesions in the pancreas or in the kidneys, both on the CT and in the Dotanov PET CT, as well as in during the surgery on visual inspection, there were no lesions anywhere else. His VHL gene was positive, and for that, an MRI brain, which was already done, was not suggestive of any cerebellar lesions. And an ophthalmoscopic examination was done, which ruled out any retinal hemangioblastomas. Abdominal CT also covered his pelvis, so there were no epididymal lesions, and there were no pancreatic cysts. Since he was the only child, his parents were counseled regarding further genetic workup and counseling for further pregnancies in future.
Okay. We have Professor Deepak Abraham, sir, from CMC Vellore Endocrine Surgery Department. Sir, any comment regarding this case, sir?
Yeah, I think can you hear me?
Yes, sir.
Yeah, okay. I think the most significant clincher is actually that first slide which said 10-year-old child. So when you have a syndromic presentation and you have a 10-year-old, your first diagnosis in syndromes is VHL. So if you had a age presentation of about 40, you would think more, okay, it could be MEN, it could be other presentations too, or SDH. The neurofibromatosis, which is the other syndromic presentation, is a phenotypic presentation because you make that out by the lesions on the skin. So the VHL diagnosis, though, can be very dramatic. We've had children or in the 20s presenting with bleed because of the medulloblastoma having a rupture, and often having to have immediate or life-saving craniectomies and decompression before we actually go into operate, because they still have to operate with the FIOs inside. So I think the crucial thing is the age, and I think you've done a history which covers all aspects of the various areas where a VHL can present, and especially there was a MRI which showed a bleed. So was that a hypertensive bleed which admitted in the ICU?
Yes, it was a hypertensive bleed. The child was admitted with a hypertensive crisis at presentation.
Yeah, so that's the other thing to consider, whether there was a medulloblastoma, which is the cause for that bleed. But apart from that, I think the management aspect is appropriately done. The issue about the VHL gene is a large gene. So when you sequence the VHL gene, it's a challenge for the laboratory personnel when they have to sequence the gene. It's easier to do the MEN2 or the RET as opposed to doing the VHL. Even larger is the NFL, so which is NF1, which becomes even more difficult. And as I said, it's a phenotypic presentation. Have you got any questions? Are you putting through, Fareen, in your question and answer now, or do you sum up and try to say what are the learning points here?
Yes, sir, essentially.
You could ask the other panelists. I think Mukta is on the team, on this panel today. And the other people, I'm not very sure, but Gunj is there. I think Gunj was somewhere around. So she is also on the case.
Doctor,
Hello?
Mukta Bakshi ma'am is on.
Yeah, can you hear? Can you hear me?
Yes, ma'am, yes.
Okay, okay. Okay, very nice presentation. Actually, everything has been told by both of the Dr. Abraham and the presenter. Basically, I just want to know that what is about the hypertension which has happened after the follow-up of hypertension after removal of the adrenals, bilateral adrenalectomy.
Initially, the patient was required high doses of noradrenaline to maintain his blood pressures, and eventually, when the requirement of noradrenaline was tapered, he was shifted to the ward, and he required only single antihypertensive. That was one calcium channel blocker, 5 mg OD dosage he was on.
So how much it reduced actually from the previous one?
His initial BPs, at presentation, were 200 by 140. In the ward, when we saw, it was 160 by 100. It had come down to 90 diastolic.
Okay. So for everybody else, they're saying, can you please tell us that for how long generally the hypertension sustains after removal of bilateral adrenals? What is generally the time period when one can expect that patient can become normotensive?
Ramya ma'am, could you just answer?
Okay.
I think it depends on the duration of hypertension and the severity of hypertension that the patient has been on. Suppose it's a long duration and there have been permanent, not in this case because it's already a child, and usually it takes anywhere between, sometimes we have seen patients who have immediate recovery, but it can take up to 6 months also for the blood pressure to recover, and some may never come back to normal if there has been long-standing blood pressure rise and there is permanent vessel wall change.
Yeah, because this is very important, as most often the patient will ask you this question
that you have removed my adrenals. Now what will happen to my hypertension? So this question will come repeatedly, practically to you. So that is why I asked this. Okay. Thank you.
Okay. Ma'am, Pooja ma'am, ma'am, am I audible to you? Dr. Pooja? Sir, Dr. Deepak, I just wanted to know one thing, sir. Is there any differentiating features in VHL regarding the CT scan? Is the characteristic of FEO different in VHL compared to other FEOs? Like we see cystic FEOs are.
Yeah, see, definitely VHL has the most cystic components in all of the lesions, including the FEOs. But generally speaking, you will still have the heterogeneous echotexture with the areas of necrosis and which are very hyper intense lesions. But the good thing about these, even if they are large, more 100% or 99% of the time they are benign lesions, and the excision and the removal of these lesions are quite. I mean, you need to know the basic steps, but definitely it is not as you can. It's not infiltrative or adherent to the adjacent organs. Imaging, more important than the adrenal is to look for other lesions in the kidney, in the pancreas, and as even Fareen mentioned, in the epididymis. So looking for other sites where this is affected is one clue. When you haven't thought about VHL, is when you have lesions in the kidney and in the adrenal or in the pancreas, you could think about a VHL. But imaging does have that cystic features within those lesions. The adrenal FEOs are like most other FEOs.
Thank you, sir. Pooja ma'am, am I audible, ma'am? Gunj ma'am, do you have any comments on this? Ma'am, you are not audible.
Can you hear me now?
Yes, ma'am.
Nice presentation, Fareen. I just have a question for you and one comment. Hydrocortisone was started immediately post-op. Did you wait to do a serum cortisol? Because I believe a partial adrenalectomy was done on one side.
He was started
Immediately?
immediately.
So the plan is to taper it off in the follow-up and see if it can be
Yes.
stopped altogether.
In fact, yeah, it was a hydrocort and flutrocort also.
Right. So this discussion came up in the previous segments in the morning today regarding cortical sparing or adrenal sparing surgery. So VHL and possibly MEN2A patients are probably good candidates to consider such kind of procedures. And initially, we would not, the norm was not to do a preserving surgery, but currently there are many publications besides Dr. Martin Walsh from Germany, which say that these are the cases where one can consider doing such procedures, irrespective of whether you're doing an open surgery or a laparoscopic surgery. So just wanted to highlight that these are the cases where we can consider doing these procedures.
Yes, ma'am. Thank you. Previously, we had two such cases we had come across in the last 1 year. And one patient who had a bilateral FEO with cerebellar hemangioblastoma, and she was having intracranial bleed. And there was another patient who had a bilateral pheochromocytoma along with pancreatic neuroendocrine tumor. If I can have ma'am, Pooja ma'am, if you are audible. Ma'am, am I audible to you? Okay, Savaratnam sir.
Gaurav is online. I can see you could ask him.
Sir, Gaurav sir?
Yes, I been online listening. Sorry, I didn't pay specific attention. What was the point of discussion here?
Sir, regarding the association, sir, in VHL, we had two such cases previously. So I just wanted to know the appropriate management for them. One was one patient had bilateral FEO with cerebellar lesion, and she was having raised intracranial pressure. So in that scenario, should we do a simultaneous surgery for both the hemangioblastoma and FEO, or should that be a staged procedure?
Well, what I mean, for more than one reason, mostly we have staged the two procedures. See, the hemangioblastoma or any intracranial surgery is done by a different team. And then both of these procedures have potential for intra and postoperative complications and requiring prolonged treatment. So I think it makes sense. What we have done in majority of patients is that we have taken care of all abdominal pathology in one go. I think that other patient is going to be discussed today, where we had a renal cell carcinoma and bilateral pheochromocytomas and neuroendocrine tumor of the pancreatic head. So all that was done simultaneously. Everything was managed in one sitting. But if you have a hemangioblastoma, perhaps it makes sense to do it separately. And I mean, we have had a whole spectrum of VHL pathology. We have had patients with VHL with only adrenal pheochromocytomas, but diagnosed based on sequencing. You might remember last year we had a young guy who had a family history of medulloblastoma in elder sibling, who had succumbed, and a family history of few otherwise. But all he had was bilateral pheochromocytoma, and we have managed him operatively. And we have had patients with both medulloblastoma, pheochromocytoma, renal cell carcinoma, pancreatic neuroendocrine tumors. So there's a whole spectrum, and I'm sure any unit with sufficient number of referrals would have seen the whole spectrum.
It means to say that if it is feasible to do two procedure in the same sitting, or should we assess regarding the severity of the case?
Yeah, I think I would agree with that. If it is possible to do two things together, there's no hard and fast rule that why you should not. But I mean, it has to be reasonable, not putting the patient and the whole healthcare system at a great deal of stress.
Thank you, sir.
Hello?
Yes, ma'am, please, ma'am.
Yeah. Hi. Hello, Dr. Gaurav. It's commendable that these VHL tumors we have not seen there at all at our time, but it is so nice that you are seeing now them more often. So can you tell me that now what is the protocol for follow-up of these tumors? Because they may have a recurrence later on.
Ma'am, I'm sorry, ma'am. We'll just go to the follow-up. I mean, we'll talk about it later. I'll just ask one question to Dr. Deepak. This was a second part of my question. Like, we have a bilateral FEO and a pancreatic neuroendocrine tumor, or any pancreatic lesion for that matter. So, if that procedure needs a Whipple's resection, so bilateral adrenalectomy with a Whipple's resection will be a morbid procedure. Again, should we do in a single setting, or should it be a staged procedure, or should the management of that lesion depend on the size of the neuroendocrine tumor? How do we go about it?
Okay, very hypothetical, but I would say, you are planning to do obviously the adrenals first because your BP is surging through the roof, and then you have to do a Whipple, right, which is going to take place in the hands of the best pancreatic surgeon, maybe about 4 hours. In a Whipple setting, if it was just enucleations or partial resections without anastomosis, no issues. Go ahead and do. As Gaurav said, abdominal pathology, you opened up, you do. But if you're talking about doing an operation which requires a Whipple, you stage it and do the Whipple maybe in the next sitting. So we had a patient like that who had a pancreatic head neuroendocrine tumor, bilateral pheochromocytomas, not I can't remember straight off if it was a BHL or not. But we did staged bilateral adrenalectomy, a cortical sparing on one side, followed by laparotomy and Whipple at end of 3 months, and she's doing well. So I think as Gaurav put it, you can't risk the whole healthcare. I mean, the management system there by operating on a patient who's going to be hypotensing, and the anesthetist is scrambling to get the blood pressures right. At the same time, you're doing triple anastomosis after a head resection. That's foolhardy.
Okay, sir. Thank you, sir. Ma'am, Pooja ma'am, are you still connected with us, ma'am?
She's having extended lunch, man.
I'm there. Yeah.
Yeah, thank you, ma'am. Regarding this partial adrenalectomies, we are talking about one side we do a total, another side it is subtotal. So there are varying definitions about this subtotal adrenalectomy. Can you just give your views, or what is the definition? How much should be removed? How do we go about subtotal adrenalectomy?
Cortical sparing, they say that 1/3 of the cortex should be left behind, minimum for the sufficient functioning for the body. It is very difficult to quantify how much is 1/3. But when you see the CT scan, you make the planning. If you see the normal adrenal apart from the tumor, you may plan on that side that you can do, but intraoperatively, it is a best judgment. And there should be some blood supply to it. They say that if the main adrenal vein, even if it is ligated, there are other veins which will take care of the blood supply. But if you can preserve as many vessels as you can, it is best to have it. But quantification wise, it should be minimum 1/3.
Thank you, ma'am. Sir, Gaurav sir, this was regarding Mukta ma'am's question regarding the follow-up of these patients. How often do we follow on about the other organs? At what interval are we going to do the anatomical imaging or the biochemical imaging of these patients?
Okay, so as far as the adrenal follow-up is concerned, it is no different from most other adrenal, as far as FEO follow-up is concerned, it is no different from usual FEO's follow-up that we do. We do a repeat 24-hour urinary metanephrine estimation or whatever form of catecholamine estimation you want to do at 7 to 10 days post-op or within maybe 1 to 2 weeks of surgery. And then we review them 6 monthly with biochemical evaluation. And as and when, if there's any rise in levels, you may have to do repeat imaging. For abdominal imaging, once again, what we have been doing is just doing ultrasonography once every 3 months in the first year. And whenever there's a high chance of a recurrent disease or a new disease, then of course cross-sectional imaging. For medulloblastoma, I am not aware of any specific protocols for follow-up, but it makes sense that the patients who either have had no intracranial disease so far, or those who have been treated earlier, must have an annual evaluation with MRI. A lot of medulloblastomas can be picked up at a relatively small asymptomatic stage by this. Is there anything else you do, Deepak, in follow-up of these patients? Deepak, you are muted.
Your mic is muted, sir.
Yeah, sorry. No, I was just saying, Gaurav, that I agree with that. And I know that the neurosurgeons here do that same in terms of follow-up annually for the yet to form medulloblastoma or a post-resected follow-up. It would be a annual follow-up, and then same thing with your, you would follow the same imaging protocol what you do for your adrenal to scan the pancreas and kidneys and other organs.
Gunj ma'am, you want to add anything to it? The mic is muted, ma'am.
Okay, thank you so much for these inputs. Actually,
yeah, Mukta, you made a comment about how frequently we see VHL. Of course, things have changed over last many. I mean, you are as old as the department is, so things have changed. We are detecting more disease. When I say we, the whole set of doctors, not just endocrinologists, but general surgeons, general physicians, and so what things were not we were not aware of, we were not diagnosing earlier. So every year we are now managing at least a few of these patients.
Yeah, very interesting to know, because generally these previously people were not very much aware, so they were not coming, and we were also not diagnosing them so often. So now I'm happy to see that so many patients coming and we are diagnosing them and treating them properly.
Okay, thank you. Very nice discussion. And now we'll go with any more questions on this case particularly from anybody?
Can I ask one question?
Yes, sir.
This is to Dr. Deepak and Dr. Gaurav or Pooja. That how do you follow up these pancreatic tumors? Suppose it is surgically corrected, then by the time imaging, suppose there is a liver metastasis already, or how often you see the liver metastasis with a syndromic association of this kind of patients? Anybody can answer.
Okay, I mean, since I'm on video, I'll do it, but it's not that generally speaking, Pradhan, we would have more of benign tumors in VHL, but doesn't discount pancreatic tumors with liver mets. So we are still doing what we do in our department is in fact, this patient had a exit metanephrines at discharge at 10th day. We would not have done that. We would have done that at 3 months on the first follow-up. And our next imaging would be at 6 months. And if then you have both of those normal, you would then go on to 6 monthly for maybe for the next couple of visits, and then after that annual. So, you know, I think imaging is your role, is your most important tool to use to identify METs. Fortunately, they are slow growing tumors, but again, the MIB will give you that clue. And the fact that if you've had on follow-up, you've seen imaging showing liver mets, if resectable, metastatectomy would be the best answer, rather than go on to systemic treatments.
Okay, Gaurav sir, would you like to comment on this?
Any experience, Dr. Gaurav?
Professor Gaurav sir, are still connected here, sir?
Dr. Pooja?
I'm now connected with a different device, so I can hear you now. Sorry. I heard what Dr. Pradhan was asking, but I missed whatever Dr. Deepak Abraham said. So,
thank you. Thank you.
The patient
They are not
uncommon to
audible.
find metastatic.
Hello, Gaurav sir, you are not audible, sir. Meanwhile, Dr. Pooja ma'am, can you please respond to this question?
Yeah, I agree with Deepak sir, and we need to do imaging for these patients because mostly these are pancreatic cysts or benign lesions and they're non-functional. So we need to do annual MRI or CT scan to keep a documentation of the sizes. If it is not increasing in size and they are simple cysts, we just have to observe. We don't have to intervene surgically unless there is a neuroendocrine tumors or solid tumors or they are growing in size. So even I remember with electron Kebbu in NIH, Bethesda in US, I had reviewed their all pheochromocytoma patients with VHL with other lesions. So they had a series of annual MRIs and CT scans done for all these patients, starting from childhood till the adulthood, and for 10 years, 20 years, more than that data they had. And majority of these lesions were stable. So majority patient lesions don't really need any intervention.
I think the issue here would be actually post bilateral adrenalectomy in a 10-year-old boy who needs follow-up, and especially if his remnant adrenal or cortex does not take over, his precautions and his education of the family for all his stress protocols, and that's more important in this boy, I would say. I think he's most likely cured with your resection.
In post-cortical sparing, we can do the concentropin test to check for the functionality of adrenal after 3 months or 6 months.
Yeah.
If it's functional, we may stop the steroids. And
Sure.
that may be the
Yeah.
Okay, we can now go to second case. Second case will be presented by Dr. Malika, senior resident from SGPGI. It is a case on MEN1 syndrome. Over to you.
Good afternoon, everybody. I will be presenting a case on men 1. This is a case of a 42-year-old male. He had he was a known hypertensive. He presented in the emergency with history of vomiting and diarrhea for 3 days and had altered sensorium for the last 1 day. Previously, he had surgery for bilateral renal stones a year ago, and he had no history of depression, neurosis, lethargy, fatigue, no history of skeletal bone pains or galacturia, headache, diplopia. There was no thyroid swelling or chest pain. He did have hypoglycemic episodes in both of these admissions when he was admitted for his surgeries. This was an X-ray that he came with. This was before the surgery when he had the PCNL in situ. We can see renal stones with staghorn calculus and maybe a little bit of nephrolithiasis, nephrocalcinosis. This was after the surgery where stents were in situ. He had family history. He had no significant family history and he could not give a clear history about any of the other family members, but there were other deaths, sudden deaths, where we could not know the cause. On examination, his pulse was 74 per minute, his BP was 130 by 90, but his tongue was coated and his oral mucosa was dry, and the skin, there was loss of skin turgor. So on further examination of the neck, there were no other findings. On general examination, there were multiple skin lesions that were present, especially at the nape of the neck. There were scars from the previous surgery. On abdominal examination. Systemic examination remained unremarkable other than this. On investigations, we found that his calcium levels were extremely high at the time of admission. They were 12.6, and we suspected a hypercalcemic crisis looking at his dehydrated state. After giving him hydration and furosemide, we saw a drop in calcium levels, which again rose the following day and remained quite high at 12.2. His serum creatinine was also higher than normal. It was 2.08, and serum alkaline phosphatase was extremely high, 4476, with an IPTH of 660. All his other biochemical tests were within normal limits. An ultrasound neck was planned, and all 4 parathyroid glands showed increased size and vascularity. The right upper one was 7 into 11 into 18 mm, and the left lower was 16 into 21 into 34 mm. These were the larger lesions, and they also described a 6 mm ill-defined lesion in the upper pole of the left lobe of the thyroid. So these are the ultrasound pictures, although they're not. You can see the left upper parathyroid and the left lower parathyroid, which are quite enlarged. And we did a maybe scan, which showed maximum uptake in the left inferior parathyroid adenoma. The BMD scan also showed that the patient had severe osteoporosis with a T-score of -5.6. An ultrasound abdomen was done subsequently, which also detected a lesion in the pancreas. This was a hypoechoic lesion measuring 0.9 into 1 centimeters in the head, and there was another lesion which was 0.9 into 0.6 centimeters in the body of the pancreas. Besides this, the kidneys showed moderate hydroureteronephrosis on the right side and gross hydroureteronephrosis on the left side. This was a CT abdomen done elsewhere. It's not very clear. I'm sorry, but you can see the enlarged kidneys, and the pancreatic lesions are not very clearly visible. Here you can see the calcium deposition in the kidneys, and the MRI abdomen also showed T1, T2 hyperintense lesions in the tail of pancreas, which was largest was 21 into 19 millimeters. You can see this. It's not very clear. I have an enlarged photograph, which was present in the tail, and there was another lesion which was in the body, which was not clearly visible. We subsequently suspected him to have, with this spectrum of lesions, we suspected him to be a case of MEN1 and did an NCCT head because the patient could not afford an MRI at that time, which was normal. During this hospital stay also, he had many episodes of hypoglycemia. He went as low as 45, and sometimes it was not even detectable on the glucometer. We prepared him for a parathyroidectomy, a subtotal parathyroidectomy with a transcervical thymectomy, and we did a biopsy of the skin lesions, which we were suspecting to be collagenomas. We did this with an intraoperative PTH, and these are operative pictures of where we found that all 4 glands were actually enlarged. The left inferior, right superior, and right inferior were enlarged, and the right inferior was extending into the intrathymic right limb of the thymus. So we did an IOPTH, and we saw that pre-incision and post-excision there was a significant fall in the PTH levels. On histopathology, we saw that it was conclusive of parathyroid hyperplasia and the thymus was unremarkable. Following this, we gave him about 2 months to recover from the parathyroidectomy, but because of his frequent hypoglycemic episodes, we had to plan surgery for his insulinoma, and we did a laparotomy with bidigital palpation and intraoperative ultrasound with distal pancreatectomy. On the intraoperatively, there was one tumor which was seen. It was palpated at the tip of the tail of the pancreas. And there was another larger lesion which was palpable, which was proximal to this lesion at the tip of the tail of the pancreas, which was in the body of the pancreas. This is an intraoperative ultrasound, but unfortunately, this picture is also not very clear. It had increased vascularity, and both of these lesions were seen clearly on the intraoperative ultrasound. If you can appreciate over here, you can see this small capsulated lesion. It was quite well defined, and on the crossing, we saw that the weight of the pancreas was 109 grams and the size was 16 into 5 into 2 centimeters. And there were two lesions, other than the two lesions that we saw in the body of the pancreas when we cut it open, when we bisected the specimen, which were also sub-centimetric. But one of the lesions was actually 2 centimeter into 2.2 centimeter in size. So if you can appreciate in the cut section, you can see these lesions in the body, and this was the lesion at the tip. On the grossing, the final histopathology was suggestive of a multicentric neuroendocrine tumor, and the mitotic count was 2 to 3 per 10 high power fields. On follow-up, the patient remained euglycemic and in fact developed hyperglycemia at certain times. The serum calcium also post subtotal parathyroidectomy. Actually, the patient had developed transient hypocalcemia, which recovered with the distal pancreatectomy, following distal pancreatectomy. We did a clinical exome analysis which showed that the exon 10 was affected and there was a nucleotide change and it was likely pathogenic for MEN1. We followed him up with an MRI head which has been normal, and all his, we did a perimetry to see if there was any visual field defects, because the patient often complained of visual acuity, which seemed like he had some visual problems. Besides this, the patient is doing well and is currently on follow-up. That's all. Thank you.
Interesting would be, I'd like to ask you, why was the patient not operated for the insulinoma first, and you had done your operation for the parathyroid? So do you have any answer for that, or was it just that sequencing? Why was the insulinoma not tackled first as opposed to what you did, where you'll have done the parathyroid first and operated on the pancreas maybe 2 or 3 months later?
So when he came to us in an altered sensorium, we attributed first to the hypercalcemic crisis because he was severely dehydrated as well. We did not, although he did on two such readings, he also had low blood glucose, but his blood glucose was maintained. Besides that, sir, since hypercalcemia is also a trigger for insulin release in insulinomas, we thought that dealing with the parathyroid would improve any hypoglycemic symptoms that he was having.
Was this patient on diazoxide while waiting for pancreatic surgery?
We could not. So this patient was actually, we did not put him on diazoxide at that time, and we did not anticipate such a long period between two surgeries. We were expecting him to recover from the parathyroidectomy and do an deal with the insulinoma probably within the same month. Unfortunately, the patient did not have adequate resources and had to be discharged, and he there were some funds arranged from the government set up, and then he was readmitted for the insulinoma management.
In the workup of the
We did not put him on diazoxide, sir.
yeah, in the workup of the insulinoma, did you have a 72-hour fast?
I'm sorry, sir.
Did you have a 72-hour fast in your workup
That
for
was
the
not
insulinoma?
required, sir, because the patient was the patient.
Symptomatic.
It was not required, sir, because the insulin. The patient was also already having hypoglycemic episodes, where his blood sugar was anywhere between less than 55 mg per deciliter at multiple times, and his insulin levels were recorded to be high.
Sure. Okay.
I would like to ask one question, sir. In cases with neuroendocrine tumors in MEN1 syndrome, how is it different from handling neuroendocrine tumors as opposed to in VHL, sir? Is the malignancy in MEN1 higher, and do we deal with it more aggressively, or? And also the second part of the question is, if there are synchronous liver metastasis, then is a debulking surgery still, is that still an option, or do we just put the patient on some medical therapy where we can do somatostatin analogs or things like that to help the patient recover from the symptoms of the disease?
Okay.
No. Yeah.
Is that question directed to somebody or?
Sir, anybody actually who would like to take that question up? The major difference in handling a neuroendocrine tumor in a VHL in comparison to a MEN1 patient, sir?
The pancreatic lesions in MEN1 are could be more malignant in nature as opposed to the VHLs. But if resectable, resect. If the burden of disease, extra pancreatic disease, and especially if your MIP1 is high, then the burden of the disease outside of the pancreas will decide your approach for the operation on the pancreas. I think if you've got significant systemic disease burden, obviously doing an operation which is itself is quite morbid, but leaving behind significant tumor load would not make sense. So in effect, in a MEN1 patient like this, I think because there were multiple, I think 4 tumors in the pancreas, 2 large and 2 small, and a subtotal pancreatectomy is the right approach. And I think the MIB was 2 to 3% of this patient, if I remember briefly on that path report. So I think this operation would have cured this patient, and the subtotal parathyroidectomy would also address his hypercalcemia. You only now screen for the pituitary lesion if and when it comes up. So the answer to your question, VHL does behave differently to MEN1. MEN1 could be more aggressive. Systemic disease burden, extra pancreatic disease burden will decide how much you operate. And if you've got significant systemic disease, extra pancreatic systemic disease, then systemic therapy after a biopsy and a MIB1, and even targeted therapies based on, you could do a screen, somatic screen, and then do targeted therapies.
Yeah. Can I say? Can I give some comment? Yeah.
Hello.
Hello.
Yes,
Please go ahead, Mukta.
Yeah. Basically, yes. As he's saying that in MEN1, the malignancy rates are obviously more than the VHL. And usually, as such, he has already told you that whenever we can operate, it's better if we can remove those tumors. But otherwise, now, if there is advanced any NEAT and this NET, then a lot of therapies, medical therapies have also come, which we can use for them, like somatostatin analogs, and there are targeted everolimus and sunitinibs, immunotherapies are there. So a lot of therapies are there in even intra-arterial or chemotherapies are there, liver therapies are there, selective angio therapies are there for the liver also. So debulking of liver may not always be needed as such, because a lot of minimal invasive and other type of therapies have come up.
Okay, ma'am, thank you.
Malika, may I have some?
Considering that most of these tumors are usually multifocal, is enucleation an option, or is it really very limited? And is a more aggressive surgery more often than not required for curing these patients? Since these patients also have an underlying hyperplasia and they were to recur with another insulinoma, would we address the pancreas in the first surgery, or do we allow the patient to undergo multiple surgeries for this disease?
Okay, I think I'll answer that to say that if you've got, if you're able to do enucleations and resect all tumors, then you would be okay in doing lesser aggressive rather than enucleations as opposed to subtotals. But obviously with multiple lesions like this, and two of them even almost very small and not, not identifiable, I think your intraop ultrasound picked up the two. But you had image, how was it? How did that work? That you had your 4 lesions in it? You had 4 lesions on your imaging, right?
Yes, sir.
Yeah. So
we could see 2 lesions pre-operatively, sir, but intraoperatively we could detect 2 additional lesions.
okay. So I think that way a subtotal answered your problem, but lesser operations like enucleation does make sense if you have identified and clearly know that there are only 1 or 2 lesions. When you have there, sometimes there are multiple lesions, including the head. Then you do a subtotal plus a enucleation of the head lesion, which is what is that standard classic operation which we describe as the Thompson operation. So I think that would be something to know, that if you're going ahead with the resection, your aim is to achieve cure, not leave behind tumor.
Malika, may I have a word, please?
Yeah.
Yeah, I recently happened to see this patient, follow this patient in the OPD. This patient is now again having recurrent episodes of hypoglycemia, and you just showed those hydronephrotic kidneys and bilateral multiple renal stones. So he has CKD as well, and creatinine is around 8-9, and he has had many episodes of dialysis as well. So we are now trying to choose the best appropriate management for him. Most likely he's going to be put on, because he's a high surgical candidate, he's going to be put on some medical treatment like diazoxide, but because diazoxide itself is causes edema, and also probably well, that's a call which endomedicine endocrinologists have to take regarding medical management of this patient now.
Anjali ma'am, if you could answer that question. This patient seems to be having recurrent hypoglycemic attacks in spite of doing a subtotal pancreatectomy, and also he has recurrent renal stones.
And CKD as well. Creatinine is around 8-9. He's high surgical candidate on dialysis. Yeah.
So what is the repeat imaging finding?
Ma'am, repeat imaging has not been done so far, not even biochemical investigation, but I myself observed him having hypoglycemia.
Like, because Sunil,
twice.
as you said, patient is already having CKD, so we are not very sure that these hypoglycemias are because of recurrent insuloma only. Because gastrinomas are known to be malignant, but malignancy rate in insuloma is relatively rare. So first we need to establish the biochemical diagnosis followed by imaging. Then only we would be able to chalk out a roadmap ahead. If like patient is having liver metastasis, or for that matter, local recurrent lesion, and is a bad surgical candidate, then maybe we can offer non-surgical management in form of radiofrequency ablation. And if this thing liver is involved, maybe chemoembolization, so on and so forth. But first we need to establish the biochemical diagnosis, followed by imaging.
Also, I would like to ask, what is the role of MEN1 testing, since there is no genotype-phenotype correlation in MEN1? How important is it to get, with this cluster of symptoms, is it still important to do MEN1 testing?
So this will not serve purpose for this patient, but it would be beneficial for the screening of family members. Here the diagnosis is clearly written on the face of the patient, but we need to screen family members. There it helps if mutation is detected, because we know that only 75 to 80% of the mutation MEN1 can be detected on routinely commercially available screening.
Thank you.
Can I ask one question?
Yes, please.
Good afternoon. I'm Dr. Sudhi from Meerut.
Yes.
It's starting like this patient has a recurrent hypoglycemia. So could be a possibility, because like chances of malignancy in insulinoma is less. It could be some recurrent lesion in the residual pancreatic head. So as such, Anjali ma'am has rightly pointed, imaging must have been done. So suppose if we find some lesion in the pancreatic, the remaining residual pancreatic head, then what should be our approach? And suppose on imaging we don't find any source of insulin, then what should be our next approach? What should be our diagnosis from where this insulin is getting secreted and causing hypoglycemia? Ma'am, Deepak sir, all my teachers can guide me regarding this.
So first, as I said, that CKD itself is known, means chronic renal diseases and chronic hepatic diseases are known to cause hypoglycemia. First, we need to confirm the diagnosis that it is this thing because of organic hyperinsulinism. Only then we would be wiser that what should be the road ahead. And there are other tumors which could, mesenchymal tumors, which could produce IGF-like factors, but in the setting of MEN, I have not come across such reports, but those are known to be existent, and those do contribute to the organic hypoglycemia.
Ma'am, one thing, suppose like on imaging and other test, a lesion is localized in the residual pancreatic head, then what should be our approach for such case?
Like Sunil said, if he is a bad surgical risk, we should just resort to some radio-guided ablation therapy or diazoxide. If first would be diazoxide, if it is not controlled with diazoxide, then we could try to ablate as much tumor as possible. That would be the best way forward.
I think the surgical risk assessment needs to be very judiciously done in this patient. Here's a guy who's got bilateral kidneys who are packing up. You've got kidney stones riddled, and you've got an issue of repeat pancreatic surgery in the head of the pancreas. So, you would stay far away from such candidates, and you would operate only if you are very sure that you are going to cure or something else has happened along the way, like a kidney transplant or something like that.
Yeah,
So
that's what non-surgical ablation would be the way forward in this.
Yes, absolutely. Or even medical therapy with diazoxide. Yes.
Yeah.
But again, it'll be salt and water retention and kidney function and stuff like that.
Yes.
What is the experience with diazoxide? Like, as such, it should be given lifelong. So, what any problem encountered with such therapy? Any complaints? Patient frequently complain, or it is very well tolerated medicine?
It is fairly well tolerated. The cost is the issue. It's about 90 rupees a day of having diazoxide. So it costs a bit, and patients have to be committed to taking that. It does cost salt and water retention. Hence, if there are comorbidities like cardiac failure, renal failure, these are issues which need to be taken into consideration. but we do have patients who have hypoglycemia post, either tumor not detected, not identified with imaging, who then are put on diazoxide, and with serial imaging, we have picked up the lesion maybe a year or two later, and then gone in and operated.
Yeah, but I just want to ask you, you said that there was hypoglycemia mainly, but in between you got some readings hyperglycemia. How do you explain that?
Post-operatively. Yes, ma'am. Immediately post-operatively, the patient did have euglycemia and a few readings of hyperglycemia.
The hyperglycemia can be explained by the pancreatectomy itself. You're now not having any more insulin. So often most of our patients who are subtotal pancreatectomy become diabetics, and they need insulin post-op for control.
Yeah,
So
that's one of the thing. Okay, fine. And is there any role of means like, as we have discussed already, that more of a medical treatment is more appropriate here, but will there be a role of any pylorus preserving pancreatoduodenectomy in that, if anything is as a last resort? Is there?
I think as Anjali and we discussed, I think this patient's is a poor surgical candidate,
Yeah, that's
especially
true.
for
That's
this.
as a last this thing, if it is not controlled or something like that, or if suppose a patient is a good candidate for surgery again.
Yeah, if none of these risk factors were there, like renal failure, definitely, and proven lesion after biochemical investigations and radiological imaging showing a lesion going back in, I would support that. I see Dr. Mishra. Sir, please comment. I think you need to comment.
Very interesting discussion. I'm just going to that. I thought just add something because tackling pancreas and immune, especially functioning tumors, very tricky situation, because not only one particular hormone like insulin, which is manifesting functionally, there can be other plurihormonal secretion also. So I'm not going to that point actually. I'm just going to insulin hypersecretion. When you're dealing with a case of immune setting with the pancreas, so one very, very careful. The primary surgery is the best surgery, especially in complications, patients like that with kidney problems and all these things preoperatively. So first thing is, we have to do a subtotal pancreatectomy. Portal vein onwards has to be cut, chopped off, right? There may be small tumors, so you will not be seeing that actually. Now, if you remember Thompson's approach, so what they say that do a very good ultrasound of the head, and if you find any small tumors, enucleate. Mukta, I'm taking your observations of pancreatic duodenectomy. In immune setting, usually do not go for extensive surgery because they have a long-term prognosis good. So Thompson's approach says, there are a couple of diagrams he has made it very carefully, nicely illustrated, that chop off as much as possible, pancreatic vein onwards. Then in the head of pancreas, just enucleate, do a good ultrasound, enucleate, and very close follow-up of these patients. Anytime you find this hypoglycemia recurrence, I'm not going to immediate post-op, that can be fluctuation, hypo and hyper, anything like that. Do a close follow-up. Anytime you find hypoglycemia, suspect it is in the head. So do a good investigation, including your side viewing ultrasound, using that any tumor. There can be some mucosal lesions also, remember that also. So this can also create problems. In immune setting, they can have also submucosal. Outside pancreas also can occur. So you have to be very careful all those things and pick up them and remove them. So that's exactly I'm telling you, no amount of any palliations are going to help with the medical treatment. They can all may respond, may not respond, etc. So that's all I wanted to add actually in this immune setting. I don't know how much extensively you have removed the pancreas. So that is very, very important in the primary surgery.
Thank you, sir.
Thank you, sir.
Thank you, sir, for this valuable suggestion. Any more question on this particular case, or we can move on to next case presentation? Our next case presentation is by Dr. Nancy Raja, resident from KGMC. Dr. Nancy Raja, if you can hear us, you can start sharing your screen. Dr. Nansaraja, you are there? Yes. You can start with the presentation. You can. Hello, Dr. Nansaraja, can you hear us?
Hello, am I audible?
Make it full screen and start your presentation. You're not audible.
Am I audible now?
Yes.
Good afternoon, everyone. I'm presenting a rare case of a von Hippel disease with bilateral pheochromocytoma and pancreatic tail neuroendocrine tumor.
Please close your mic.
Close computer.
I think, Nancy, you have two devices who have logged on and both are on. And that's the reason. So switch off one device and then connect with only one device.
हेलो मैम अनम्यूट कर लीजिए आप.
Dr. Nansaraja, can you unmute yourself? with another presentation. Meanwhile, you rectify the problem. Next case is by Dr. Malika. This is a case on men 2A syndrome. So over to Dr. Malika.
The second case is the case of a kindred of a men to A family. In fact, this entire family is being treated currently at SGPGI. This was the first patient to appear to us, the index for our institute. She was an asymptomatic 34-year-old lady. She is, her brother was diagnosed with a MEN2A C611Y mutation in exon 10 of the red gene. He had a pheochromocytoma, which was metastatic, and he was being managed elsewhere. She came to us for a routine evaluation and to rule out any features of MEN2A. So on screening, she was found to be positive. And so on family history, we saw that we screened their entire family, and this was actually the index patient who was treated elsewhere. And we found that 3 other siblings were also found to be RET positive. On examination, there was her general physical examination as well, examination of the neck there was nothing abnormal detected. We did biochemical investigations with urinary metanephrines and normetanephrines, which were both found to be normal. Serum calcium and IPTH were also within normal limits, but the serum calcitonin was 251 picograms per liter, and vitamin D was slightly low. On ultrasound, neck was done, and it showed a 10 into 13 millimeter lesion, which was a hyperechoic nodule with a hypoechoic rim in the right lobe of the gland, which was suggestive of an adenoma. The rest of the right lobe and the left lobe and isthmus were normal. There was no cervical lymphadenopathy seen on ultrasound. We did a guided FNAC from this thyroid nodule, which was suggestive of a medullary lesion. It did not show, they did not clearly say that this was a medullary thyroid cancer. So we went ahead and did a guided cell block from the lesion, and which was suggestive of a medullary thyroid carcinoma. And on immunohistochemistry, this was positive for calcitonin, synaptophysin, and chromogranin E. CECT neck was done, which showed a hypodense nodule in the right lobe. This was well defined, 13 into 11 millimeters, with an extent of 16 millimeters on craniocaudal sections. It was it showed inhomogeneous intense enhancement on contrast imaging, and there were also subcentimetric bilateral level 2 lymphadenopathies, which cannot be seen on this CT scan. A total thyroidectomy plus central compartment lymph node dissection was done, and a single nodule was palpable in the right lobe at the mid pole with the left level 3 lymph node enlarged. There were 3 other enlarged lymph nodes seen in the right lateral compartment, 2 in level 3 and 1 in level 4, but a frozen section was done from the same, which were reported as negative for malignancy. On cut section, we can see this nodule. The left lobe was normal. There was nothing seen. On the right lobe, we could see a 3 into 4 into 5 centimeter right lobe with a 1 into 1 centimeter hard brownish fleshy nodule in the mid region of the thyroid. The post-operative course was uneventful, and there was no hypocalcemia for this patient. She was started on tablet Tylenol 125 micrograms and discharged on post-operative day 6. On follow-up, there has been no recurrence in the neck, and the ultrasound neck has been normal. Serum calcitonin and serum CA are within normal limits. Screening for parathyroid and adrenal lesions have been negative so far. Thank you. I would like to answer any questions.
I think Malika, the index patient for this family was to our hospital was the patient with pheochromocytoma. She was a 25-year-old girl, and then the one that you have shown, she is the sister of this patient, index patient. The first patient detected in this family was having a metastatic pheochromocytoma, who was managed at Sri Venkateshwara Hospital in Delhi, and he had undergone surgery for PHPT at SGPGI.
So, how many members were screened and how many of the screened were positive in this kindred?
So I'll take you back to the slide with the family history.
No, I'm talking about genetic screen.
Yes, sir. They were of her immediate family, sir. They were all 6 were screened. There were 6 siblings, and all 6 were there were 6 children, and all 6 were screened, of which 3 came out to be positive.
Okay.
In
That's pretty much autosomal dominant 50%.
Yes.
What about, do they have children?
Yes, sir. One of them does have a child who has also turned out to be red positive recently. She has also been diagnosed to be red positive.
Okay, so the generation above the 3 siblings, that generation, that means the parents' generation, have they been screened?
They have also been screened, sir. One set of family has been screened, and there has been the mother has turned out to be positive, and no other people are positive.
Okay, it's come via the maternal route.
Maternal, yes, sir.
So her side of the family has been screened, her siblings?
Yes, sir, they have been screened. And again, there is 2 out of, in one side of the family, sir, 3 out of 3 siblings are positive. In another subsect of the family, 2 out of 3 are positive.
So you've got about roughly 10 to 12 people who you've screened.
Yes, sir.
May I suggest that you take a family photograph?
Yes, sir.
It's very, very rare to get it. So I will strongly urge you, even if you have to pay their travel charges to get them to SGPGI, please take a photo.
Yes,
it's
sir.
extremely rare to get so many screened and positives, and and all of them are available for, you have access to them. So I would suggest please do that.
Yes, sir.
Anyone had a prophylactic thyroidectomy?
Yes,
and how
sir.
many did?
Yes, sir. There were 2 prophylactic thyroidectomies done, but one of them was only showing C-cell hyperplasia, while the other member showed MTC. So that was done in a 16-year-old boy, sir. But he initially on ultrasound there was a nodule, so we could not call that he was.
But it was screen detected. That's what it means.
Yes, sir.
You've done a screen detected, and only one of them actually has a truly prophylactic in terms of being C-cell hyperplasia and not having an invasive cancer.
Yes.
That basically is the point, that even when you do screen detection aggressively, your patients who you pick up on screening often have invasive MTCs, right? Our story is about 4 out of the 6, about a couple of years ago when I analyzed the data, 4 out of the 6 still had an invasive cancer of the 6 who had a prophylactic thyroidectomy or screen detected thyroidectomies. So, I mean, it's all the more important to screen and aggressively screen. So everybody, every MTC gets index screen, and then from there, if positive, you screen first degree relatives. That means the sibling, the offspring, and the parent generation. And then from there, keep on working on the family tree, and you identify the whole group. So that's how the way you pictured the family tree, you should actually get a family photo with all of them together. And then it's a very good story to tell.
Sir, may I add something?
Yeah.
Sir, what was even more striking in this patient was the proband who had malignant pheochromocytoma was detected at the age of 22 years only. While if we go through the current recommendations, ATA recommendations, with this mutation 611, they recommend screening for pheochromocytoma to start from 20 years of age. So probably this is the youngest patient of a malignant pheochromocytoma in the setting of codon's 611 mutation. We searched the literature extensively. There are a couple of patients of malignant pheochromocytoma, and I think 2 of them are from Iran. There are a couple of publications, but their age is also around 25 years.
He's 26, Sunil, when he came.
At the time of diagnosis, I'm saying.
Yes, he was 26.
When he developed symptoms.
No, when he came to us,
He started to develop symptoms.
He was 26. At the time of surgery, he was 22.
Yeah, now the follow-up of this patient is that patient developed metastatic liver and lung lesions, had lutetium therapy in AIMS, and he received samarium also at some point of time. And later in PGI Chandigarh, he received chemotherapy CVD regime due to progression. And now he has expired I think a few months back.
Are these metastases from MTC or PHEO?
From PHEO, ma'am. In fact, this patient received MIBG therapy at AIMS in Delhi.
What was serum calcitonin level and what were metanephrines level?
Ma'am, the proband, there was no MTC, calcitonin was normal. When he underwent neck surgery at SGPGI, all these evaluation was done, and only mild PHPT was there. For that, he was operated.
So your index patient has not had a thyroidectomy yet?
He's no more, sir. At that time, no.
But yeah, so okay, sorry. He did not have MTC as a manifestation.
Yes, sir. In fact, these are all actually cousins, not the same father.
Ramya, this patient,
yes, sir.
sorry, I'm just participating as an audience. This patient, the index patient that we are talking of, so has had no histological confirmation of lack of MTC. The
Yes, sir.
calcitonin you say has been normal or low.
Yes.
This issue of metastatic pheochromocytoma in a MEN2A setting needs to be seen with a lot of care and circumspectly. The genotype is 611.
Yes, sir.
So all the more. You said that patient had a neck surgery done, but only for hyperparathyroidism. Nothing
Yes,
done
sir.
for the neck.
Not for thyroid, sir. Only parathyroid.
Prophylactic thyroidectomy was not done.
Not done, sir.
But why?
Because mainly because biochemically calcitonin was normal and he was already having metastasis and he was receiving MIBG therapy.
Was hyperparathyroidism uncontrollable?
No, ma'am, it was not. It was not. It was mild disease.
Yeah, I mean, there are a lot of firsts in this patient. First of all, PHEO first, that's right. And a malignant PHEO on top of it in a syndromic situation, which is again very, very rare. And 100% MTC presentation, you have not seen that yet. And I think if you had decided to do parathyroid surgery, doing a prophylactic thyroidectomy would have not added too much of morbidity.
Yes, sir. Yes, sir.
And I think that could have been done. I mean, I must say that I'm a bit stumped by this. The fact that you've got a PHEO first, malignant PHEO first, and dead by the age of whatever, 22 presentation, 26 operated, and he's gone. And doesn't behave like a 611, in a mutation of 611 where you would have expected them to be the low risk group where your MTCs, you don't even tell this family to do prophylactic thyroidectomy today. Today's guidelines say you operate only on 634s and 883 and 918. There are only 3 mutations who undergo prophylactic. Everybody else is followed up on calcitonin. And here's I was so happy to see this image where it was a completely intracapsular tumor. The thyroid, it had not breached the capsule. And I knew that this patient was cured of her disease because the nodes are negative and you've cured the patient. But I mean, it's never say never in medicine. Yeah.
Adrenalectomy slides were reviewed, sir. They showed pheochromocytoma only at SGPJ also. In fact, another interesting thing was that there is another cousin who was 25-year-old who had come with pheochromocytoma to us from the same family. We did prophylactic thyroidectomy. For her, there was less than 1 centimeter, I think 0.5 centimeter tumor in the thyroid with metastasis to central lymph nodes, central compartment lymph nodes.
Okay.
So,
next question. Oh, sorry. Carry on.
Sir, it's all right. Sorry, go ahead, please.
No, please, you go. I'll ask later.
See, I mean, just what would give us a definite diagnosis in this patient? Unfortunately, he's no more. The definite diagnosis would come from histology of the thyroid and histology of the metastatic sites. The patient we know can have pheochromocytoma and has had pheochromocytoma. Histology of the primary disease in no way is absolutely confirmatory of malignancy. What is confirmatory is histology of the metastatic sites. And so if we had the pheohistology, the thyroid histology, and the histology of a metastatic site, that would have settled this issue.
But Gaurav, wouldn't they have had done a biopsy of the metastatic site before giving him systemic treatment?
Biopsy was done from the metastatic site, which was suggestive of metastasis from the pheochromocytoma.
No, means sometimes it would be difficult to differentiate metastatic neuroendocrine tumor, but sort of that I would like to have CA and calcitonin level at the least in this patient in order.
I thought that was normal.
CA and calcitonin.
Both CA and CA.
Both
CA was
CA
also
and calcitonin were within normal limits for the malignant pheochromocytoma patients.
Yeah, that's strange because even if this was a seronegative or the low calcitonin MTC or C cell hyperplasia.
Normocalcitoninic MTC.
Thank you for the tongue twister, Deepak. But even if this was one, the CA should have been high. Okay.
Yeah, and the MTCs are behaving less aggressively here. I mean, this is strange. That's what I'm telling you. I think all your patients in this family should be more aggressively screened for their PHEOs rather than for their MTCs. I mean, yes, you need your MTC screen with calcitonin. And if you're positive, you offer them prophylactic, no issues. But I think the recommendation is an annual screen for the PHEO. You should change that in this family, in this kindred, because they have so many, I mean, all of them are presenting with malignant PHEOs. I mean, did I hear that right? There was another one who had an adrenalectomy. Was that malignant?
No, sir, that was benign.
Only one malignant PHEO, sir, in the entire family.
Yeah.
Sure. Okay.
Can I ask one? What was the chemotherapy given to him in AIMS?
MIBG therapy, ma'am.
MIBG, okay.
Yes.
And chemotherapy he received in PGI Chandigarh later on, CVD regime.
Okay.
So this was all in 2018, is that right? Somewhere around that time?
17,
year-wise.
yes,
And the response, how was it? And the response of chemo?
He's obviously no more, so he didn't respond.
No, immediate response I want to know because it is later on I think he come to the disease, right?
No, but I think Mukta, these kind of patients today should be on TKIs. I mean, you should ideally a biopsy, and if you can even do a somatic screen and a somatic, they can do targeted, identify the suitable or the correct drug which will work, like personalized medicine, and that would help these patients.
Right.
Interestingly, sir, in our series at SGPGI, if we take the index cases of all the MEN2 patients, around 65 to 70% have pheochromocytoma as the presenting feature. Of course, they will have MTC when we look for it, and for them it's not the that doesn't bring them to the hospital. Mostly it was pheochromocytoma in around 70% of the patients, in index patients.
Sure.
So all
I mean, I'm not.
Yeah.
Sorry, Ramya, I didn't. Did you look at the tabular column about 611? What is the manifestation of PHEO? I don't know the answer offhand, as I'm asking you. What was the, I mean, you have a 2+ for MTC, 1+ for FEO, 1+ for
Yes,
PTH,
sir.
PHPT. What was it for 611?
I think it's MTC only. I'm not sure, sir. I have to check.
1+, sir,
For FEO is a 1+?
Yes,
Not
sir.
a 2+. Yeah. Okay. Whereas for 634 and all, it's a 2+. So, your chance of having a FEO is much higher. So 611 is an indolent tumor. This doesn't fit in with an indolent and a presentation. And a
Sir, is
FEO
it
plus.
possible to have an additional mutation? Because we check only for 6 exons. In literature, they have found that the kindreds which behave differently than what is expected of the normal, they have an
more plausible explanation. More plausible explanation, Ramya, would be non-RET mechanisms. So you have a double hit, but the double hit is not the RET route. Okay, you have one via the RET route and one you have with a non-RET mechanism. It could be a CKNB1 route, or it could be another route where you again have a trigger. So then the tumor, when you look at only that pathway of the RET, you think, oh, I've got an indolent tumor, but you've got something else happening on the other side. So a somatic typing of that tumor will then give you something more. So you may have a genotypic mutation, which is in the blood, which is the germline, and the somatic tumor typing will then will give you another mutation, which will then tell you, okay, this is more aggressive. So a non-RET mechanism is more plausible as opposed to 2 RET, if you know mutations in the same RET gene.
Yes, sir. Thank you.
Any other questions? Actually, I have one last.
We have had a few very large families with MEN2 RET mutations and MEN2s. Perhaps the one that we have screened, the largest number was that ran into some 22 or so. Ramya, is that right?
Yes, sir. Yes, sir.
So, and with some
3
14,
generations.
4 actually, 4 generations.
4 generations.
The first generation, yes, the first generation was a grand old lady who died of metastatic disease, and 14 members positive. But unfortunately, I mean, what you say, Deepak, is gold dust if we can get the 4 generations together in a photograph. But it's more than a
you remember the Clinton family in Sydney, right?
I know, absolutely. and also the Southern Australian and all those families from the Thailand. Yeah. Anyhow, so but it is more than medical. This is a social issue. The cousins and the 2 generations or 2 side branches of the family tree, would not talk to each other about their medical problems, and they do not want their people to come together, unless they be labeled as a cancer family or a FEO family, and then face a lot of problems. So hopefully someday we'll have a
No, Gaurav, I've got an answer for you. Take individual pictures and fuse them.
Yes.
Get them digitally fused.
Yeah.
Well, one somewhat similarly valuable picture I recollect now. I'm sure majority of you in this group who have been in endocrine surgery for a few years have seen at least some pictures of one of our earliest parathyroid carcinoma patient. And with great bit of difficulty, we could dig out her childhood photograph with her younger sister, where she was a little bit the height was longer for the parathyroid carcinoma patient. And then we had another photograph with the same sister, where this girl had lost about 2 inches of height. And so those kind of pictures, and similarly, if you have a large family with a familial syndrome, those are the kinds that you can get into any journal without any trouble.
Dr. Gaurav, what was the follow-up of all these patients, all these family members? I think 2 already have gone for surgery, but it will be very interesting to know the long-term follow-up in these.
How many really develop the disease?
Can Malika take that question? Malika, you have information about rest of the family members of the patient that was
Sorry, ma'am.
present?
Can you please repeat the question?
Yeah, I just want to know that what was the follow-up of other family members who have not gone for surgery, not gone for surgery actually, because it will be really interesting to know how many really are developing later on the disease. What is the scenario right now in them?
Ma'am, actually, all of the red positive patients have undergone at least a thyroidectomy, and in addition, they have undergone, some of them have undergone surgery for the pheochromocytoma as well.
Okay.
Ma'am, there are, and the one that was red positive has, who did not have MTC, has undergone prophylactic thyroidectomy. So all of them have undergone surgery so far.
Okay, all have gone, but the MTC positivity was there in how many? Only one?
No, ma'am. Only one did not. Only one showed C-cell hyperplasia, ma'am. There were
Okay.
no normal thyroids detected in the entire this generation, ma'am.
Okay. So how long the follow-up is for? How many years?
2018 onwards.
17 October is the first patient.
Okay.
And she had surgery for MTC in October last year, 2018. So at least we have, the latest would be 2 years, ma'am.
Okay. So let's see, interesting for how long we can follow them, all of them.
Yes. Thank you very much. We would like to close this session, and we will start at 4 p.m. For the following session, we will start with Dr. Nancy Raja, please. Dr. Nancy Raja from KGMC, we will start with you at 4. I hope that is okay. Thank you, everybody. Please rejoin at 4 p.m.
Thank you.
Thank you, Malika.
Thank you.
Thank you.
Thank you.
Thank you everyone for your active participation.
Dr. Nancy, if you can hear me. Dr.
Hello?
Nancy Raja.
Yes, I'm able to hear you.
Just share your screen. We'll just see a trial if we can do it without any hassles.
Sure.
Just share your screen. Yeah, just put it in the slideshow mode. बात करिए अभी वहां से.
Hello?
Yeah, your slides are visible. You're audible. ऐसा ही रख दीजिए. Don't change it. Just keep it like this.
Yes. Thank you.
Thank you.
हम इसको थोड़ा छोटा नहीं कर सकते?
Here you're not stopping her, I don't understand. ఇప్పుడు ఇక్కడ తింటుంది అది మళ్ళీ కనిపిస్తలేదు ఎట్లా ఎంత దారుణంగా తయారైతుంది తెలుసా పళ్ళు సినిమాల్లో చూపిస్తారు చూడు నీకు ఒకటి గుర్తుపెట్టుకో అంటే నేనే వీళ్ళు కటింగ్
Okay.
వాటర్ బాటిల్
Should we start? Dr. Nancy, are you ready?
Yes, I'm ready.
So for the final, this is the concluding session on men and neuroendocrine tumors. The panelists, I want to welcome Dr. Chitresh from AIMS, Dr. Pooja Ramakant, KGMC, Dr. Gitika Nanda from KGMC. Dr. Bhargav is here with us. I hope Dr. Bhargav is joined. And Dr. Sanjay.
Yeah, I am there.
Yes, sir. And Dr. Sanjay.
Hi, Malika, I'm here.
Yes, sir. So let's start this final session. We will try to take up as many cases as possible, and we will try to conclude in time so that we can have a few words from Dr. Mishra at the end. So Nancy, are we ready? You can please begin.
Yes. Good evening, everyone. Today I'm presenting a rare case on VHL with bilateral pheochromocytoma and pancreatic tail neuroendocrine tumor. 34-year-old male, Mr. Yu, resident of Gujra district of West Bengal, presented to us with complaints of epigastric pain for the past 7 years. The pain was episodic and it was insidious in onset, dull aching associated with bloating sensation. It was relieved with medications. It was not associated with nausea or vomiting. He also gave history of constant dull aching pain over the lower back and calf muscles for the past 5 years. It was not relieved on medications and it hampered his daily activities. He gave history of episodic headache for the past 3 years, which started spontaneously and which was global, dull aching. It occurred about 3 to 4 times per week and it was relieved on resting. He gave history of palpitations, which was present on mild exertion for the past 3 years. History of excessive sweating, which occurred even at rest, and a history of easy fatigability, which compelled him to rest after 1 hour of activity, and history of reduced sleep, all for the past 3 years. There was no history of giddiness, diminution of vision, discoloration of skin, or easy bruisability and weight gain, no history of loss of weight or appetite, no history of any neck swelling, and no history of any skeletal or urological complaints. Past history, patient was a known hypertensive for the past 6 years. He was not on any regular medications. He was a known diabetic for the past 3 years, which was not controlled on OHAs. There was no history of any major surgery in the past. Family history, his father had died 3 years back due to brain tumor at an age of around 60 years. He too was a known hypertensive for the past 3 years, 5 years on medications. His mother is a hypertensive for the past 3 years on medications. He has a younger brother who is healthy and doing well. He's married with 2 children. Both of them are doing well. Personal history, patient takes mixed diet. He gave history of chewing tobacco for the past 15 years. Coming to general examination, patient was conscious, cooperative, oriented in time, place, person, averagely built and nourished. His BMI was normal. There was no evidence of pallor, icterus, cyanosis, clubbing with severe generalized trauma. There was no evidence of any neurocutaneous markers. He was afebrile.
and pulse was 104 per minute, regular in rhythm and volume, measured in right radial artery in supine position. And blood pressure was 180 by 110, measured in supine position, and 150 by 90 in standing position. His respiratory rate was normal. Local examination. On inspection, abdomen was flat. There was no fullness, umbilicus midline inverted, no scars. On palpation, there was only tenderness in the epigastric and the right hypochondriac and lumbar regions, but there was no lump palpable or organomegaly. And percussion and auscultation were normal. There was no bruit heard. In other system examination, cardiovascular and respiratory system within normal limits. On fundus examination, there was a bilateral papilledema present, and central nervous examination was normal. His routine investigations, hemogram, kidney function tests and liver function tests, as well as serum potassium and calcium levels were within normal limits. And patient had impaired glucose tolerance with elevated HbA1c levels. His baseline and ONDST serum cortisol levels were within normal range, and he had markedly elevated 24-hour norepinephrine levels of about 10,823 micrograms per 24 hours. His serum gastrin and calcitonin levels, as well as serum DHEAS levels, were within normal limits. On imaging, contrast enhanced CT of the abdomen revealed a heterogeneously enhancing soft tissue lesion of about 7 centimeters in the right suprarenal region, which were abutting the surrounding structures as well as the IVC with a 90-degree circumference, and another heterogeneously enhancing soft tissue lesion of about 5 centimeters in the left suprarenal region, which too was abutting the surrounding structures, the kidney, the renal vein, with a 90-degree circumference. It was also effacing the pancreas and obliterating the fat plane. And there was also a 3 centimeter ill-defined heterogeneously enhancing lesion in the tail of the pancreas. We arrived at a final diagnosis of bilateral pheochromocytoma with pancreatic tail mass with diabetes mellitus, and the patient was planned for bilateral open adrenalectomy with distal pancreatectomy. Preoperative preparation with alpha blockade and calcium channel blocker was done over a period of 3 weeks. Patient was started on tablet prazosin, 0.5 milligrams, which was gradually titrated to a maximum dose of 15 milligrams per day, and tablet nifedipine to a maximum dose of 240 milligrams per day. Then beta blockade was started 5 days before surgery. Patient underwent bilateral open adrenalectomy with distal pancreatectomy, spleen sparing Kimura's procedure with a rooftop incision. Intraoperatively, the right adrenal gland measuring about 8 centimeters and left adrenal gland measuring about 6 centimeters were carefully dissected from the surrounding structures. It was slightly adherent to the surrounding structures. And also a calcified nodular growth of about 2 centimeters was noted in the distal tail of pancreas. Hence, distal pancreatectomy was done with splenic vein and spleen preservation done. And pancreatic spleen was covered, the stump was covered with omentum. And intraoperative maximum blood pressure of the patient was 210 by 160 millimeters of mercury. Microscopy revealed adrenal classical features of a pheochromocytoma, that is polygonal shaped cells with salt and pepper chromatin, and the pancreatic neuroendocrine tumor revealed cells with finely granular eosinophilic cytoplasm with salt and pepper chromatin. The PAS score was 3, indicating potential for biologically aggressive behavior. In the perioperative period, in view of bilateral total adrenalectomy, patient was started on hydrocortisone infusion just before induction of anesthesia. It was slowly tapered off, and the patient was then started on tablet prednisolone 7.5 mg on postoperative day 4 and tablet fluorocortisone 100 micrograms on postoperative day 5. On the third postoperative day, patient had a drain output of more than 100 ml, and drain fluid amylase levels were high. That is 3 times the normal serum amylase levels, which suggested low output pancreatic fistula. Hence, patient was managed conservatively with injection of trutide, and the drain output gradually reduced. And we had sought gastrosurgery opinion, after which the drain was removed on the 10th postoperative day. Patient had blood pressure on the higher side, which was controlled on a single antihypertensive drug. Patient was then discharged with post-bilateral adrenalectomy precautions. And on follow-up, patient was advised genetic testing, in which he was diagnosed VHL gene genetic mutation. And repeat 24-hour urinary metanephrines were done 1 month later, which was within normal limit. Patient at present is on a telephonic follow-up with us. We also had advised genetic testing of his first-degree relatives. As a patient will require lifelong surveillance due to risk of secondary malignancies, patient is advised routine follow-up, yearly blood pressure and pulse rate monitoring, regular pulse rate and blood pressure monitoring, and yearly urinary metanephrines and normethanephrines, and retinal examination, and 2 yearly MRI brain, MRI internal auditory canal, MRI or CT of the abdomen. Thank you.
Thank you, Dr. Nancy. We're now open for questions. Pooja ma'am?
Yeah, I think in these cases of VHL and familial settings, one issue is to work up for all the components. We should not be missing retinal angiomas or spinal or cerebellar hemangioblastomas or pancreatic lesions, renal cysts. So we have to work up for that. Second is, if we can do cortical sparing adenectomy, we should do, because these are usually bilateral lesions. But in this young patient, we could not do it because the lesions were very big, these tumors both sides, and there was hardly any normal tissue left behind. So we couldn't really do it. And pancreatic lesion was also stuck on the left side with the left adrenal lesion, so we couldn't spare even on the left side. We started with the right side, but we thought, okay, right total has happened. We'll attempt on the left side, but we couldn't really do it. And he is he works in a very small the shop and sells samosas in West Bengal. So he's from a low socioeconomic background. So we have to be really careful, and we keep re-emphasizing him to continue his steroids and to do evaluation and follow-up. He couldn't come back to us because of COVID issues. So he went to the Calcutta Government Medical College, and we coordinated and got his all tests and evaluation done, and got the reports telephonically. So I think these patients require lifelong follow-up. Counseling is very important, and we need to work up. Like he has 2 kids, we need the sample for them also. So that is also equally important, apart from these surgical procedures and interventions. Chitresh, Bhargav, do you have any experience you may like to share for these patients?
Thank you, ma'am. I'm absolutely agree with you that at least MRI brain and spine should be done before operating these kind of patients. Because if we get a medulloblastoma or angioblastoma of the brain, then the treatment plan will be changed. We will be focusing first to these brain tumors rather than these adrenal tumors. And the life expectancy is also depending upon these behavior of these brain tumors. So before attempting the surgery for adrenal or pancreas, we should do the brain screening first. And the second observation is, first we should get the genetic testing for the index patient. Then we should advise the genetic testing for relatives, first degree relatives, after the confirmation that this patient is a VHL patient. Till now we are suspecting, but we are not confirmed. So for first degree relative, we should.
No, the testing was confirmed.
Okay,
Yes,
okay,
that
ma'am.
was done from SCPJ. It was confirmed. The report
Sorry,
came
sir.
in the post-operative period. That's what she meant to say.
Okay, ma'am. Okay, then I thought it was not confirmed. That's all.
Yeah, Nancy, it was a wonderful presentation. Hi, Pooja, Chitresh, and everyone at STBJ. Very happy to see all of you and feel I'm there. Coming to this, particularly, can the presenter highlight what was the specific mutation which was found in this study, and also throw some light on the genetic aspect, because that is the most dubious issue in this. And secondly, I suggest, as Chitresh told, we have to form the pedigree chart of the kindred and the family for any genetic syndrome associated with these endocrinopathies for VHL.
So Nancy, do you like to answer this question?
Yes, ma'am, we had sent the sample to SGPJ hospital for testing, where he was diagnosed VHL gene positive. So
it is usually on chromosome 3. So, and it is a short gene, not a very difficult or complex gene. So it is done easily. So with Kaushik Mandal in SGPGI and genetics department, we could take his help and do it. And it was single exon, he directly hit on 3, and it was positive. So we could get this test done in 2,000 rupees itself. So it was affordable by the patient. But if we do big, large genes like MEN1 or NF1 or BRCA mutations in breast, then the charges go up more than 10,000, 20,000. So that restricts us from getting it done. But single exons, and with the clinical scenario when we are suspecting VHL in view of pancreatic lesion with bilateral FEO, we asked him directly to check for VHL, and we just hit the right target. So that way we could save the patient's money and do it. Otherwise, as a PUSA seller, it's very difficult to get these things done.
Yeah, for the purpose of the younger people, so I suggest that any endocrine tumor which you remove for a syndromic suspicion, we have to do somatic and also germline mutation. So because that gives the somatic mutation will give us the very good academic and theoretical knowledge about the further diagnosis, and also this germline mutation will help in the further treatment and counseling of the family, which is very important. We have to go out of our way even with the low socioeconomic status, because it affects the entire family. If we properly convince and motivate the patient about the importance of all these intricacies of any syndrome, I think patients will go extra yard to contribute some money, and also we can put from our pocket to an extent, because that's very important for these rare syndromes.
Yes, even for him, I remember gastrosurgery people, they donated their stapler for doing the stapler partial, this distal pancreatectomy. So I remember 20,000 rupees went off in that, and we said patient cannot afford, so their department fund only gave that. And then Shashi, our final year resident, he coordinated with Calcutta Medical College, getting all the investigations done by the doctor in general surgery, and he coordinated what all has to be done. So that way we have really gone to help him with whatever way we can. And we are fortunate that he's regular and follow-up touch with us on telephone in spite of all these problems and issues.
Yeah.
Okay, hi, Dr. Sanjay here. So well presented, Dr. Nancy. So Pooja ma'am, what is your policy regarding management of pancreatic tumors? Like if they are not NET, so do you routinely go for excision or do you observe them?
Now, Sanjay have asked a nice question that pancreatic lesions, majority they are benign cysts. So simple cysts can be observed, they need not to be operated. We can do the imaging and just see that it is a cyst, and we can just observe and see the size every year. If it is increasing or causing any symptoms, then we may intervene, otherwise not. But in this patient, very rarely you can have solid neuroendocrine tumors in VHL, and that is what has happened in this patient also. So if it is a solid lesion, large lesion, and we are suspecting a neuroendocrine tumor, then we have to excise. So cysts can be observed, but solid tumors, they need surgery. And pancreas is such an organ that we should not mess with it. So we should be very safe in doing pancreatic surgery, because fistulas and healing is a big issue in this organ. So we should be very careful and try to do minimum possible surgery and not too much of handling of pancreas causing pancreatitis, or when we are suturing it back, we should be careful that we should not cause high output fistula and all these things, because these morbidities are very difficult to manage. So that way we have to
Yes, ma'am.
intervene very carefully when pancreas is the organ.
Yes, ma'am, rightly so. And I think you said that this patient had exon 3 mutation, and exon 3 mutation is more likely to be associated with aggressive variant of NET. So that is the benefit of doing exonal analysis in these patients. Patients who have exon 1 and 2 mutation, they can be safely observed.
Correct.
Yeah, slight correction, Sanjay. It is third chromosome and 21 exon, 3p21.
Right, right, Bhargav. Thanks for correcting that thing.
Any more comments? Otherwise, we can move to Dr. Loreno, please. Dr. Loreno, are we ready with the next presentation?
Yeah. Yes.
Okay. We will be discussing neurofibromatosis with pheochromocytoma. Over to Dr. Loreno.
Good evening, everyone. So I'll be presenting a very rare case in a very young female patient, female child, 8 years old. So she presented to us with a history of on and off pain in right upper abdomen for the past 8 months. The pain was insidious in onset, progressive, persistent, had no postural variation, not related to any food intake, and gets relief only on medication. This episode of pain in abdomen it occurs every after 3 to 4 days. It was associated with nausea and vomiting. However, there was no history of hematemesis, melena, no history of altered bowel habits, fever, trauma, headache, palpitation, and excessive sweating or blurring of vision. There was no history of weight loss or loss of appetite, no urological or musculoskeletal related complaints. Her past history was non-significant. She has not attained her dilarchy and menarche. She belongs to low socioeconomic status and has a poor scholastic performance. Coming to her family history, her paternal and maternal grandparents, as well as her mom, dad, her 5 other siblings, that is 3 younger siblings and 2 elder siblings, they are alive and healthy. There's no history of sudden death in the family or no history of malignancy in the family. Coming to our general physical examination, the patient is of thin build with height of 130 centimeter, weight of 26 kg and a BMI of 15.4 kg per meter square. Her blood pressure, which was measured in her right arm, in supine position was 110 by 70 millimeter of mercury, and in standing position was 100 by 60 millimeter of mercury. Her pulse rate was 114 per minute, which was of regular rhythm and normal volume. There was multiple brownish flat pigmented marks with irregular borders was visible over her bilateral upper limbs, her right upper thigh, her torso and nape of neck, the size ranging from 2 millimeter to 5 centimeter. However, apart from that, she had no obvious other deformity or no other neurocutaneous markers. There was no pallor, icterus, cyanosis, clumping, lymphadenopathy, and edema. Her breast and pubic hair were in a Tanner stage 1, which is normal for her age and sex. On per abdominal examination, on inspection, she had a normal abdominal shape. Umbilicus was in normal position and shape. All the quadrants were moving with respiration, and there was no visible swelling or peristalsis. There was a multiple flat pigmented patches over her abdomen. On palpation, her abdomen was soft, non-tender, had a normal temperature. A lump was palpable in her right hypochondrium and lumbar region, which was extending 7 centimeter below the right subcostal margin and medially extending the midline. The lump was moving with respiration, had a firm inconsistency, smooth surface, and well-defined borders. However, the upper border of the lump was not appreciable. A finger can be insinuated between the costal margin and the liver. On Carnet test and knee elbow position, the lump became less prominent. There was a dull note on percussion over the lump. Liver dullness was noted in the fifth intercostal space in mid-clavicular line, which was continuous with the dull note of the lump. Auscultation at the normal finding. Rest of her systemic examination, including cardiovascular system, the central nervous system, the respiratory system, and her skeletal examination was grossly normal. Coming to her investigation, her basic routine investigation, including hemogram, liver function test, and kidney function tests were unremarkable. Our baseline, the overnight dexamethasone suppression test, it was suppressed on 1 milligram of by giving 1 milligram of dexamethasone. But her 24 hours urinary metanephrine was slightly elevated, that is 2 times the upper limit, and the normetanephrine was markedly elevated. It was 5,691. DHES and serum potassium level was within the normal range. On evaluation of our cardiovascular system, including ECG and echocardiography, it revealed a normal study. Our fundus examinations also revealed normal study. However, on slit lamp examination, there was presence of more than 2 leash nodule in her bilateral iris. I don't have the clinical picture of that. Coming to our anatomical imaging, ultrasound abdomen revealed a well-defined heterogeneous mixed echogenicity lesion in a right suprarenal region. On contrast enhanced CD of the abdomen, it revealed a heterogeneously enhancing lesion in a right suprarenal region with having central necrosis and with few area of calcification. The lesion had a well-maintained fat blends with that of the surrounding structures. The size of the lesion on CT scan was 9.5 centimeter at maximum dimension. Therefore, on the basis of clinical features, that is, she had 2 clinical features which was suggesting of neurofibromatosis type 1. And as per the National Institute of Health consensus, diagnosis of NF1 was made along with pheochromocytoma based on her biochemical and anatomical imaging. Since the size of the lesion was almost 10 centimeter and the patient having a small body habitus, she was planned for open adrenalectomy via endotransperitoneal approach. Preoperatively, although her blood pressure was within a normal range, she was started on alpha blockade, prazosin, a dose of 0.5 milligram per day, which was slowly titrated up to 5 milligram within a period of 2 weeks. And 3 days before surgery, she was started on propanolol. She underwent right open adrenalectomy. Intraoperatively, the size of the tumor was 12 centimeter in maximum dimension, weighing 144 grams. The lesion was slightly adhered to the inferior surface of liver and had a retrocaval extension. The minimum blood pressure recorded during the surgery was 70 by 50 millimeter of mercury, and the maximum blood pressure recorded was 112 by 82 millimeter of mercury. The her final histopathology was pheochromocytoma with a PAS score of 2. Her post-operative period was uneventful. She remained normotensive during her post-operative period, was orally allowed on BOD1 and discharged on BOD4. At 1 month follow-up, she is normotensive. Her urinary metanephrine and normetanephrine are within the normal range. Since the patient has a neurofibromatosis type 1, there is a high chance of secondary malignancy. Therefore, she will need a lifelong follow-up. All her family members has been counseled regarding this. And for further follow-up, she will assess with routine physical examination, including her height, weight, her pubertal development, as well as skeletal and extremities for any deformities. Ophthalmological examination will be done yearly till the age of 13 years. Routine blood pressure measurement will be done annual for any development of any secondary hypertension. And yearly cardiovascular examination will be done, as well as yearly metanephrine and urinary metanephrine and normetanephrine will be done. Thank you.
Thank you, Lorena. That was a very nice presentation. We are now open for discussion.
Yeah, Lorena, it was a very nice presentation and very workup and very good management of this case by the team. So my query, one of the queries is, can you throw some light on the genetics, little bit on the genetics of what you have done or whatever you know, little bit, because that is very important in this issue, being a syndromic entity.
Yes, sir. For this genetic analysis, since he has the typical features of neurofibromatosis type 1. And so based on this recommendation, here we usually don't need any genetic analysis for if the patient is having a typical feature for NF1. However, we had a consultation with PGI, Dr. Kaushik. Since this gene is a large gene, and with time consuming and very expensive, we couldn't do it. And the patient was from a low socioeconomic background, and they were not affordable for it. So we didn't go ahead with it.
Yeah, I have two points to make with regards to this neurofibrous entity. Of course, it's a relatively rare entity, but one of the commonest causes for syndromic pheochromocytomas after SDH mutations is neurofibromatosis. In fact, it is more common than MEN2 related, because the neurofibromatosis syndromes are more common in society than men. And secondly, the penetrance of the NF1 gene with regards to pheochromocytoma incidence is very high. It's almost 70 to 80%. And thirdly, this neurofibromatosis, we have to, it's preferable, though it's difficult to do test this gene because of a very big gene, it's preferable to do, because labeling the exact subtype of neurofibromatosis, whether it's type 1, type 2, or type 3 is very important, because the type 1 has normal life expectancy and type 2, type 3 have lower life expectancy. And contrary to what you said, the neurofibromatosis 1 has very less likelihood of developing malignancies in future. That's why we usually recommend the annual screening only till 13 years, not beyond that. But in neurofibromatosis 2 and 3, we have to do lifelong follow-up, because the life expectancy is lower, because of the incidence of other malignancies is very high in neurofibromatosis 2.
Okay.
Sir, the penetrance for pheoparaganglioma in NF1 is around 10 to 15%. No, so it's not very high. And the malignancy rate is around 11%, 11 to 15% reported.
Yeah, compared to neurofibromatosis 2, it is less. Yeah, malignancy rate.
NF2, does it have pheo, sir? Because it will have auditory.
Yeah, that's what, it's not, I'm not talking about pheo alone. I'm talking
Yes.
about other entities of GI and other soft tissue things. Yeah.
Okay, sir.
Dr. Chitresh, would you like to?
No, I agree with Dr. Bhargava. And the fact is that the genetic mutation is very difficult, and most of the time we have a clinical diagnosis of an neurofibromatosis 1 by the 6 criteria. If we have 2 or more, then it's a confirmed case of neurofibromatosis 1. And my impression was that the pheochromocytoma is not really associated with neurofibromatosis 1, but for me it was a rare case, but I'll have to review the literature. Then what is the incidence of pheochromocytoma in neurofibromatosis 1?
Sir, actually, it's around 0.1 to 5.7 percentage association of neurofibromatosis with pheochromocytoma. Incidence of pheochromocytoma in NF1, it is still 5.7 percentage, 5.7%.
Okay, otherwise the case was well
Yes.
presented and well managed. Pooja ma'am, please.
Yeah, for this patient also we had consulted Kaushik, and then we were happy to know that because of these financial constraints, her father did not agree to do genetic testing. So we had applied for the government funding for genetic tests. For rare genetic tests, there is a separate fund from government, so which Kaushik had applied from his side. So we just got registered under him, and he said once the money comes, we will do it. But according to him, it will cost around 50,000, 20,000 rupees. So he had applied for 1 lakh rupees fund for her. So I hope if we get that thing, then we may call this girl and get the genetic testing done to label which type of NF1 she has. And she has other siblings also, so we need to then work up for them also. Though the siblings who came with her for her care, they didn't have neurofibromatosis. We checked them clinically, and they were not hypertensive, but they were just 2 or 3 siblings which came along with her, not the full family. So we need to look that. And then other thing in children is the dose. Somebody, I think Ramya has asked for the pediatric dose for prazosin. That was also difficult for us, and we had to consult with the endocrinologist. The dose difference is, it is for children, it is starts from 0.05 to 0.1 milligrams per kg per day, and we titrate and increase to 0.5 alternate days. And other thing with children is the issue of laparoscopic surgery. Though the planes were defined, but this tumor was very large, 9 or 10 centimeters, and then it was going retrocavally. So we thought it will be a difficult surgery. So we didn't thought of laparoscopy for her. But then for children, if it is a small tumor, 3-4 centimeters, we may think that way also. But so I think these were the concerns. But being a child, her recovery was dramatic, and as we expect children, they run and they recover very fast. And she was very happy to go, and that way the recovery pattern was much better compared to adults.
I'm getting the drug must have been very difficult, right? 0.0. The dose usually we get is from 1 milligram. I think acquiring drug would also have been challenging.
Yes. And then breaking the tablet into small parts and labeling all that issues. But then the family was very cooperative in that way, though they were from uneducated background. But this girl was very smart, and we were very happy to see such children. She was very bright and intelligent. So she was very cooperative from her side itself. Being 8 years old, she knew how to do things, and she was very cooperative. So that way we didn't struggle much with the drug dosage because the family and the patient herself, they were very cooperative.
Any comment on the prevalence of somatic mutations NF1 in sporadic pheochromocytomas? Because I was recently asked a question by endocrinologist, and then later sir told, of course, I need to review the literature, and that the most common mutation, somatic mutation in
Yeah,
pheochromocytomas.
they are the commonest. NF1 are the commonest.
Is it
NF1 and STH? These two are the commonest.
Okay, Mallika, I have a comment.
Yes, sir. Dr. Sanjay,
So,
please.
this was a well managed and well presented case, Dr. Larena. I must congratulate you. And regarding incidence of pheochromocytoma and hypertension in neurofibromatosis, that other causes of hypertension are more common in neurofibromatosis 1. Okay, essential hypertension and renal artery stenosis are more common in adults less than 30 years. It is so much more common that NIH guidelines recommend first screening for renal artery stenosis. And if it is absent and there is hypertension, then screen for pheochromocytoma. The actual incidence is approximately 5 to 10% in NF1.
Okay, sir.
Malika, I would like to share experience with gene testing in one of our patients of NF1. So patient had clinical diagnosis of NF1. We ordered a clinical exome analysis in which point mutations are tested usually. So the test came out to be negative for NF1 gene mutations, but MSH2 and MLH1 gene mutations were detected in that patient. And this patient had her mother had adenoid cystic carcinoma of parotid also. So what my point of telling it here was that so not all gene mutations can be detected by exome analysis only. So because it can have this NF1 can have large deletions and duplications also. So you may have to resort to second line investigations then. So which becomes quite tedious, particularly because these genetic testing is quite expensive. So the patient has to shell out 30,000 rupees for clinical exome only with no results. So, and the second line testing involves deletions and duplications, which can be detected by MLPA tests.
Yes, sir, that was Very informative, especially with NF1. It is considering it's such a large gene, as all of us have emphasized. It's very difficult to actually find a NF1 mutation.
I think I agree with
Any other?
Sanjay sir's comments that other causes may be even more common than NF1 itself.
Correct.
Yeah.
Other causes.
NF1 is also quite prevalent, 1 in 8,000. It's one of the most common syndromes, but pheochromocytoma as such in NF1 is rare.
Yes.
Yes.
Any other comments? Any other questions? Okay, thank you, Dr. Loreno. We can move on to our next presentation by Dr. Surbi from KGMC again. She's going to be presenting a case of fungating medullary thyroid cancer. Dr. Surbi, please can we start? You can please share your screen now.
Hello, can you hear me?
Yes, very well.
Thank you. Good evening, everyone. I'm going to be presenting a case on a fungating metastatic medullary thyroid carcinoma. The patient is a 55-year-old male, resident of Bareilly district of Uttar Pradesh, who presented with the chief complaints of with complaints of swelling over the anterior aspect of the neck since the past 5 years. This swelling was progressively increasing in size, and although painless, there was history of rapid progression since the last 3 months. There was history of recent change in voice since the past 3 months. There was no history of any other compressive features and no history suggestive of hypo or hyperthyroidism. There was no history of any flushing, diarrhea, no history of diaphoresis or any hypertensive episodes. Patient was diagnosed as a case of metastatic medullary carcinoma thyroid with bilateral lung metastasis and bulky mediastinal lymphadenopathy reaching up to the para-aortic window. The patient was started on palliative chemotherapy, which was a dacarbazine and 5-FU based chemotherapy of a 28-day cycle, and had completed 4 cycles of the said chemotherapy. However, in the past 2 days, the patient presented with the rupture of the neck mass and active bleeding. There was no significant past history, and there were no similar complaints or syndromic association or malignancies in the family. The patient belonged to a poor socioeconomic status, and he consumed a mixed diet with history of iodized salt intake since the past 30 years. The general physical and vital examination of the patient was normal. Prior to giving chemotherapy, the patient had a swelling present over the right side of the neck, which was approximately of the size of 12 into 10 centimeters, extending from the angle of the mandible superiorly to the clavicle inferiorly, and going beyond the borders of the sternocleidomastoid muscle laterally. The swelling did not move with deglutition, and there were no overlying skin changes. The Pemberton sign was negative. On palpation of the swelling, it was a nodular swelling, which was non-tender, firm to hard consistency with ill-defined margins. The lower border of the swelling was not palpable. It had a restricted mobility, and it was likely a conglomerated nodal mass. Another swelling was present next to the big swelling, which was of the size 3 into 3 centimeters. The swelling was firm in consistency with smooth surface, and all borders were palpable, and it moved on deglutition, which was likely the right lobe of thyroid. The left lobe of thyroid was not palpable. The trachea was deviated to the left side, and right carotid pulsations were displaced posteriorly. Bilaterally, level 3, 4, and 5 lymphadenopathy was present, largest on the left side of 2 into 1 centimeter, on the right side, apart from the big conglomerated mass, 2 into 2 centimeters. At the time of presentation, after completing 4 cycles of chemotherapy, the patient had a rupture of the nodal mass and presented with a large ulcer of size 6 into 6 centimeter over the swelling with ill-defined margins. There was active bleeding present from various sites at the base of the ulcer. At this period of time, on hemogram, he had a low hemoglobin, although the other parameters, the renal function and the liver function were normal. Serum calcitonin evaluation prior to chemotherapy and at present state after completing 4 cycles of chemotherapy were relatively stable. They were around 1200 picogram per ml. The serum CEA levels prior to starting the systemic therapy and at present were also stable in the tune of 1800 nanogram per ml. The ultrasound of the neck, this was prior to chemotherapy, revealed a hypoechoic lesion in the right lobe of the liver, largest diameter 3 centimeter with bilateral cervical lymphadenopathy. The same finding was evident on the CT of the neck, where a multiple hypoechoic mass was present in the right lobe of the thyroid of size 3 centimeters, which was infiltrating the right paratracheal soft tissue. There were multiple conglomerated lymph nodes present in the cervical region and the mediastinum. In the mediastinum, the lymph nodes extended to the prevascular, the bilateral paratracheal region, the para-aortic AP window, and the subcarinal and the bilateral hilar regions. Also, multiple nodular lesions were noted in both lungs, which was suggestive of metastasis to bilateral lungs. Prior to starting chemotherapy, we performed an FNA of the patient, which was suggestive of metastatic carcinoma thyroid, and the possibility of a metastatic medullary carcinoma thyroid was given. On further performing a biopsy for immunohistochemistry, the reporting was given as a medullary carcinoma thyroid, which stained positively for calcitonin and negative stain for thyroglobulin. As the patient was a known case of metastatic medullary carcinoma thyroid with a rupture of the right nodal mass, in consultation with the radiotherapy department, we planned external beam radiotherapy in a palliative dose. A total dose of 20 gray was given to the patient, divided in 5 fractions. On subsequent follow-up at 1 month, the patient showed a relative decrease in the size of the lesion along with healing of the ulcer and control of the active bleeding from the base of the ulcer. We further plan to complete the remaining cycles of chemotherapy and start the patients on tyrosine kinase inhibitors and again review the radiological imaging of the patient. Thank you.
Thank you, Dr. Sirvi. That was a good presentation. Dr. Bhargav?
Yeah, it is a very good presentation, and the case also very interesting case. In fact, because in my experience, I have never seen a fungating medullary thyroid cancer, because most of its infiltration due to medullary thyroid cancer usually occurs to the deeper tissues into the visceral neck structures.
Yes,
very unlikely that it infiltrates the skin or the subcutaneous plane. Anyhow, two small clarifications I need, because I feel the presentation is little incomplete. Though it's a very good presentation, I have no issues, because there's not much information on the pathology or other aspects, or even at least a minimum discussion of the literature or review. So my opinion in this case is, it may be a mixed tumor. It is not a pure medullary thyroid cancer because of 2 reasons. It is a hybrid tumor of medullary thyroid cancer with differentiated follicular thyroid cancer, which has de-differentiated, maybe a combination of anaplastic and medullary thyroid cancer. The reason is the calcitonin level is only 1200, which is quite low for such a ferocious tumor. It should be to the tune of 10,000 or 20,000 or 1 lakh or something like that. So secondly, as I said before, the skin infiltration is very, very unlikely with medullary thyroid cancer, though there can be hyperemia and hypervascularity around the tumor. So these are my comments.
See, Bhargav, you are right in saying it's a very difficult case, and I had a lot of discussions with many people about the management issues. And he was having lung mets to start with, and such a difficult surgery. So we were not considering surgery, but we were just exploring, should we in the first setting itself. But then surgery meant to do sternotomy, excise or mediastinal nodes, because they were in continuity with this nodal mass. And the primary was very small, but the nodal mass was very huge. And that nodal mass only got stuck to the skin, and it ruptured and it ulcerated and fungated. So he came in very low hemoglobin of 3-4 and in a very bad state, and we thought he may not even survive. But then when we discussed with radiation oncologists, they said they can try RT and this is a good setting to give to palliate for the bleeding ulcer. And after radiotherapy, in 4 or 5 days, when he was in the ward, he bled again. So even at that time, we were exploring, should we go ahead and excise this nodal mass, this palliative surgery, finish it off and come. But then this ulcer was badly stuck to a large extent, to a huge around 10 into 8 centimeter skin. So that much skin would have gone, and we should have done the pectoralis major flap reconstruction to cover the skin. All that also I explored with plastic surgeons and other people, the literature what says and everything. But then again the bleeding stopped, and then the patient was really fed up with all this thing, and he said, I want to go back home and I'll come back after 3-4 weeks for surgery. So patient and relative both at that point were not mentally prepared for surgery. So we said, okay, you go and take your time and come back. Anyway, it's a bad disease biology. So we don't want to be very aggressive or heroic in such cases. Though we were reviewing literature and seeing what best we can do, he had a cancer card made and we got TKIs also for him. So we started him in the later part. And we were just on telephonic consulting him every week, how he's doing in his village. So that way we thought that if he comes back and his lung lesions respond, we may excise them that way. But then surgery intention will be only palliation for
Yeah,
these
I have.
settings.
Yeah, I have
Chemotherapy
no.
don't really work. Huh?
Yeah, I have no issues with the management. It was, in fact, excellent management. Whatever you people have done, because if that case would have come, I might have not. I would have asked the patient to go directly back home. So by my issue here, interest is only purely academic interest, not a
Yes.
clinical issue. Because
Yeah,
what I yeah, based
Huh.
on my experience, my conclusion with this case is, based on my experience is, it could be a mixture of medullary thyroid cancer and anaplastic cancer, almost invariably, because as I said, calcium level is relatively low, and the differentiated follicular cancer, as you know, is very much more common than medullary cancer. And thirdly, the skin infiltration is very unlikely with medullary thyroid cancer. And maybe what we could have done in retrospectively is FNAC of the thyroid nodule or the lesion, to show at least to see for any thyroglobulin or at least serum thyroglobulin level, just for academic interest. Because in some cases of medullary thyroid cancer, I have seen not these type of cases where the disease burden is very high with lung mets, still they have done very well for 5 to 10 years. Not in these ulcerative cases. What I mean to say is those which are hidden within the body, even with a huge tumor burden with persistent hypercholesterolemia, they still do well. They live for another 5 to 10 years with minimal suppositive and palliative therapy. This case, definitely we cannot do anything, just purely academic issue.
Yes, I agree. If he comes back to us and if he survives, we can do that thing just for academic and for curiosity and to know the disease biology also better. But for me also, this was the first fungating metastatic medullary thyroid cancer. Usually we see anaplastics or poorly differentiated ones fungate.
Yeah, I feel it. Anaplastic component is definitely there. It cannot be pure MTC. Yeah.
Many other systemic metastases are there apart from lungs, I mean mediastinal nodes?
No, there were only lung metastases.
Okay.
Suresh, you want to have any comments?
Yes, ma'am. Now, because at the first, it is very difficult case to manage. There's no doubt about that. We all are agreeing. But because now the 4 months have been gone and patient is with us and patient is still not progressing, so the possibility of anaplastic now is little less. But at the first instant, as Dr. Bhargav said, yes, the possibility of anaplastic carcinoma was very high, mixed medullary with anaplastic, because the first calcitonin and CEA levels giving the clue that the de-differentiation has already been started. And the cause of the ulceration, fungation is not exactly fungation, but the cause of ulceration is because the lymph node is stretching. The skin over the lymph node mass is stretching. And sometimes when we do a core biopsy, so this stretched skin where the blood supply is already poor, so this type of ulcerations may happen. So I don't know the exact reason what was happened, but the lymph node mass was the same as starting before the chemotherapy and after the chemotherapy. The size was same. The only the ulceration was there.
So
And
even this nodal mass, it became cystic and it became mobile. Even the patient also said that earlier it was hard and fixed, but then with chemotherapy, he was responding. So we could go below the nodal mass, we could instrument the finger, and it was moving side to side. So we thought he's partially responding, so we thought to continue chemotherapy. But because this ulceration happened in third or fourth cycle of chemotherapy, that created a complication. It
response,
was like
you're
30
right,
to
ma'am.
40% response.
You're right, but even this is not partial response, ma'am. When we see the REGIST criteria, it is stable disease, not progressive, but it's a stable disease. And after 4 cycles of chemotherapy, I think furthermore chemotherapy will not help for this patient. It's not very
But I
chemosensitive.
discussed with people, and some surgical oncologists have gone too aggressive and they have done pectoralis major flap for the cover, excising it. But in view of metastatic disease going so much aggressive in surgery, that was the only question and
Yes, at
concern
that
for
time
us.
it was very difficult, ma'am, because now 4 months have been passed. Now we can think that disease is not progressive very fast, so we can go ahead with the surgical excision of the thyroid along with the nodes and some medicinal dissection, maximum whatever we can do. But now it can be justified to go ahead with the
Yes,
surgery if
yes,
patient is not
exactly.
progressive.
Because when he had, I think 5, 6 donors to donate the blood, then again he re-bled, he again lost blood. So it was very difficult for us to get the blood stable and hemoglobin increase for him. So all those issues were also there. So at that time, that's why surgery was not a feasible option. But we thought that if he responds to radiotherapy, we may wait for 6 to 8 weeks and then go for surgery. And that's what patient also agreed for it. So
Yes.
I think if he comes back, we may consider that. But I think we will do palliation only, whatever we can do in that.
Yes,
And the other option would be if there is somatostatin receptor imaging uptake, we can also try lutetium therapy after debulking.
Yes, but government has to fund for him.
And for that purpose, we have to do first we have to do the 80 more than 80% cyto reduction. And
Yes,
if
ma'am.
the residual is very less, then the lutetium will help. If the residual disease is very high, burden is very high, the lutetium won't work.
Yes.
But we need even if the patient comes back, I think we need all Marvel's Avengers team to attempt surgery on that.
Yes,
Normal
yes.
people cannot attempt on that.
Exactly. It was a very high risk surgery, so we had a lot of questions in our mind. Even when he was bleeding, we thought of emergency exploration. But then emergency surgery also needs a lot of preparation. So that time also I had consulted many people and thought and made a team to do. But then we changed our mind, and then radiation oncologists intervened, and then we thought, okay, we got some help from them. So that way, yeah, it is a very difficult decision making at that point, and even now for him. But that bad disease biology anyway will behave bad only.
And one more comment. The hemostatic RT worked very well for this patient. I mean, the two pictures are showing that it was a hell before the hemostatic RT, and after that it worked very well.
No, but then this picture is after 1 month. But then after 1 week when he re-bled, then we were reconsidering whether RT helped or not helped. Then again we were rediscussing and I explored, and then we were slightly discouraged, or we were upset that RT didn't work. And I discussed in CMC Vellore also with Paul sir, and he said RT sometimes helps, so you try this thing. And some patients, they had help. So we had lost all hope in the second week when we discharged him home. And we had called him up on telephone and asked whether he re-bled again in his village. How will they manage the bleeding? And previously also they couldn't manage it. So we were surprised to see after one month what pictures they have shown that that ulcer healed. But then it was not a smooth healing. So it was like a very bumpy ride we had with him.
Dr. Sanjay is also with us. Dr. Sanjay, do you want to make any comment?
No, sir. Only this was well-managed case, considering his financial status. I think it was a right approach, whatever was done for this patient.
If Gaurav sir is present, and he would like to share his experience.
Well, I can't recollect any fungating medullary carcinoma that we have managed, but we have experience of a few poorly differentiated and up to poorly differentiated carcinomas, and they've been patients with fungating lymph nodal mass, primary primary thyroid mass, but can't recollect any medullary carcinoma. Of course, a few of these poorly differentiated might have been medullary de-differentiating into poorly differentiated. Um, well, the management that was done for this patient is pretty much what one can do under the circumstances. Uh, and surgery here on will be challenging. Just take it very carefully, evaluate the cross-sectional imaging should be reviewed again just before surgery, uh, and then for as you would approach any patient with locally advanced thyroid carcinoma, see if it is actually resectable, if it is invading the pretracheal fascia, prevertebral fascia, and if there's circumferential involvement of the carotids, or any um, reason which makes it unresectable, better to leave it as such. No point being heroic and not being able to help the patient.
One minute.
Sure, sir. Thank you. Yeah, I fully agree with that part.
Thank you very much. Any other comments?
I have a question for the panel, if that's all right.
Yes, please.
I would like to know regarding the experience of the panel of radiotherapy in a setting where the patient has not been operated. Usually, radiotherapy, whether external beam or intensity modulated, has been given in an adjuvant setting for patients who had residual disease or with persistent hypercalcitonemia, but no evidence of residual disease. But in this setting, since we gave radiotherapy to the patient prior to any surgical intervention, does the panel have any experience in palliative radiotherapy for a patient of medullary carcinoma thyroid who has not undergone any surgery, and the response rate to said radiotherapy? And secondly, surgery following such a palliative radiotherapy, as radiotherapy may complicate the intraoperative period due to extensive fibrosis or adhesions which may not have been present previously when radiotherapy was not given. So can anybody, if they have any experience or regarding the same? Thank you.
Yeah, if I can answer, I will answer the second question first.
Yes,
so
sir.
with regards to the surgery after radiotherapy, definitely I think it's not indicated at all. We cannot operate because there will be board-like rigidity and the planes are totally obliterated, and we cannot even think of incising or putting a knife on the irradiated neck. That is the first comment. So regarding the first question, most of the experience with the palliative radiotherapy or the adjuvant radiotherapy, or for that matter neoadjuvant therapy, is limited in medullary thyroid cancer.
Yes.
I might have given for 1 or 2 cases, but that too doubtful. In fact, the pathology is doubtful. So in those cases, one case relatively it responded well, because in the sense they could manage for 1 to 2 years the pull on the patient, but the patient had a lot of post radiotherapy complications like dysphagia and malnourishment and all those things. And second patient did not do well with the radiotherapy. So in all, the medullary thyroid cancer is relatively radio resistant tumor, but maybe it can be tried because it may at least palliate the patient from that fungating or that bleeding tumors, provided we explain the downside of the radiotherapy. But most of the patients do not choose for radiotherapy if we explain those complications. So we can try. It's basically anecdotal experience. That's all.
Thank you, sir.
Yes, Bhargav, you're right in saying this is very rare scenario, and even with Paulser also said in CMC they had given to 5 or 6 patients preoperative palliative RT, but and that 50% patients responded. So there was some response, and with that consideration only in mind, we went ahead and did. Because anyway, we realized surgery is not a good option for this patient, and it required there are too many logistic issues to do that time. So RT really was beneficial at that point, and it after 1 month we could agree that RT helped at that point to save from bleeding and managing that blood loss and that ulcer yield. So, and if we have given radiation, then if we have to go for surgery, better to go after 2 or 3 months.
Yeah,
So
yeah,
that's
true.
what we have to wait for post RT changes to regress.
Yeah, definitely, definitely radiotherapy should be considered in the whole list of options. Definitely, we cannot totally ignore it. And secondly, I think we have to wait even more than 1 or 2 months, because at least 6 months, I feel, because the radiotherapy changes are prolonged for 6 months to 1 year. Yeah.
Yes.
Thank you, sir.
Thank you. If there are no other comments, we could move to the final concluding case. This is a case of metastatic insulinoma, a very rare patient presented by Dr. Nitish. Here are final year SGPGI resident. Share screen.
Okay, sir. Slide share. Good evening, everyone. I will be presenting case of metastatic insulinoma, a rare case. We chose this case basically for the discussion. 45-year-old male farmer from Sajapur presented with the complaints of giddiness, palpitation, and sweating for the 1 year. He presented in the 2015 and with the complaints of blurring of vision for 1 and 2 years, occasional recurrent episodes. Patient consulted at the physician at his place and diagnosed to have a hypoglycemia. And he was further evaluation found to have a pancreatic mass on USG or CT scan. Patient was referred to SGPGI. On retrospective 2015. On retrospective history taking, there was no history of any syndromic association. There was no significant history of previous surgery, hospital admission, or chronic illnesses. No significant family history. His general examination was unremarkable. Neck examination was normal. Systemic examination was normal. So lowest fasting blood sugar was recorded as 35 mg per deciliter. Insulin level was 29. C-peptide was 15. Serum calcium was 1.4. And serum PTH was 176. And as he was vitamin D deficient, so he was started on vitamin D supplement, and which after that PTH reduced to 61.5 picogram per ml, and calcium reduced to 1.31 milliequivalents per liter. Growth hormone and prolactin and 8 AM cortisol were normal. I am sorry that a patient has lost all the previous record and scan, so I don't have a detailed CT scan report, but on CT scan, there was a multiple pancreatic mass. So on the basis of imaging and blood investigation, diagnosis of multiple insulinoma was made, and our aim was to rule out MEN syndrome, MEN1, and he was planned for exploratory laparotomy and proceed. So intraoperatively, multiple masses were found in pancreas. largest 14 into 10 into 5 centimeter vascular heart mass extending to splenic hilum with the peripancreatic lymph node. There were another two pancreatic mass, one about 2.5 into 2 centimeter and other about 1 into 1 centimeter at the junction of head and body of pancreas. Both were enucleated. Distal pancreatectomy was done. Rather, it was pancreaticosplenectomy was done. And splenic, there was multiple collaterals, and there was a suspicion of splenic vein thrombosis also. And there was no palpable tumor in the head. There was no ascites, liver mets, or peritoneal nodule. On gross examination, the tumor size was tumor on the body and tail was 14 into 10 into 5 centimeter, which was attached to the spleen. And the two tumor in the neck were of 2.5 into 2 centimeter and 1 into 1 centimeter. So patient developed hyperglycemia, which was managed with the insulin. Patient had fever and abdominal pain, which was managed conservatively. Drains were removed on post-operative 13 and patient was discharged. And its final histology was neuroendocrine tumor. Margins were free. And tumor was positive for synaptophysin and chromoganin. Ki-67 index was less than 1%. Follow-up, patient was advised for the evaluation of primary hyperparathyroidism, but he was lost to the follow-up. And meanwhile, patient developed diabetes, so he was started on insulin by endocrinology department. Patient presented 1 week back with the complaints of recurrent episode of giddiness, tremors, palpitation, and sweating for 3 months. There was a few episodes of loss of consciousness, and lowest recorded blood sugar value was 32 mg per deciliter. However, there is no history of seizure. There's a history of increased appetite and weight gain around 3 kg in last 1 month. General examination was normal. There was no neck examination was normal. Per abdominal, there was a previous scar was healthy and no mass was palpable. And 72-hour fasting test was done. In set 1, fasting blood sugar was 42 and insulin level was 81.66 and C-peptide was 1.95. C-peptide and insulin and C-peptide ratio was 0.3 and blood ketone were 0.2 nanomole per liter. And the set 2, fasting blood sugar was 34, insulin level was 90.6 MIU per ml. C-peptide was 1.87 nanomole per ml and insulin to C-peptide ratio was 0.35 and blood ketone was 1.1 nanomole per liter. And he was and other parameters. Now serum calcium was 9.8 and PTH was mildly raised. Growth hormone, prolactin, and cortisol were normal. Vitamin D is awaited. And CCT was done, which revealed multiple enhancing lesion in liver, largest being 8.5 into 5.5 centimeter in segment 5 and 6. There are multiple nodular lesions in pancreatic bed, nodular deposit in hepatoperitoneum and adrenal glands, and most likely these are metastases. These are the CT scan images. We can see the large metastasis in the liver, and there are some nodules also. So USG neck was also done to rule out the hyperplastic parathyroid adenoma. It was normal. So based on the biochemical and the imaging findings, our diagnosis is recurrent hypoglycemia with recurrent, most likely insulinoma, status distal pancreatectomy. And here again, we have to rule out primary hyperparathyroidism and MEN1 syndrome. So our plan is to manage patient with the medical management with diazoxide to control the hypoglycemia, and patient is defer PET scan. So we choose this case. First thing is it is a rare case, and second with all how to go further. So case is open for discussion.
Nitish, before anyone can ask question, can I ask you one thing? How long the patient has been on insulin?
Sir, ma'am, post-operative, around 5 years.
So has he stopped taking insulin as of now?
He was not compliant, ma'am.
No, the biochemical value, because I could see insulin levels were high, but C-peptide was not very high.
Yes.
Okay, and another thing is this patient has cholangiomas also, that was biopsied. He's a proven MEN1 case.
Yes.
And current CT also shows bilateral nodular adrenal enlargements. Apart from these, radiologists are not very sure whether those are metastatic or primary adrenal lesion.
Yes.
And this thing, we are still deciding about his surgical management. Our first option would be to go ahead and resect as much as possible once his complete biochemical diagnosis is available to us. But I'm still curious, when did he stop insulin? Because I did not have access
He
to
was
all
taking
the
insulin off and on. Was not regular. So,
Any other questions?
I have a question to ask Pradhan sir. Sir, is Exendin scan, which is the new one, is it better than FDG PET in this scenario? But considering it's a malignant one, it must have de-differentiated. Which one do you suggest is better?
Actually, in this setting now, the Dotanoc will help. So because your objective is now with so much of metastasis, it's basically will be palliation. Even if let's go for surgery and for following surgery with so much of metastasis, it's palliation only.
Yes, sir.
So obviously it will Dotanoc should help. So there is no need of extending to really differentiate or something.
Okay, sir.
You see, so that is the, when you have confusion with the tail of the pancreas, then you will choose for a very specific extended scan, because it is false positive shown in Dotanoc scan. That's why the people came with extending. But here is the case, especially in this present case, it is already metastasized and multiple nodules. And what really we are going to gain with it?
Sir, is it false positive in tail or the uncinate process, sir?
They are the same on-site process in the.
Okay.
So Dr. Pradhan, here I would like to add upon, this is a case of insuloma, where this thing somatostatin receptors are not known to be as widely present as other neuroendocrine tumor. And second is, our main intent is to prevent recurrent hypoglycemia, because that is going to be more detrimental to the patient than the metastatic process per se. So in the phase of insuloma, it is advisable whatever could be resected, we should resect, then try to complement our management with other form of ablative therapy. So our intent would be once patient consent to it, and we are sure that these metastases are from insuloma, because we know that in the setting of MEN1, these could be plurihormonal. So we need to know whether these metastases are arising only from insuloma. That's why I asked Nitish whether endocrinologists are absolutely sure about the diagnosis of insuloma or not. Though going by his hypoglycemia, it is likely to be the case. But regarding metastasis, we are not sure. It could be anything else. So in that scenario, both, maybe if needed, we could have to resort to both FDG as well as Dotanoc.
Any role of biopsying these metastatic lesions?
No, because we don't have immunohistochemical markers to differentiate between insuloma and gastrinoma. At the end of the day, the diagnosis would remain the neuroendocrine tumor. So that is not going to tell us exactly what exactly is the case. And in fact, then in that instance, functional imaging would help, because if those are taking up somatostatin analog, then those are likely to be non-insuloma metastasis, and then lutetium therapy and other forms of therapy could help.
Dr. Gyanchand is also here. Please, if I could ask him to opine.
In between, my phones are coming, so I am not able to hear the
one story. So in between, I'm in emergencies, so most of the calls
Yes.
are coming from there.
Yes, sir. No problem, sir. He is away at for his COVID duty. Sanjay sir, would you like to opine on liver metastasis, synchronous or metachronous, and how if debulking surgery is helpful?
Yes, I completely agree with Anjali ma'am's opinion. Even hepatic resection is indicated in treatment of metastatic liver insulinoma if there is no extensive bilobar involvement, or if there is no extensive extrahepatic metastasis, then liver resection should also be contemplated. Because although majority of patients will not be cured, but prolonged survival could often be achieved. So yes, we should plan an extensive surgery in this patient.
And what about genetic testing in patients with insulinoma? Anybody has an opinion? Anybody on the panel or the audience who would like to opine? Genetic testing in insulinomas? Dr. Bhargav?
Yeah, it's a very interesting and also a tough case to manage this, and very rare too. Hi, good morning, Anjali madam and Gaurav sir. Very nice to interact after a long time. And
Good
coming to
evening.
this, yeah, madam. Coming to this case, I think the only definitive curative option, if at all it can be done, which will be a very heroic act, super heroic act, is the Whipple's pancreatic and also the partial hepatectomy or total hepatectomy with the liver transplantation. Of course, it can be easily said than done. Of course, we have to entertain the other options in the armamentarium, such as the RFTA ablation or the chemo ablation and all those things, which have been tried. There are several anecdotal reports of partial success or even total success. We have to try all possible palliative measures which are available within our reach. So what I mean to say is we have to try put all our efforts to palliate the patient with whatever means are available to us, whether it is biological therapy or whether it's diazoxide or whether it's a somatostatin inhibition, or it could be any ablative therapies. And regarding genetics, of course, it's just a men one workup. That's all. There is no specific workup for with regards to insulinoma, and as such, the malignant insulinoma is very rare. But anyhow, it's a very interesting case.
Thank you. I would like to conclude this session, and please invite Dr. Mishra to speak a few words. Thank you everybody for your participation. It has been a wonderful day being spent with all of you. Thank you.
Thank you, Malika.
I just request all of you to just wait for 5 minutes. I will conclude in 5 minutes. First of all, thanks everybody, all the faculty members and all the residents across the country to take part in this interactive session during COVID times. And very interesting that we have been able to talk to each other after so many months, especially academically. In fact, our only collaborative session with Vellore, Cuttack, KJMU and Amrita has been completely suspended. So this gives really a kind of enthusiasm amongst our residents here that they could discuss with you all. So thanks for agreeing to participate in this session and spare your weekend for this academic exercise. The thing that I want to just put you across is just because in COVID time we are learning a lot of things actually. So one thing is this experiment that we did in this weekend. Ordinarily, we usually gather for a physical CME and workshops and postgraduate courses, conferences, etc. I'm request to at least all alumni and all the colleges running MCS program endocrine surgery to think of should we just have at least every quarter year, every 3 months, maybe one of the institutions take a lead and not to strain any self, everybody for doing this program, is just get out your archive cases or get out or take out all your cases you have discussed in the joint meeting with pathologists or in radiology systems, and just a little bit add current data and make it ready for such kind of weekend session, maybe in day, if not 2.5 days. So that gives insights to two things. One is we're exposing our resident to number of faculty more, and we're making our resident also to learn about some cases which are very rare, not seen so frequently like the last case today. Many residents will finish their 3 years of MCH, still they cannot see a case like that. There are several other cases we have been discussing throughout the day today. We know that endocrine diseases, especially MEN, some rare tumors, etc., are very, very rare. That we discussed today, like the primary hyperplasia, the adrenal Cushing's, all these things are very rare. So in our specialty, I think such kind of collaborative exercise, sharing each other's clinical material, immense help for our resident to gather this knowledge and experience. Besides, of course, all the faculty members get the opportunity to put their mind in some mind-boggling questions coming from the residents. The last thing I want to say that this initiative, again, I repeat what I did in earlier, starting the exercise, this is done by the residents and being managed by the residents and for the residents. Let me put it that way. If that is the spirit, I request residents from other institutions also to think in same line and just preserve your cases you are discussing with joint meetings, or you are preparing your cases for presentation or your own clinical material, own department, and just request one faculty member to guide you, and you can also have similar kind of session. So with that little comment, I request all of you just see that tomorrow if you are free in the evening, we have 2 lectures. We have Foundation Day tomorrow evening, and we have 31st Foundation Day. We are split into 2 parts. The first part is the Foundation Day, that is a social event here that the alumni are requested to participate. But the second part is very good academical exercise. 2 eminent endocrine surgeons, one from the country, Professor Arvind Nair. We all know about him, and he's speaking as on Foundation Day orator. And the second thing is Professor Quan Du from University of California, San Francisco. He is delivering a Silver Jubilee address tomorrow. So the times are starting from 6 o'clock to 7 p.m., 6 p.m. to 7 p.m. We are purposefully make it a little delayed to make San Francisco time to be comfortable for Professor Du in the morning. So I hope all the alumni and all the eminent faculty interested in endocrine surgery in the country, now all this encourage your student also to join in and listen to these 2 eminent endocrine surgeons of our times. Thank you very much again for your kind participation and encouraging your resident also to join and sparing time to share some of the interesting cases from your side. Okay, so we'll make a sign die. Okay. Just want to one thing. I just want to thank the telemedicine team here who are helping us, and of course the residents who are took part in this. We have sort of residents still you could all manage. Thank you very much for them. Sorry, I just forgot to mention.
Thank you, sir. Great to see you again, and see all the faculty.
Thank you, everybody. We will wait for all of you to join tomorrow. Thank you for your participation.
Thank you, Malika.
Thank you, everybody. Thank you. Great meeting. Very nice.
Thank you.
See you tomorrow.
Right. Yeah.
Yeah.